খুব ইম্পর্টেন্ট, তা নাহলে মিটিং টাইমে শেষ করা যাবে না। সব চেয়ারপারসনদের রিকোয়েস্ট করবে আর স্পিকারদের রিকোয়েস্ট করবে।
একদম স্যার।
Hi Singh ji, Anil ji.
Hello sir.
Namaskar sir, namaskar.
Namaste sir.
Hey, who is on Redmi? Can you introduce yourself? We can't see you. Redmi with the green curtain and AC on the top. Yeah. No. Who is this? The lady with the mask?
Hema sir.
Hema, yeah, Hema, please. Nice to meet you here. Amitabh, welcome.
Good afternoon.
Good afternoon.
Hema.
হ্যাঁ, চলে যাচ্ছি।
দুর্যোগটি এসছে দেখছি।
Dr. Sinha, welcome. Looking very smart. Rujjotida.
Sir,
Mute karo,
his
unmute.
video, sir, unmute your video, sir. Unmute.
Mine. Okay.
Yes, sir. Yes, sir.
Yes, sir.
যদি খবর
Good
ভালো
afternoon.
কি খবর আপনার ভালো আছেন?
আমার RDNA প্রেসারে ব্লাড প্রেসার হচ্ছে 120/80।
The time schedule. So I hope that this program will help us all to enrich our knowledge for the clinical practice. So finally, I declare this scientific program as open, and thank you all once again, and hand over to the chairman of the scientific committee. Dr. Shah and Dr. Prakash Hajra, please take the charge.
Prakash, you say
I
something.
think before Jayanto Shah takes over the whole scientific program 2020 on behalf of all the seniors and all the hardworking people, medical fraternity and the health workers, I congratulate you for the tremendous work you are already doing. This time we could not meet physically, but I'm sure Dr. Jayanto Shah has formulated a nice program with the guidance of all the seniors, Dr. M.K. Das, Manoranjan Mandal, Parthuda, P.K. Dev, Dr. Bishas, and I thank everybody, and Dr. Sinha is also here. I could see many more faces are coming gradually, but I'm sure the program you like. Only two housekeeping I want to mention here. Since we are doing it on virtually, I would request everybody to unmute yourself if you're not talking. If you want to talk, you can mute and unmute according to the need. Please keep your background a decent one, and your iPhone or in your mobile phone in the switch off mode, sorry, in the vibration mode. And I wish it will help the speakers to get attention, and the audience will be able to hear and interact properly. If you have any questions, you can always interact in the chat box, and I'll request all the speakers to finish in time. If you cannot finish in time, you actually you cannot buy time in the market, and you are actually stealing time of the next speaker. With that note, I'll be on the background, and Dr. Saha, myself, maybe we become rude a little bit when you cannot maintain the time. You have to excuse us because it is basically a timeline everybody wants to maintain. And with that note, I will hand over the session to Dr. Jayanta Saha. And Dr. Jayanta Saha, please take over.
Thank you, everybody, all my seniors and my colleagues. They have given me a lot of responsibilities. I'll try to carry out that. So let us go straightway to the program. I'm handing over the mic to Dr. Arudas Vishwas, Dr. Amitavo to start the program, because already it's 4.
Thank you, Dr. Saha. I thank the organizers for giving me the opportunity to session this chair. And in this first 40-minute session dedicated to hemodynamics and oximetry, my co-chair will be Dr. P.S. Banerjee, who needs no introduction. He is the present President CSI of the West Bengal. And Dr. D.P. Sinha, Professor retired from SSKM Hospital, an acute clinician and interventional cardiologist. Has Dr. Bishwajit Bandyopadhyay? Okay. We also have Dr. Amitavo Chattopadhyay as chairperson, who is the senior pediatric cardiologist of NH Sanjeevani in Howrah. I know him for a long time to be a very good intervention and clinical cardiologist. So,
Arudha, I'm here.
Okay, Bishwajit.
Yes, he has joined.
Bishwajit, all of you know a very senior pediatric cardiologist. In fact, he is leading the show of pediatric cardiology here and also in RN Tagore. So I think Bishwajit can introduce Dr. Anil Singhi.
Anil has joined a few years back. He is he has done his training from Madras Medical Mission under Dr. Shivakumar. He has been to Australia, and he is very logical periodic cardiac interventionist, and I wish him all the best in life.
And we also have moderator Jayanta Saha himself and Dr. Siddhartha Mani. Siddhartha Mani has joined.
You can start the program.
Okay, we'll be definitely. So Dr. Singhi, Anil, can you hear us?
Anil.
Hello. Am I audible, sir?
Yes.
Yeah, Anil, you are audible. Please carry on.
Anil, you can start. We have, very little time, so you can start and go ahead to straight to the topic.
Thank you, sir. It's my pleasure to be with all of you, and thank you to CSI West Bengal to give me the opportunity.
Sharing, sir.
Is my screen visible, sir?
Yes, go ahead.
Okay, thank you, sir.
Thank you, sir.
Yeah. So the topic given by the team is very interesting and challenging. Is catheterization generated hemodynamic data is necessary in 2020, and I wish to pay my regards to four generation of great hemodynamic clinical cardiologist, Professor Alexander Nadas, Raj Tandon, Krishna Kumar, and Dr. Shivakumar. They are all linked in Guru-Shishya relationship. So if we see from the early 90s to 2020, the phone has had a huge leap from the wired phone to smartphone. So we were wondering whether the same thing will happen or going to happen in the hemodynamic from pressure trace to MRI generated high profile data. When we talk about cardiac catheterization, our objectives are threefold: doing the hemodynamics, taking the oximetry, and doing the angiography. In terms of angiography, the cardiac catheterization has been dented by CT and MRI. CT angiogram is pretty good for the vascular anatomy delineation, and MRI, in addition to the angiography, also has data for QPQS assessment and to some extent calculated PVRI, where a lot of work has come from Greater Ormond Street and Guy's Hospital, and they told it can help to get some lead over it. But when it comes to hemodynamic and oximetry data, we need to see where we stand. So the data are usually twofold: absolute data and the calculated data. All the data what we discuss are the pressure data which are absolute, like systolic, diastolic pressures, mean pressure, the end diastolic pressure, especially LVEDP, RVEDP, and wedge pressure. They can be only taken by placing directly the catheter inside the chamber. The saturation from different chambers are also direct, which help us to understand the shunt lesions and QPQS. The calculation data are like cardiac output and PVRI, which has some limitation, but they are also immensely helpful. When we discuss the importance of hemodynamic pressure tracing, it is extremely important to get the real trace and real-time analyze with the respiratory variation. There are two examples I have quoted here. Everybody knows the pulmonary artery pressure above and wedge pressure below. When we put an automated mean, it will give some number, but we know the pressure to be measured ideally in end of expiration. The mean pressure in the wedge is coming 4, but when we calculate the same in end expiration, it will show 10. So machine cannot replace the calculation and analysis of a cardiologist seeing and pressure tracing. So same thing, end diastolic pressure exactly matching in the QRS, which is the accurate assessment, which is very useful in analyzing the cardiac condition. This is another pattern of trace where high PA systolic and deep diastolic pressure, which indicates severe PR in pulmonary hypertension like AR. So we can see this trace is very, very unique for these circumstances. This is one classical example of coarctation of aorta. We can see the proximal and distal pressure and this radiofemoral delay. We can assess how much it is significant. Another example where we are seeing left ventricle to aorta simultaneous tracing showing significant pressure trace gradient. The interesting part, when we pulled back from in this given patient, the tracing, aortic tracing itself reduced, showing the obstruction is somewhere in the supra valvular aorta rather than in the valve, and the gradient is significant. So this type of location of the gradient can also be told by the tracing. This we all have seen before doing a balloon to know that which rate, if we pace the heart, the balloon will be more stable, and that a good trace can tell us. This is, I think, in all great teachers have told in our cath lab days that post-ectopic potentiations in TOF with VHD and in obstructive lesion like AS. So we can see the post-ectopic potentiation seen in aortic stenosis with intact septum, but not in tetralogy. So this is having great understanding hemodynamics. The very, very important confusing state like constrictive pericarditis versus restrictive cardiomyopathy. Again, we get a characteristic deep and plateau pattern, and in real patient, it helped us to understand this is a patient where the confusing data, we got a almost nearly equal LVEDP and RVEDP in 5 millimeter difference, which helped us to understand that this is a case of constrictive pericarditis. So this is dynamic assessment where aorta, pulmonary artery, both pressure trace. The trace began to separate out as it was closed by a balloon in a pulmonary patent ductus arteriosus. So balloon occlusion test showing the reduction of the PA pressure is very important again, and that only can be achieved by a good hemodynamic assessment. This is again a dynamic assessment where an occlusion hemodynamic and pressure tracing before and after ASD device closure, we can assess and see the apparently looking 12 LVEDP has gone up to 26 with significant symptom, and again proving the point. Oxygen saturation, when we see the difference of the saturation between different chambers at atrial level 7 to great vessel level 5, if we can document, still these oximetry data on table tell us that it is a significant shunt and help us to understand the calculate quickly the QPQS. So operability in the shunt lesion depends on clinical evaluation, non-invasive investigation, and cath. The PVRI data still is included in the ESC guideline where more than 3 wood unit is showing high pressure, and PVR SVR ratio more than 7.5 not good. Vasoreactive testing again can only be done in cath lab by putting the vasoreactive drug, which is important in management of the PH patients. So 3 quick examples I'll show. As a 10-year-old VHD patient showing cardiomegaly with increased QP, overall biventricular forces, and there was LVS3. So clinically the child was operable, but we found in echocardiogram large VHD bidirectional shunt with severe PH. In the cath, we found near systemic PA pressure where oxygen caused some reduction in the diastolic as well as mean pressure. So the question was whether he was suitable for VHD closure or whether we are going to help the patient. In the Q and QPQS calculation, the QPQS from 1.34 increased to 2.14 with oxygen, and PVRI mildly came down from 11.8 to 7.5. So we discussed with family, explained, and the patient with higher risk taken for fenestrated VHD closure and PD ligation. In post, the patient underwent surgery and did initially well. PA pressure came down to up to half systemic, extubated day 2 and discharged on sildenafil. And this is the X-ray I am showing 1 year after surgery. This is the before surgery, so we can definitely see that we have made some change, which is positive. And when we assess the recath, the PA pressure is almost half systemic, and the PVRI has come down nearly to the post-oxygen level, and that is the advantage of having a good hemodynamic study. Quickly to tell, 46 years old lady having significant effort intolerance came as an ASD patient. You can see dilated PA and right axis with RBB pattern. T showed 36 millimeter ASD with bidirectional shunt and some RBOT turbulence with RV dysfunction. The RA mean pressure was 16, which was elevated, and PA pressure was 60 of systolic with a mean of 30. We occluded with a balloon 33 millimeter equalizer, and LVEDP increased up to 40, significantly coughing patient. You can see the significantly elevated LVEDP. So QPQS was 1.5, though PVRI was less, but in view of LV dysfunction and lung disease, we decided to keep the patient on follow-up and not to close. And that's how this whole hemodynamic trace and analysis help us to come to a conclusion. And third patient was an adolescent girl, large duct with PH. We can see dilated PA with increased QP. There was LV forces. So 10 millimeter duct, and there was brisk pulmonary venous return we can see in the 4-chamber view. This is a very large PDA we can access here. So basal hemodynamics showed near systemic pulmonary artery pressure marching with aortic pressure. We took a 16 millimeter amperage VHD device and occluded the same, and there was no residual. So the PA pressure came down to 40% systemic on device occlusion. So we were happy and released it. 3 years down the line, the PA pressure is now 40 and patient is doing extremely well. So cardiac catheterization hemodynamic data, where we stand, is a gold standard for pulmonary hemodynamic and diagnosis of pH and operability decision to monitor the therapy and confer prognostic value. So it enormously helps us in clinical decision making. In univentricular heart, it helps us for operability decision. Gray zone, as we discussed, constrictive pericarditis versus restrictive cardiomyopathy. Also, it is a criteria to do a cath pre-post transplant to understand hemodynamics. And in safe hand, risk of cardiac cath is very low. So it is proven beyond point that cardiac catheterization generated data is a value addition in the diagnosis and management, and wish to add that cath is remain forever like lust for gold from ancient time to now, and that make up what was there earlier. You can see in 2020 BC, a prominent carving in Indian temples in medieval time, and today also it is similarly popular. So cath is going forever. Thank you, sir, for your patient hearing.
Thank you, Dr. Singh, for sticking to time. We'll be take up the discussion part at the end of the two speakers have spoken. Now, Amitabh, can you invite the next speaker, Dr. Sanjeevan Ghosh?
Yes, sir.
Amitabh is there?
Yeah, hello.
Yes, sir. Yeah.
Yeah.
So Dr. Sanjeevan is the next speaker, and he is a colleague of mine, a very young and energetic pediatric cardiologist. Himself and Dr. Aritra Mukherjee both have created a set of about 6 questions for our young and budding cardiologists, just to answer them, and is known as a fellow session. And I would invite him just to take up the next session.
Hello, am I audible?
Yeah, you are audible.
Yeah,
And,
yes.
please take care of the time, okay?
Yeah, sir. I'll try my best. So you can see my slides also, right? Good evening, everyone. I would like to say thanks to the organizer for giving us the opportunity. Myself, Dr. Sanjeevan Ghosh, pediatric cardiologist at Narayana Super Speciality Hospital, and I have my colleague Aritra Mukherjee. He is from Medica Super Speciality Hospital, Kolkata. The topic that we are going to cover is hemodynamics and oximetric data analysis in congenital heart disease. This session is mainly meant for the DM cardiology fellows. Here we have kept few real-life case scenarios, and we have kept few questions from each the case scenario. As we have decided before, we have divided all the DM fellows in 6 different groups so that each group can answer one question scenario. Just to remind you, this is not a quiz competition, this is not an exam or viva anything. This is just a formal discussion. At the end of each question, we shall discuss the correct answer, and we shall also discuss how to approach the problem. In the previous talk, Dr. Anil Singh has beautifully described the importance of hemodynamics in congenital heart disease. This is not only important in congenital heart disease, but also in structural heart diseases. How the hemodynamic understanding is important in congenital heart disease, we shall see in the next few slides. So, the first case scenario, this is pediatrics from the National Medical College Cancer. Yeah, Dr. Rajiv and Dr. Rajesh, are you there? So the question is, this is a oximetry data. As you can see, we have given the pressure of each chamber and the saturation. So go through the data. We have given the pressure of RA, RV, PA, pulmonary artery, LA, LV and aorta, and the saturation of each chamber. Hello. Else you can put your answer in the chat box also. PDTs from National Medical College, Dr. Rajiv and Dr. Rajesh. So my first question is, which group of congenital heart disease is this?
Sanjeevan,
Yeah, sir.
I think you can allow them to interact in the chat box. Otherwise, it will take a lot of time. You cannot finish in
Yeah,
time.
yeah, sir. Yeah, sir.
We are already
No, they
running
can
short
put in
of
the
time.
chat box also.
Yeah.
Any one of you can answer in the chat box. Which group of congenital heart disease? So how to classify it? Like we usually divide in cyanotic and acyanotic heart disease. In the acyanotic group, we have shunt lesion, obstructive lesion, and regurgitant lesion, the myocardial disease. In the congenital cyanotic heart disease, we have increased pulmonary blood flow group and decreased pulmonary blood flow group. That also can be subclassified in TOF physiology, fellow physiology, or a TGA physiology, or a admixture physiology. In the chat box, any one of you can put your answer. Which physiology is this? Is there any response? I can't see.
There is no response. You go ahead.
Okay, sure. So as you can see, how to approach this kind of problem? First, you look into the saturation in the aorta. So if the aortic saturation is less than 92 or 94%, you are dealing something with a congenital cyanotic heart disease, because here it is 88%. So this is a cyanotic heart disease. Next, look into the PA pressure. The PA pressure is high. So this is a cyanotic heart disease with unrestricted pulmonary blood flow. Next, you look at the PA saturation. If the aortic saturation is more than the PA saturation, that means you are dealing with a fellow physiology, where aorta is getting blood from the LV. If the PA saturation is above the aortic saturation, then you are dealing with a transposition physiology, where the PA is facing the LV. And if these two saturations are same, this is admixture physiology. Here you can see the aorta and the PA are same. So this is a cyanotic heart disease with increased pulmonary blood flow, admixture physiology. For admixture physiology, you can have mixing at the 3 level. Either it can be at the level of atria, where the examples are like a TAPVC or a tricuspid atresia, where the saturation in LV and RV will be same, because mixture is happening at the level of atria. The mixing chamber can be the ventricle, like a DILV, and the mixing chamber can be a great vessel, like a truncus. So in this particular case, you can see the RV saturation is 74 and the LV saturation is 96%. So till the level of the ventricle, there is no mixing. So the mixing is happening at the level of the great vessel. So this is an example of truncus arteriosus. So definitely echocardiography is the gold standard to define the anatomy. But looking into the cath data also, without knowing the diagnosis, you can approach like this. So this is an example of truncus arteriosus. Is the baby operable? Any response? Okay, so if I proceed, there is a beautiful paper published in Cardiology in the Young, where almost 30 patients they have shown is the saturation, Rumeier's saturation, baseline saturation is more than 87%, almost always indicates operability. So Rumeier's saturation, anything more than 87 or above is operable. So here you can see the Rumeier's saturation is 88%. So this child is probably operable. Again, from the history also, you can see 2-year-old male recurrent respiratory tract infection, which indicates increased pulmonary blood flow. So still the PVR is low and there is increased pulmonary blood flow. That's why this patient is probably operable. So all these questions we can answer from this oximetry data. Shall I proceed to the next question, sir?
Yeah, please proceed.
Yeah. So next question. This is again a real life case scenario. A 9-month-old child with history of poor weight gain and recurrent respiratory tract infection. The Rumeier's saturation was 68%. And the echocardiography showed TGA with large VSD, where the shunt is bidirectional. So at this point of time, what is your concern regarding doing an arterial switch operation with a VSD closer? Is this the coronary artery anatomy? Is this whether the LV is still prepared or not, because this is already a 9-month-old child? Whether the patient has already developed pulmonary vascular obstructive disease, or whether your concern is whether all the things are your concern. Actually, this question was meant for fellows from RG Corp, Dr. Manishankar and Dr. Leena. Any one of you? Are you there? Or else you can put in the chat box also.
So go ahead.
Give 30 seconds time and go ahead.
Yeah, sure. So 9-month-old in presence of a large VSD, question of LV regression will never come because the PA pressure will never fall. There will be pulmonary arterial hypertension and that will keep the LV viable. Again, for doing an arterial switch operation, none of the coronary artery anatomy are contraindication. Like even if it is an intramural coronary artery, still we can go ahead with a arterial switch operation. So these two are definitely not the concern. Development of PVOD. If we go by the natural history of TGA with VSD, the mean survival is around 19 months, and TGA VSD gets complicated by early development of PVOD as early as 2 months. And 50% of them will have PVOD by 6 months, and 90% of the survival patients will develop PVOD by 1 year. So as this is a patient with 9 months age, definitely development of PVOD is a concern. So my slides are not moving. Okay, so my questions were, natural history I already told, how to assess the operability in a TGA VSD. It's a very difficult question, how to assess. For a simple VSD, we have lots of data like clinical signs and symptoms, ECG, chest X-ray, and as Dr. Anil Singh has already mentioned, cardiac catheterization. But for a TGA VSD, it's difficult. If the patient is symptomatic, like features of increased pulmonary blood flow symptoms are there, definitely the patient will be operable. If the chest X-ray show plethora, if the Rumia saturation is on the higher side, like in 80s, the patient will be operable. But if the operability is borderline, doing a cardiac catheterization, doing an oximetry study is very, very difficult because we cannot apply the fixed principle in a transposition physiology. Again, lot of bronchopulmonary collaterals will be there, which is difficult to take into the account. That's why cardiac catheterization is never reliable. What we can do, we can administer 48 hours of high flow oxygen to the patient, and we can assess whether pulmonary venous return has gone up or not. As you can see here, this was the baseline echocardiography of the patient. This is the 4-chamber view. You can see this is the LA, pulmonary venous return was not that high. You can see the interstitial was bowing towards the LA, and PFO was totally bidirectional. After giving 48 hours of oxygen, you can appreciate the pulmonary venous return has gone up. There is significant mitral inflow gradient. There is mitral regurgitation also. And you can see now the interatrial septum has bowed towards the RA. So definitely there is increased pulmonary blood flow. So which indicates there is still the PV, there is not much the PVOD, whatever pulmonary vascular resistance is there, that has come down after giving oxygen. So this patient is still operable. Okay, so moving to the next case scenario. So another case scenario. So here you can see a few pressure tracing. In the left hand side here you can see this is the RV pressure tracing, which is showing a RV systolic pressure of almost like 200. And this side you can see there is RV and aorta simultaneous pressure recording. So here you can see the RV pressure is almost like 200 and aortic pressure is lesser than that. So what are the possibilities? Anyone, you can post your response in the chat box. Actually, this question was meant for Dr. Nasim and Dr. Shravan from CMC, Kolkata Medical College. Are you there? So I shall continue.
You can expedite yourself, otherwise you won't be able to finish in time. How many problems do you have?
Only 6, sir. Only 6.
Okay, so you are going for the third. Fine.
Yeah. So this here you can see this is a suprasystemic RV pressure. So what are the conditions can have a suprasystemic RV pressure? First condition will be pulmonary stenosis with intact ventricular septum. So pulmonary stenosis with interventricular septum can have a suprasystemic, severe pulmonary stenosis can have a suprasystemic RV. Next, if it is a severe pulmonary arterial hypertension, like idiopathic PH without any VSG or without any PDA, will have a suprasystemic RV pressure. And third is a Hoffman variety of TOF, where the tetralogy of Fallot with a restricted VSG. So RV is not having any egress, like the RVOT is obstructed and the ventricular septal defect is also restricted. That particular condition is a surgical emergency, and that patient can have a suprasystemic RV pressure. So probably these three conditions can have a suprasystemic RV pressure. So I would like to request Dr. Aritra to continue the other three problems. Dr. Aritra, can you please continue this? I can show you the slide. Are you there?
Introduce Aritra before you leave.
Yeah. Dr. Aritra is a consultant pediatric cardiologist from Medica Super Specialty Hospital, and we have prepared the slides together. So Dr. Aritra can continue.
Aritra, please come in and step in quickly.
Yeah. Sanjeevan, next slide, please. Yeah, actually these scenarios were meant for fellows to interact. Unfortunately, I don't think we have too many of our residents here at this point in the participant group. Anyways, I'll breeze through the remaining three questions. So this is a clear-cut scenario where we find this was meant to bring to the notice of the residents that the importance of looking into the ECG when interpreting a hemodynamic tracing. So if I'll jump, since there are not much of response and not many fellows, I think, waiting in our ranks in the participant group, I'll jump to the what we are seeing here. This is a simultaneous LV and brachial artery pressure tracing, and here we can clearly see in the initial segment the patient was having a nodal rhythm, junctional rhythm, and it then and that time the gradient in the between the to ventricle and the brachial artery was much more, and the gradient came down suddenly. And this happened once the rhythm became sinus. This is an example of some sort of a HOCM-like scenario, hypertrophic cardiomyopathy, because once the preload came up with when the rhythm became sinus, this gradient came down. So this is we kept just to once again impress the importance of looking into the ECG while interpreting any sort of hemodynamic tracing. So Sanjeevan, show me the next slide. Yeah, this is an interesting, very nice, interesting. It would have been fantastic if some of the residents could have interacted in this. This is a 2-year-old child, and we are showing some sort of a pullback tracing. Obviously, it has started in a chamber. We have a catheter which has started in one chamber, which is some sort of a ventricular tracing. We can see that we have a scale of 20 here. So roughly a ventricle, we're having a pressure of around 120, and it is ending in another, probably looking like some sort of another ventricle, which has a pressure of nearly half, maybe around 60. So, and in between we are finding some, I don't see any responses. So I'll just breeze through the explanation of this chart. So what we are finding here is one from the catheter is started from one ventricle, has gone through some great arteries. Obviously, this is a pulsatile great artery tracing, and there are two forms of great artery tracings, and then we are ending in another ventricle. So obviously, the higher pressure ventricle most likely would be LV. So this possibly is an LV to aorta pullback, and there is another great artery tracing. So how to enter from and that has to be possibly PA. So how to enter from LV to aorta and then to PA, possibly through either an AP window or a PDA, and then to RV. So this is the catheter course in this patient, and then the complete diagnosis would be possibly and obviously there is some gradient between the aorta and the LV, which is roughly to the estimate of around 30-35. So there is mild aortic stenosis and obviously a large PDA. Why do we say or a large AP window? Why do we say large? Because the systolic PA pressures are quite high and there is diastolic pressure equalization. And finally, the fate of this child, obviously this mild age does not need anything, but this needs closure. So this needs closure. How can we tell that? How can we say that this is not this is already not, this is a 2-year-old child? Large PDA or a large AP window can become inoperable by this time. But in this case, we can see that there is significant wide pulse pressure. So even with an AS where there will be systolic decapitation, it is still having a wide pulse, 80/40. So definitely this is an operable kit. So just from one single hemodynamic tracing, we can get so much of information if we look very carefully. This was the message to the residents. Come on, Sanjeevan, to the last slide, last scenario. I don't think there are any chat response, right?
No, nothing. Yeah.
Okay.
You can go ahead.
Yeah, so this is the last scenario. This was a 6-year-old child, large VSD, large ASD with a severe PH. We can see the X-ray. X-ray is showing some cardiomegaly, still some plethora is there, mild degree of pruning is there. Next slide. So, and this is a real life scenario. All of them a couple of, except one or two are actual real life scenarios, both for Sanjeevan and whatever I am showing. So this is how we, so this patient obviously needed a oximetry cath to look for operability. So these are the pressure data, and we see in the room air and 100% oxygen and the saturation and PO2 data. Sanjeevan, next slide, please. Next. Yeah, next, all the questions. Yeah, so no, go back. Yeah, so basically what we wanted to highlight here is that what is the opinion regarding operability. So we have given room air QPQS and 100% oxygen QPQS and PVRI. So based on PVRI, the general rule of thumb at this point, I think Dr. Singhi also touched upon this point in his presentation. So as of now, the 8 to anything beyond 8, we will be very, very careful in offering surgery to that child. So something between 8 to 6 is mixed with caution, and anything below 6 is clearly operable as per the latest guidelines. So this child has a PVRI of 7.8, and post oxygen also it is high. So at this point we might be a little bit doubtful, but are these two parameters enough? No, probably not, because we need to also calculate the resistance ratio, that is PVRI SVRI ratio, because that ratio does not depend on the VO2. VO2 is a highly variable thing, and we often do not calculate the VO2. We take it from a chart. So resistance ratio is a far more reliable indicator than PVRI in terms of deciding operability. Also, there is a great big fallacy in this data, because whenever we do 100% oxygenation, we need to ensure that whether the patient is actually 100% oxygenated or not. In this case, as you can see, the pulmonary venous saturation, we could measure the direct pulmonary venous saturation in this, because this child had a large AST. We can see the PO2 is only 155. Saturation will only go up to 99, 99.5, but the PO2 can go up to 500, 600. So this PO2 value, unless the patient is properly oxygenated, it will be in the range of 500. So unless your 100% oxygen data is showing a PO2 value, pulmonary venous PO2 value of around 500 or 400, your patient is not properly oxygenated, and hence your 100% oxygen data is not correct. So this is one. So probably if you would have oxygenated properly, the PVRI would have come down even more, and we would have been able to clearly delineate that the child is operable. Next slide. So these are some of the important tips that anyone should keep in mind while going for oximetry caths, in particularly left to right shunt. One should avoid major fluctuations in basal state. Either you go for intubation, that depends on institutional protocol, but there should not be major hemodynamic alterations. Simultaneous pressure recordings are always better to keep two. Zeroing is very essential. These are very, very proper sample collection from proper place with proper technique. I don't want to go through this because these are mostly for residents, and I don't think that we have too many residents here, but these are some of the points we need to. Dissolved oxygen should always be taken into consideration, particularly when we are looking for oxygen data. Not you may miss it in the basal data, but in the oxygen data you also always have to calculate the dissolved oxygen. So, and whenever you are assuming pulmonary venous saturation, you are not having a PFO or an ASD, then also you must take into account the patient's condition. Supposedly the patient has recently recovered from pneumonia, and the basal pulmonary venous oxygen saturation is 97%. You cannot take it as 100, because when you take it as 100, your patient will become falsely inoperable. So these are some of the things all of us should be very, very careful while doing oximetric caths. So the last slide. So the main message that we wanted to give all the residents, whoever is watching this presentation, is that hemodynamics and oximetry in congenital heart disease do not necessarily begin and end in the cath lab. This is also true for any other heart disease as such, but more so for congenital heart disease, because many of the scenarios like Sanjeevan presented in the initial first couple of scenarios where we cannot do a proper oximetry analysis at all. Cyanotic congenital heart disease, there we have to depend a lot on history, basal saturation, oxygen saturation after oxygenation. So some of the things we have to take everything in concern, even for left to right shunts. Whenever we are going through our oxygen study and we are finding some numbers, we have to always look at these numbers in terms of the clinical
can you
data.
please conclude?
Yes. So this is the final slide. We end here.
Thank you very much, both Sanjeevan and Aritra, for nicely pointing out that oximetry and hemodynamic study through invasive method are still needed. So if we look into the talks of Dr. Singhi, Dr. Ghosh, and Dr. Aritra, we find that hemodynamic oximetry data by catheterization is still important, though the non-invasive methods are growing and have grown up to a large extent. And also it is not only in the congenital field. If we look into the adult cardiology, valvular heart disease, particularly with the different types of interventions we are having in coronary artery, different types of intervention and assessment, particularly the intermediate lesions, we have the role of invasive catheter estimation of the hemodynamics. Now, I would invite Dr. Saha and Dr. Mani to make their comments, and if the other chairpersons have to make any comment.
I have a comment, Arudha.
Yes.
Dr. Biswajit here.
Yeah.
The cases
switch over the screen. I mean, stop slide sharing so that we can...
it's all right. It's all right. I will just give you the message. This older children with very large left to right shunt, when you operate, then this severe PH patients tend to have this severe PH, in some cases very long lasting. So these patients sometimes have sudden cardiac death. So they need to be on pulmonary vascular dilators like sildenafil or bosentan for a very, very long time. But still then, even if you prescribe these medications, these patients cannot guarantee that, you cannot guarantee to the family that this patient is going to get cured. One. Second is, Anil presented one large ASD in a older individual. I would like to share my own experience with 22 millimeters ASD in a 65-year-old lady who had a COPD, who had an atrial fibrillation, and she had atrial. She was a doctor. She was my teacher, and this lady, we closed the ASD and under just light sedation. After that, once we closed the ASD, this was Sunday morning, and then she developed quite significant respiratory distress. We intubated her, and then when this patient gradually over 1 or 2 days developed severe pulmonary edema, so we had to go back to the cath lab and take out the device with a very innovative technique of loop to loop. Venous to venous loop. Amita was there with me, and once we took the device out, and then we could extubate the lady, and she was on tracheostomy, and she had a very tough time, but we were able to discharge this lady. So it was a very difficult scenario. So in any adult patient, even if it is a small ASD, before just seeing the rims, assess that whether this patient will be happy with
Yeah,
an
basically,
LT program or not.
it is nice to warn, particularly the juniors have received a good message
Absolutely.
from yourself.
And another technique which I follow is that
we are running short of time. Please wind up quickly.
one second only. These patients should have a pigtail catheter into the LV for continuous monitoring of the LVEDP.
Yeah, this was a memorable case, Vishwit. We remember.
Yeah.
This was a very memorable case for us. I think. Thank you for sharing your nice experience.
Yes.
Maybe in the dearth of time, and I can introduce the next speaker. Dr.
I
Patnavata
think
can
you should
introduce the
present it
next
as a
speaker.
problem case in wherever the situation faces. At least 15 minutes will take to take the whole discussion. I am also aware of the situation.
Very memorable case for us, sir.
Yes.
It took place on a Sunday
Dr.
afternoon.
Saha, can you go to this next session?
So the next session.
So I'll be taking leave. Thank you very much.
Now, before that, I think you deserve a note of thanks from our side, not only as a chairperson, but also our president, and also other participants in this discussion. And only thing that we could not have active participation from the fellows. So next time probably we'll have it. Thank you, Parthoda.
Thank you very much. So I think we switch over to Dr. Saha.
Our next session is hemodynamic and oximetric data in daily clinical practice, and that will be said by Dr. Satyendranath Datta, pre-transplant hemodynamic assessment in patients with ventricular systolic dysfunction. And the moderator Shoroda is absent. Arindam Basu is there.
I'm present.
Yes.
No, Solo is there. Solo is there.
Sorry.
Very
nice to see you.
Dr. Guha has joined? I don't think. Dr. Das Vishwas is here. Dr. Minal Kanti Das is here. And Dr. Mitro. So let us start.
Mitra is here. Yeah.
Okay. So good evening, everybody. So just to give you a small information, I am just recovered from COVID infection. I was having a fever about 10 to 12 days. Luckily, I'm fortunate to be in front of you.
Great to have you.
Welcome back.
To waste any time.
Would you start the proceeding?
Hello, Sauro.
If you can just start the proceedings, sir.
Okay, so this is a topic that Dr. Satyan is going to talk about. He presently is an interventional cardiologist at Health World Hospital at Durgapur, and he's going to talk about the pre-transplant assessment of patients with LV dysfunction. And a month back, when I asked him what you are going to talk about, he said, I really don't know because it's a very difficult subject. In any case, I think he has prepared himself properly for this event. And without wasting much time, over to Dr. Datta.
If you can please start.
Good afternoon, everyone. Am I audible?
Yes, you are audible.
Please continue.
Yes,
you are audible and your slides are visible.
Okay. Thank you. So our topic of discussion is pre-transplant hemodynamic assessment in patients with ventricular systolic dysfunction. Before I go to the main topic, I want to say that
Just click your mouse.
Okay. So from the day one, where everything was started in Cape Town, where Christian Barnard started his first human transplant in 3rd December 1967, we have went a lot, and every year around 5,500 transplants are being made worldwide, mostly in Europe and America, and the survival rates have increased over the years, probably because of improvement in immunosuppressive therapy, better assessment of rejection, and better patient selection. The coming to the indications of heart transplant, the ACC/AHA guideline says that refractory cardiogenic shock requiring intra-aortic balloon pump and counterpulsation or LVAD are indications, along with cardiogenic shock needing continuous intravenous inotrope, and a peak VO2 of less than 10 ml per kg during cardiopulmonary stress testing, NOH class 3-4 or recurrent life-threatening VT even after available managements, end-stage congenital heart failure with no evidence of pulmonary hypertension and refractory angina. The ESC guidelines are almost same, only they have mentioned a left ventricular ejection fraction of less than 30%. And the United Network of Organ Sharing Heart Allocation Algorithm have listed suggested a status classification for the patients. The class 1A includes mechanically circulatory patients with mechanical circulatory support for acute hemodynamic decompensation, LVAD or RVAD, which is implanted in the candidates, and they are being valid for 30 days, and total artificial heart, intra-aortic balloon pump or ECMO. The with mechanical circulatory support with objective medical evidence of significant device-related complications, along with continuous mechanical ventilation and continuous infusion of single-dose intravenous inotrope or multiple intravenous inotropes. The main agenda here, whether we should select a patient with who are close to end-stage heart disease and associated non-cardiac organ dysfunction, or a less ill patient whose survival is acceptable with medical therapy and non-transplantable surgical therapies. The problem is that we have a limited supply of organs. The allocation of a donor heart to a patient with a relatively better prognosis would deprive someone who cannot live without a transplanted heart. And thirdly, the cardiac transplant is not a curative treatment. It has its own limitations. So this is a complete evaluation test, and the important part here we are going to discuss is about the cardiac evaluations. Along with ECG, Holter, echocardiogram, we can go for a thallium scan for a better understanding of LVEF. Exercise tested with oxygen to see the functional capacity of the patient. A myocardial biopsy when needed if there is diagnostic dilemma of the etiology of the LV dysfunction. So how do we approach a patient for heart transplant? We address the potential reversible causes and components of heart failure. We evaluate the severity. We tailor our medical therapy to improve symptoms and see if we can manage with medications for at least a few time unless he gets a heart. Assess the risk of deterioration and sudden death, and prioritize for listing. Identify indications, exclude contraindications, and if a transplant is recommended, we continue our management with periodic reevaluation. So when a patient is referred for refractory heart failure, we see for reversible factors, we omit them, we tailor our medical therapy. If the patient is inotrope dependent, we straightaway list for transplant and hold the time with mechanical circulatory devices or spice. And if the patient is not, cardiopulmonary stress testing and other heart failure risk stratification algorithms. If the patient is not ambulatory, we again reassess the patient and shift him for a transplant candidate. So if the patient is ambulatory, we perform a cardiopulmonary exercise testing, and we measure his VO2. We calculate his Seattle heart failure model survival status. We calculate heart failure survival score, and if his VO2 is less than 10, his survival for the 1 year is less than 80%, and heart failure status is medium to high risk, we straightaway list him for transplant. If his VO2 is more than 14, if his survival is more than 90% for 1 year, or is a low risk case, we defer listing and continue our medical management. In a gray zone, it's an individualized procedure. We reassess the patient, we look for correctable causes and defer listing. So Cardiopulmonary stress testing is a standard test with EKG testing and patient in a treadmill or a bicycle, and we calculate his peak oxygen consumption volume. According to ICLT guidelines, if a patient has maximal cardiopulmonary exercise test, which is defined as a respiratory exchange ratio of more than 1.05, if the patient is intolerant to beta blocker, the cutoff point is less than equal to 14 ml per kg per minute, and it should guide us to list the patient for transplant. If the patient is on beta blocker, a cutoff point of oxygen consumption is taken as less than 12 mm per kg per minute. And this is a heart failure survival score. There are some clinical characteristics and coefficients. The ischemic is a patient with ischemic cardiopathy gets a value of 1. And these parameters are multiplied with their respective coefficients, and the sum is taken for heart failure survival score. If the score is greater than equal to 8.1, it's a low risk case. Medium is from 7.2 to 8.09, and high risk is less than 7.2. This is a model computerized calculator for Seattle heart failure model calculator. When we enter the clinical medication history and diuretics and other easily done lab data, we get a baseline survival score for each patient. And if the patient can be intervened with medications or devices, we can put them and get a survival score after non-transplant surgery or procedures. So it can guide us whether the patient is has a survival rate less than 80% even after intervention or not. So ICHLT guideline on this prognostication scoring says that cardiopulmonary test.
You have 4 minutes left.
An estimated 1 year survival rate is less than 80%. We go for heart failure survival score. And is a criteria of heart failure survival prognosis score should not be performed individually. It should be performed along with cardiopulmonary exercise testing. So heart failure and pulmonary arterial hypertension, as we all know, irreversible pulmonary arterial hypertension is standardized as a absolute contraindication for transplant. But every patient who has shown a pulmonary hypertension during initial evaluation should undergo periodic testing and reversibility testing before they are being chalked out of the list. So we do a right heart catheterization with a Swan-Ganz catheter. The cardiac output is measured with thermodynamic dilution technique. The PVR, the TPG are calculated, and PHT is defined as a PVR more than 2.5 Woods unit and a transpulmonary gradient of more than 12 millimeter of mercury. Reversibility testing is done if the patient is diagnosed to having a pulmonary arterial hypertension. This is a paper published in European Journal of Heart Failure in 2003. These 150 patients were taken for a heart transplant, and they were initially refused. Then the candidates underwent reversibility testing with prostaglandin E1, and they were achieved a PVR of less than 2.5 and TPG of less than 12 as their guide. Among the 61 patients who showed reversibility, 18 underwent cardiac transplant, and the 1 year mortality rate of those patients were comparable to those who doesn't have any pulmonary hypertension initially. So they concluded that patients with reversible pulmonary arterial hypertension have comparable post-transplant outcomes and no tendency to higher acute right ventricular failure. So what are the important hemodynamic parameters to assess in a patient with PHT before cardiac transplant?
The mic in mute.
The pulmonary arterial hypertension and elevated PVR should be considered as relative contraindications to cardiac transplantation when the PVR is more than 5 Woods unit and index is more than 6 or a TPG exceeds 16 to 20. The pulmonary arterial systolic pressure exceeds more than 60 in conjunction with one of the above mentioned variables, the risk of heart failure and early death is increased. If PVR can be reduced to 2.5 with a vasodilator, but the systolic blood pressure falls below 85, the patient remains at high risk of right heart failure and mortality after cardiac transplantation. And we should also go for a left heart catheterization. Coronary artery anatomy should be delineated. It's a class 1 indication before any transplant. And we should measure the LV EDP to see the LA pressure, which would guide us toward tailoring our medical therapy and improve symptoms. And hopefully we can get a better window period before transplantation. We can get a invasive left ventricular ejection fraction along with our non-invasive methods. So what are the take-home messages? Number one, selection of suitable candidates and proper timing is of utmost importance for a reasonable result. Timely re-evaluation of clinical and hemodynamic status of patients in waiting list. Whenever possible, functional capacity should be tested by CPET, cardiopulmonary exercise testing. Use of multiple parameters like oxygen maximum oxygen peak oxygen volume consumption, heart failure survival score, and Seattle heart failure model scores are recommended. Reversibility testing should be done in presence of PhD. Thank you.
Thank you, Dr. so much. So it was a difficult subject, but I think you have covered it adequately and in appropriate time. So we can take up the questions at the end of the next speaker's study.
So next speaker is our cardiologist, who is a well-known cardiologist, Dr. Sunandan Sikdar from Narayana Hridayalaya, Jessore. He is well-known to our Calcutta community and also West Bengal. So he will be speaking on hemodynamic data for evaluation and management of shock, a really day-to-day affair. Sunandan, please. Dr. Sikdar, are you there? Start slide sharing.
Yes, sir. Yes, it's.
Welcome, Dr. Mitro.
Uploading.
Yes. Karudha,
Yeah.
how are you? Okay.
Okay. I'll call you later on.
Yes.
Sunandan, are you having any problem?
Sunandan sir, kindly unmute. Kindly unmute. I have sent a request. Kindly unmute yourself.
Are my slides visible now?
Yeah, you are visible, not the slides. You have to start slide sharing.
Kindly share it again.
Okay.
Because we have only 12 minutes left for you.
Can you see my slides?
Yeah, we can. Please start speaking.
Yeah. So
kindly change to presentation mode, sir. Thank you.
Okay, so this is a very important topic, and every day we face numerous patients of cardiogenic shock, and most common cause, as we know, is myocardial infarction, and we will be concentrating mostly on that. So what is the hemodynamic criteria to define the cardiogenic shock? Systolic BP of less than 90 for more than 30 minutes, or use of vasopressors to achieve this, or a plus cardiac output which is measured at less than 1.8 liters per minute per meter square. Many of the times it is not possible for us in quickly to measure the cardiac output, but this is an important criteria, and therefore we should try to measure it whenever we have the opportunity. Why is the hemodynamic data important? Because up to 25% of the patient with cardiogenic shock due to left ventricular failure will not present with classic symptoms and may sometimes slide gradually to a hemodynamically irreversible condition. So it is better to pick them early, and hemodynamic data helps us in that object. This is an important marker, lactate, but it is not a hemodynamic marker. But I draw everybody's attention to lactate because we know from data that 61% of patients will survive if the initial lactate level is less than 5. Only 8% will survive if it is more than 10. Though it is a biochemical marker, but it has very close relation to hemodynamics because it is the end result of tissue hypoperfusion. This is one marker, though it is not a hemodynamic marker, but it is the end result of many processes that can be automatically evaluated after we get the ABG of an MI patient. So we will discuss about predominantly at the acute myocardial infarction as a etiologic cause of cardiogenic shock. We know all the causes, myocardial infarction and myocarditis are the two major causes of this scenario. Now, these are the presentations of cardiogenic shock. It can be a catastrophic shock, it can be an acute severe shock, or it can be an indolent progressive shock. Indolent progressive shock are actually those candidates which are going towards a transplant. Acute severe shock are the cases that we receive day in and day out in an emergency or in a hospital. So we will be predominantly dealing with acute severe shock. So these are the intermax profiles for the definition of cardiogenic shock, which are predominantly directed towards those who are going for heart transplant or LVAD. But this we are not usually now dealing with. These are the hemodynamic parameters. We have already known about the hemodynamic parameters from long time. Now, how do you classify shock when a patient of shock comes to you? This is very important because many times a person of an MI will have sepsis. A person of an MI may have hypovolemia. Now, what is the cause of that shock? That can be determined by hemodynamics by looking the cardiac index, the SVR, the RA pressure, pulmonary capillary wedge pressure, and SVO2. So hemodynamics comes in handy when we have to differentiate whether in an MI it is due to hypovolemia or whether it is MI due to the cardiac or the left ventricular dysfunction. So this is a flow chart which usually is utilized in a critical care to look at the shock, any shock, and you look at whether what is the blood pressure, what is the lactate, what is the mixed venous saturation. All these can be utilized to differentiate cardiogenic shock, hypovolemic shock, and septic shock. This is a very important slide. This is the slide showing the different stages. There are, as we see, 5 stages of cardiogenic shock, which was given by SKY consensus in 2019, which came out in Cath Cardiovascular Intervention. And what we are dealing with is the classic cardiogenic shock, and this is the stage C that we usually get in the critical care and emergency, because many of the time patients in the early part of cardiogenic shock are missed because they don't land up in the hospital early. And the persons who are in extremis, that is the stage C extremis, they are not salvageable. So we must concentrate on stage B, C, and D: beginning of cardiogenic shock, classic cardiogenic shock, and deteriorating doom. So how do you use hemodynamic data to choose therapy? We can use a hemodynamic data to differentiate different types like sepsis, ventricular dysfunction, pulmonary embolism, and cardiac tamponade. These are the tracings. The left-hand tracings show a classic tracing of a right ventricular infarct, and right ventricular infarct shows 2 dips in RA pressure trace, that is X descent and Y descent. While on the right, I have a trace of cardiac tamponade where there is paradoxus in the arterial trace. This is an important trace which shows a trace of an acute mitral regurgitation with large V waves in the pulmonary artery pressure curves. This is a trace of a IABP which is in a 2:1 mode, and these tracings are important in daily evaluation of the patients. Coming to the flow chart, we have a patient of cardiogenic shock. The first thing to assess whether he fulfills the criteria of the cardiogenic shock or not. Yes, it fulfills. Then we go immediately to lactate. If the lactate is high, go to step 3. Step 3 always is whether it is an MI or not. If it is an MI, we have to revascularize immediately. While revascularizing, while taking up in the cath lab, we can get a mixed venous value, SVO2 value, that immediately helps us in calculation of cardiac index. So cardiac index by Fick method can be easily calculated by getting the AVG, one from the arterial end, another from the mixed venous saturation. So these are the difficulties or pitfalls of using a Fick method. The main thing is whether the blood is properly mixed and whether there is contamination with air bubbles or heparinase saline. So step 5 is you interpret the data. This is the main step. If the cardiac index is less than 1.8, if it is if the pulmonary capillary wedge or the left ventricular end diastolic pressure is high or more than 15, usually we are in a cardiogenic shock, which is wet shock, and so we have to decide whether PAPI is more than 1 and power output is less than 0.6. These two indices I will come immediately. If they are there, then we go for a hemodynamic support. What is the hemodynamic support usually available? IABP is usually available. Very rare cases we can get an ECMO or an impeller. So these are the different types of hemodynamic support which are available. Mostly we use IABP. What is the importance? Because if there is a low cardiac index with a high pulmonary capillary wedge pressure, the mortality is very high. That is, in the Forrester classification, the mortality comes to around 50% mortality. So that the hemodynamics doesn't end at that point, because it is also important to monitor, and therefore in IABP you have to monitor the pressure tracings and the hemodynamics. So mortality of shock is very high. In a more than 75 years patients, the mortality shock is 75%, but usually it is around 60%. What are the predictors? Predictors are age more than 70, creatinine more than 2, lactate more than 4, and cardiac power output less than 0.6. So this is one of the flowcharts that we have already discussed. Now, what is PAPI? PAPI is a novel index, pulmonary artery pressure, pulmonary pulse pressure divided by right atrial pressure. This is an important new index. PA, pulmonary artery systolic pressure minus pulmonary artery diastolic pressure divided by right atrial pressure, predicts mortality in inferior valve MI, in RV failure after LVAD, and also in heart failure. So this is a study which was done, which is called an ESCAPE study. So which showed that low PAPI, there was lower survival. Other hemodynamic indexes are there, but they are not useful now. What is the cardiac power output? It is defined as cardiac output into MAP divided by 451. And it is a powerful predictor of mortality in cardiogenic shock, in chronic heart failure, and it is useful in the algorithm for cardiogenic shock. So we come to one of my cases. 42-year-old male. He is a lawyer by profession, profuse smoker, a diabetic. He comes to my emergency with chest pain of 2 hours, vomiting, restless, but BP is not there. Femoral pulse is not palpable, radial pulse is not palpable, BP is not recordable. He came at the time of COVID, something around June, July, and I couldn't do a COVID because, or even an HRCT scan, because the patient was sinking. So this was the ECG at admission, very common, inferior valve MI, complete heart block. But the thing that is different between him and others is that we have an ejection fraction of only 22%. So ejection fraction of 22% with inferior valve MI, with RV involvement, with complete heart block, and RV dysfunction is there. So it is a very high risk substrate. As we see, if we go by our classification that we have described, it is a stage D of SCAI. Stage D of SCAI, lactate is 15. So we know that mortality should be something around more than 60%, should be around, say, 80-90% mortality. So lactate is 15, pH is 6.99, PCO2 is 50, and the patient is now going into type 2 respiratory failure. So we had to do a TPI in the emergency, and once we did a TPI and shifted to cath lab, the question is whether we should quickly revascularize the patient or put in a mechanical circulatory support, or should we intubate first. So first, always we decide that we have to support the blood pressure, because a falling blood pressure cannot be used for going for intubation or an intervention. So first we put a IABP from the left groin. IABP lifts up the BP to 116 augmented and systolic BP of 70. After doing the IABP, then we intubate. And we start noradrenaline and insulin infusion, because now patient has is a sugar or a CBG of nearly more than 500, 600. So this is the I think. So his LAD is occluded. Yes, sir. LAD is occluded and his RC is also occluded. So IABP is going on. So which artery should we open? LAD, RC, or both? So we decide, because of the ECG, to go for the RCA, and it is quickly wired and stent is placed, and we have the flow. So I think anyway, what we achieved was that RCA flow was there, and we were able to quickly revascularize the RCA, but we had to leave out the LED because the patient's BP is so low and there is so high acidosis. I decided it is not worthwhile doing the LED at that time, though many of the time it is said that we should revascularize all the arteries. LED was now our question is, we get an ECG after the patient is shifted to CCU, and this is the ECG where there is an ST elevation also in the lead V1, V2, and V3, and this may be possible that the LED was a CTO, and because of the RC occlusion, the LED territory also infarcted, and because after the RC has been revascularized, it is now becoming visible in the ECG. Post PCI, there is persistent acidosis, but however, is urine output improved? Now we are to decide which one to remove first, IABP or a ventilation. We kept the IABP and we extubated the patient. Now we started tapering noradrenaline, and after tapering noradrenaline in day 2, now this is the ECG, and we see that the ST elevation of the LED territory has settled. On day 3, even more settling of the ST elevation in LED territory. Now we have a dilemma. We are not able to taper off the NORAD, and once we start reducing the IABP augmentation from 1:2, 1:1 to 1:2 to 1:4, SBP starts falling, BP is falling. So what should we do? We decided after much soul searching to add adrenaline, and after adding adrenaline, IABP could be tapered off. Vasopressors are tapered off. Ultimately, patient was discharged home on 10th day. So this highlights one important aspect of IABP. IABP is also helpful in RVMI. But why is it so? It causes improved organ perfusion, left coronary perfusion augmentation, improving septal contribution to the RV stroke volume, and it also increases the flow in the RCA. And it has a helpful role in proper positioning of the septum. Important thing is to realize that though there are many devices available now, IABP, tandem heart, Impella, none of them have shown a mortality benefit, and they are all nearly same. Though hemodynamically support by Impella is much better, but 30-day mortality, as we see from the table, is not working.
Wind up.
Yes, a summary is there. So hemodynamic parameters are early indicators of shock and should be measured. Early transition to mechanical circulatory support is to be considered. However, in spite of all advances of treatment, it is a high mortality condition, especially in the elderly. Thank you.
Thank you very much, both the speakers. Now the session is open for discussion for 5 minutes only.
Yeah, I think both the speakers have done excellent job in their presentations, especially the cardiac transplantation as well as the hemodynamics of the cardiogenic shock. I would have preferred some more emphasis on the non-invasive hemodynamic data assessment also, because these are now being almost given as a standard thing, like especially the echocardiography, which gives a lot of information regarding regarding many parameters. And apart from this, the thermodilution technique, which was earlier used, but this is again coming up in a very, very big way, because a lot of companies have shown interest. And in the CCU level, we can actually determine the cardiac index, then stroke volume, and so many other parameters just at the bedside itself, and we can decide upon the various parameters. Now, so for the cardiac transplantation is concerned, definitely there has been a surge in the cardiac transplantation, and naturally we should know the various hemodynamics. There is no doubt about that, and we are picking up. But so for the cardiogenic shock is concerned, I think the case Sunandan has presented, it was beautiful. Only thing I was having the doubt in my mind whether he should have gone for opening up the LAD as well, because that would have given him much more benefit in terms of the hemodynamics much more quickly. So any comment from other moderators and chairpersons?
I think it all depends on whether the LAD could be opened or not, because if it was a CTO, the RCA was a culprit lesion there, and if LAD was a CTO, maybe if it was a full toss case, he could have opened it. But if he could do it and try, then- yeah, yeah.
Sir, actually, this patient is now back to his profession. He doesn't want to open his LAD now.
No,
Yeah,
what
he says,
was it?
He is not fine. I have told him to undergo another angiogram.
Deferred PTCA for the LAD. Deferred
Yeah. Deferred PTCA of the LAD was the strategy that I took. But now the patient refuses to do anything more. He says, I am fine. I am into my profession. I will not go to open the LAD.
That's a good decision by the patient himself. Yes, Kanak, just unmute yourself. Kanak, unmute.
Yeah, in cardiogenic shock, it's better to revascularize as far as possible in the same sitting to overcome the shock. In cardiogenic shock, you should not address not only the culprit vessel, but also the other vessels if they need revascularization in the same sitting.
So actually, sir, cardiogenic shock is also a big spectrum thing. So we have a patient whose lactate is 15 and his EF is 22%. He is already on a ventilator. If we have a CTO in the LAD and we have a lot of time wiring the LAD, then there is a high possibility that the patient wouldn't have gone home at all, because he may have crashed there only, there and then and there. So I just took a chance in the case, and that's why I presented it.
It needs to be judged case by case.
Absolutely agree with you, because this is the current guidelines. Current guidelines as per shock trial, it is the culprit shock trial. It is only the culprit vessel should be revascularized and the other non-infarct related arteries should be left for received by a later death. So this is the current guideline. This is the current guideline. Culprit shock trial. So I have two questions. One to Dr. Sikdar.
Yes, sir.
Dr. Sikdar?
Yes, sir. Yes, sir.
I have one question, not question, I need your comment. You have defined several hemodynamic parameters regarding the treatment of cardiogenic shock.
Yes.
But we are sometimes at the dilemma when to use IABP, when to use Impella, or when to use ECMO. So can you give a rough guidelines in which parameter hemodynamic status we should prefer either of these devices?
Sir, as far as the literature is there, so literature does not say that Impella should be preferred over IABP in any of these conditions. But if it is well known that if the cardiac output is so low, Impella is the one that will give a good cardiac output. But there is no guideline as far as saying that Impella should be used instead of IABP. But what we have found is that IABP, if it is properly used early, is quite good in salvaging the patients. Impella in any case is not much available in our setup. So thinking that I will put in an Impella or that thing is a thing that is theory in most of the hospitals we have now in Calcutta. So
especially in the background of MI, IABP is preferred than Impella in the background of STEMI.
STEMI, yeah.
STEMI heart failure. Yes. Now another question to Dr. S.N. Datto.
I think time is over. So
okay.
Time is
okay,
over. Could you give your concluding remarks and wind up the session?
Dr. Mitra, you can wind up. You can conclude the session.
Yes, these are the two very important sessions regarding the hemodynamics, and this is the basic guidelines for the treatment in both the subsets, that is in cardiac transplant as well as in the management of the stroke. Both the speakers were very meticulous in their description. So thank you all, and thank you is the speakers for their excellent speech regarding this. Thank you also my chairpersons and my others.
So thank all the participants, including the audience. Dr. Saha, it is over to you.
Okay, sir. So let us move on to the next session. This was a nice one. And sir, if it is possible, you please stay with us. Dr. Das Bishash.
I can stay back.
Because the congenital portion will be continuing.
Now we are moving to our next session, which is congenital heart disease routine practices. And I like to request the chairpersons and the moderators to please proceed the sessions. Dr. Alok Mojumdar, Dr. Shubhendu Mondol, Dr. Amitabu Chattopadhyay, Dr. D.P. Sinha, and the moderators are Dr. Chanchal Kundu, Dr. Vishwajit Bandhopadhyay, Dr. Hemant Nayak, and Dr. Debashri Gangopadhyay.
So, Adhinika, have you verified all are there or not? All of them are present.
Sir, one second. Sir, Dr. Shubhendu Mondol.
Okay, start with the moderator first, and first speaker is Nurul. So if they are present.
Yes, sir, there is a Dr. Hemant Nayak present.
Yes.
Dr. Vishwajit Bandhopadhyay.
I think they can join later, but at least Dr. Alok Mojumdar, Dr. Amitabu Chattopadhyay, Dr. D.P. Sinha, they are wanted very much, and Dr. Chanchal Kundu. I can see Dr. Chanchal, he's there, and Nurul is also there. So I think Alok can join later. Amitabu, if it is there, it is nice to have him. Dr. Sinha, he may join later. Now we can invite Dr. Nurul Islam and Dr. Chanchal Kundu. Dr. Kundu, you know, is the assistant professor at Medical College, and he's a very good clinician as an interventional cardiologist. He will moderate the session. And Dr. Nurul Islam is a very well-known pediatric cardiologist from Durgapur Health World Hospital, and he is very experienced in all types of clinical, invasive and non-invasive job, and looking after pre and post-operative patients. So, Nurul.
Yes, sir.
You start with your program very quickly. You have to finish within 12 minutes. ECG,
yes.
Congenital heart disease.
Yes, sir. I'm sharing my screen.
So I would request to finish it by 5:35.
Sir, is it visible on the screen?
No, you are only visible, not your slides. Please start slide sharing.
Is it visible now, sir?
Move to the presentation mode.
Yes, sir. So, good evening, everyone. My senior teachers and colleagues on the screen, other side. It's a pleasure to present this topic, though it's looking simple, but we as a pediatric cardiologist, we face in our day-to-day practice different congenital heart disease, how they present. The topic is on the electrocardiogram, though it is a very simple diagnostic tool, but really it's very difficult in a case of small baby or children to have good ECG strip. But honestly, if the findings on ECG paper fused with the clinical notes, it can give good information and helps to diagnose even without the basic echocardiography in a remote part of the country. Before I would like to start the basic classification of congenital heart disease, it's in two parts, acyanotic and the cyanotic. And acyanotic are divided into shunt lesion, either is a pre-tricuspid shunt or post-tricuspid shunt. And sometimes it may be obstructive lesion involving the left side of the heart or right. And other group that might be some congenital heart block. Among the cyanotic or blue baby, that it most commonly we face the decreased pulmonary blood flow, and the most common lesion is tetralogy of Fallot with different combination like pulmonary atresia or other cardiac illness which having the tetralogy physiology, decreased pulmonary blood flow, or increased flow like TGA physiology, truncus, TAPVD, or tricuspid atresia, unrestricted pulmonary blood flow. Before starting the ECG paper, it is better to always check the age of the child or the baby and the background for which it has been advised. The clinical picture is very important. And if you have any previous ECG, always try to compare any changes or new findings appearance, and also look at the calibration height, that is the voltage, and the paper speed. There is a 7-year-old child, 18 kilogram weight with little bit of failure to thrive, saturation 98%. You had a chest X-ray which shows increased cardiothoracic ratio, as cardiomegaly with short ejection systolic murmur. So on ECG paper, it is showing the lead 1 and the lead AVA. You see there is the right axis deviation, and if you go to the chest lead, there is V1, right precordial lead, there is a intraventricular conduction delay or right-sided volume overload which is expressed on the ECG papers like RS, R-dash patterns, is very classical for a child with an ostium secundum atrial septal defect. So this is the classical pictures of ASD ECG. The same type of child, 6 years, 15 kilogram, 98% saturation, there is the S-cyanotic, and the X-ray also the cardiomegaly, but you get the grade 2 pansystolic murmur, the left axilla. Here ECG helps. There is a left axis deviation you see from the lead 1 and the lead AVF, and there is a RSR dash pattern in the chest lead. So most likely it is a case of atrial septal defect, but ostium primum time, left axis deviation is there. Similarly, if you see that, there is a 4-month-old child with a history of failure to thrive and frequent chest infection, syndromic baby. There is a sweating during the feed and the short ejection systolic murmur on auscultation. X-ray shows the cardiomegaly and the plethoric lung field. So most probably we are dealing a child, syndromic baby with increased pulmonary blood flow kind of situation, and acyanotic, it may be some septal defect or shunt in between the great arteries. And the ECG paper shows the normal axis, but if you go to the left-sided precordial leads, it is showing the left heart predominance and the presence of the deep Q wave in the V5, V6 or V4. So it's suggestive of the shunt lesion is significant, causing the volume overload on the left-sided chamber. But the same baby who comes after almost 8 to 10 months later after first birthday, it has developed already features of pulmonary hypertension, and there is a disappearance of the Q wave from the left-sided chest lead. So patient is developing pulmonary hypertension. We need to take a call little early. 25 days old baby with mild tachypnea, and saturation is 92%, borderline. So it comes under cyanotic, but you are getting a long ejection systolic murmur at the grade 3, chest X-ray mild cardiomegaly, but normal parenchyma. So it's a newborn baby, just remember, and you see there is a predominant or R wave, true R wave in the V1 lead, which is suggestive of the RV under pressure overload, not volume overload. So in a newborn, if you get a long ejection systolic murmur, probably we are dealing a baby with obstructive lesion. Most likely it's a right heart obstructive lesion. It's a severe pulmonary stenosis and the ASD shunting right to left causing desaturation. Frequent chest infection with pneumonia, failure to thrive during the infancy. And there is an improvement of the symptoms during the early childhood. At teenage, the patient presented with a complaint of shortness of breath. So, and saturation has dropped to 88%. On auscultation, you get loud P2. So from the history, it gives the child had some shunt lesion, and in course of time, the symptoms improves. That means there is a development of the pulmonary hypertension and the restriction of the pulmonary blood flow, and now developed pulmonary hypertension causing right axis deviation with the predominant R wave, the chest lead V1, and there is a disappearance of the Q wave from the V4, V5. That means the developing pulmonary hypertension. And you see in the lead 2, there's a P is very tall, pulmonary. So 3-month-old baby, failure to thrive, tachypnea, tachycardia, subcostal retraction, and echo shows echogenic papillary muscle with severe MR. So these are the children with significant MR. So presence of significant findings in the lead AVL. In a child with deep Q wave in the lead AVL or lead 1, there is a myocardial disease. So this is a child with anomalous origin of the left coronary artery from pulmonary artery. 35 years old lady, there is a large pretricuspid shunt, now desaturating. Chest X-ray showing oligemic lung field, pruning of the distal vessels, and X-ray shows right axis deviation, pure R wave in the V1, and from the clinical picture, it's showing the patient has developed pulmonary hypertension. So patient had some acyanotic lesion, most likely ASD, and now developed the Eisenmenger syndrome. 3 years, apparently looking pink, grade 2 clubbing, short ESM pulmonary area, and previous history of loss of consciousness. Most likely we are dealing a child, cyanotic child with spell. So it's showing the right axis deviation, pure R wave in the V1. It's a case of tetralogy of Fallot. This is another ECG, a classical ECG in top child. 6 years old, shortness of breath on exertion, saturation 95%, very irregular fast heartbeat, increased CT ratio, prominent RA border, lung field oligemic. And you see that the ECG shows very fast heartbeat, ventricular rhythm, and most likely patient is AF. So probably it is a case with Epstein anomaly where we expect some abnormal rhythm due to some extra pathways. Adolescent girl previously diagnosed with cyanotic heart disease TOF. Now the ECG is not classical of TOF. There is a left axis deviation. So probably the child has developed significant amount of the collateral causing left-sided volume, adequate volume causing left axis deviation. 13-month-old baby with saturation of 70%, short ejection systolic murmur, chest X-ray oligemic, prominent right atrial border, and you see on the ECG left axis deviation with the prominent LV forces. Most likely it is a tricuspid atresia. This is a previous admission with very fast heartbeat in the PICU on medication, and it is most likely a child with extra accessory pathway. Yes, sir.
I'm sorry to I'm interrupting you. Just I'm asking how many ECGs you have. If you don't have a lot of ECGs, then you can discuss the differential diagnosis also. Otherwise, if you have a lot of ECGs, then you have to proceed in the way you are doing.
I think I have to finish within time, so I have to just proceed, sir. Otherwise, I will cross the time, sir.
Sorry to interrupt.
Okay, sir. So in this ECG test lead, it is obvious there is a probably delta wave which caused the arrhythmias. So patient is controlled with medication. 5-month-old baby with tachypnea, dusky look, saturation 88%, and X-ray shows the mediastinum is little bit of widening, superior mediastinum, not any classical figure, classical images, but pulmonary venous congestion, and the ECG shows right axis deviation in sinus rhythm, RV forces. Most like it was case, mostly we get in a child with TAPVC. This is the ECG in a truncus where there is increased pulmonary blood flow. The RV is systemic and there is a right axis deviation and biventricular forces. The cyanotic child with chest X-ray, narrow pedicle. So most likely both the great arteries anteroposterior and the classical agon side appearance. So it's a case of TGA. The pattern, the commonest pattern of ECG, right axis deviation, RV forces as seen in the pure R wave and V1 lead. Sometime in a congenital heart disease, whether treated or operated, we might get some narrow complex rhythm and the P is not visible or coming just after the QRS may have the nodal rhythm. Sometime even if we depend on the machinery interpretation from all the machine, ECG machine, they give the automated report, but sometimes we need to very careful whether it is true or not, because this is the baby who is showing the 94 heartbeat, but if you see carefully, they lead to the QRS complex is very less. It is a baby with a congenital complete heart block who require the pacemaker later on. So don't depend on the machine only. In the left to right shunt type of lesion, we get the QRS axis -30 plus 150 and RS-R dash pattern in V1. Mostly it is ostium secondary MASD. When it is a left axis deviation, either LVH, RVH or BVH, ostium primary MASD. The normal axis LV dominance or LVH, it may be a shunt lesion post-tricuspid, either VSD or PDA. In a newborn or a small child, if you get the pure right ventricular dominance, so there may be pulmonary stenosis part. Obstructive lesion show the pure right ventricular hypertrophy for PS and left ventricular hypertrophy for left-sided obstruction like aortic stenosis or coarctation of aorta. In this regard, we need to keep in mind in the newborn, there is particular value which helps to diagnose RVH or LVH. If the R wave is more than 25 millimeter in a newborn, it's a RVH. Or if we get the T wave positive till day 3 of life, after 3 of life, so it is a RVH or RV under pressure overload. In a newborn baby, we do not get so much of the LVH, but if a baby with having the R wave in the V6, left precordial more than 12 millimeter, so it can be a case of left ventricular hypertrophy. So the ECG, though it's a basic tool, but if it is combined with the presentation and whether the child is having acyanotic or cyanotic heart disease from the clinical examination and the pulse oximeter saturation, it helps whether it is the diagnosis to reach the diagnosis. And also the chest X is very important because the chest X gives the idea whether it is increased pulmonary blood flow on the context of cyanotic or acyanotic. So by this, ECG can be helpful in congenital heart disease, and we should practice, especially in our SRship or residence period. It can be helpful for diagnosis also.
Thank you, Dr. Islam, for nicely covering the spectrum, but it is a very wide spectrum discussion and cannot be finished in 12 minutes. We'll take up the discussion part at the end of the session. Now have Dr. Alok Majumdar and Dr. Amitabh Chattopadhyay joined. Dr. D.P. Sinha also is wanted. So if they have not joined, I am continuing.
Yes, sir. Yes, sir.
Who is speaking?
I'm Amitabh, sir. Amitabh.
Okay. So Amitabh, you can note down the points and discuss at the end. And you can call upon Dr. Dhritabhata Das to begin the next session. And is Dr. Vishwajit Bandhavadhyay is also there? He is the moderator of this session.
I can't find him, sir.
Okay.
I think he has not
Dr.
joined.
Chattopadhyay, Amitabh, you please call in Dr.
Yes, sir.
Dhritabhata Das.
Yeah. So welcome to Dr. Dhritabhata Das. He's my colleague and instantly he's my co-fellow. We have trained together. He's a consultant pediatric cardiologist at the AMRI hospitals, Mukundapur and at Korea. So may I invite Dr. Dhritabhata Das? Dhrito?
Good evening. Can you hear me properly?
Yes, go ahead, please.
But Nunal, stop.
I cannot share my screen.
And allow Dr. Dhritabhata to step in.
Okay, sir. Yes, sir.
Can you see my screen?
Yes. Please put in the slideshow mode. Yeah, good. Go ahead.
Thank you, Amitabh, for your nice introduction. My topic is quite common. It is atrial septal defect, the role of echocardiography in the assessment of ASD as well as post-procedure follow-up. Now, we know that atrial septal defect is the commonest among the adult congenital heart disease because it is not picked up in the children. And that's the reason ASD device closure is a topic of interest for both the pediatric as well as adult interventional cardiologist. One thing is important, although PFO is technically an interatrial shunt, but I will leave the PFO because it is a completely different entity in today's discussion. The echocardiography plays a very important role both in the detection and selection of cases, the procedural guidance, and as well as post-procedure follow-up. The most important in case of ASD device closure is definitely the selection of cases. We all know that there are different types of ASD. Out of these different types of ASD, we will be discussing on the ostium secundum ASDs here because these are the common ASDs which are closed by non-surgical method. And the commonest devices we use is Amplatzer septal occluder or similar type of devices. Sinus venosus and coronary sinus type of ASDs, although truly they are not atrial septal defects, but some of them can be closed non-surgically. We will not be discussing that assessment in this talk as well. Now, what is an ideal ASD? We all know that it is a centrally located ASD with a good rims all around it. What are important is that there should be adequate rims around the ASD so that the device can be held in its position. One thing is important that there should be dilatation of the right atrium and right ventricle. If there is a very small ASD, which is not causing any right ventricular volume overload, there is no reason to close that ASD because the QPQS is small. Another important thing, especially for the elderly patient, is ventricular function, especially the diastolic function in the elderly patient can cause problem in the post-procedure period. During the echo assessment, one thing which is most important to keep in mind that interatrial septum or ASD is a three-dimensional structure. When we are assessing the ASD, especially on 2D echocardiography, then we have to keep in mind that ASD is three-dimensional and we need to analyze the ASD from different views to get the size and shape properly. ASD is not definitely always a circular thing, so it can be of different shapes. Another important thing which is sometimes missed is the eustachian valve or Chiari network. Sometimes it can be picked up as the inferior or the IVC margin of the ASD and cause problem in the procedure. In the post-procedure assessment, one should rely on the position of the device as well as the rims have been captured by the two discs of the device, and it is not causing any obstruction to the surrounding structures. Regarding nomenclature of ASD, there are different views and different nomenclatures, but most of us use this nomenclature where I think we know about these nomenclatures. I will skip it. One thing is important, that it is not necessary to have a 5mm rim all around the ASD, although that is ideal. If one rim is absent, which is commonly the aortic rim, which is absent in most of the large ASDs, we can usually place the ASD device in most of the cases. But if there are two deficient rims on the opposite sides, then it is difficult to close the ASD with non-surgical. Another thing is important is that it is not only the length of the rims, the firmness of the tissue is also important. If we look at the ASE guidelines, then these are the nomenclature of the rims: the aortic rim, AV valve rim, SVC and IVC rim, posterior rim, and the right upper pulmonary vein rim. So one should assess all these rims before planning the procedure. Now, out of the different kinds of echocardiography, transthoracic echocardiography is the most commonly available and always the initial assessment tool, and it is often adequate in young children even for the device closure procedure. And it is also the mainstay for follow-up. One thing again, I will stress that it is one should look at the ASD from multiple views and get a reconstruction, three-dimensional image mentally at least, to get a proper assessment of the ASD. Now, these are the different views. I will not go through the detail how to get these views because most of us know. Subxiphoid views, where we see the right pulmonary vein, venous rim of the ASD. We measure the ASD diameter from the subxiphoid long axis views. And if one is interested in the atrial septal length, this is the view where one should measure the atrial septal length. In the post-procedure echo, we look at the ASD device, whether it is in position, and also we look at the color flow mapping, whether there is any residual flow across the device. Then the next important imaging plane is the subxiphoid short axis view or sagittal view, where we can see the SVC and IVC rims, and we can measure the ASD diameter. This is the best view to measure the diameter of the ASD, both from the short axis as well as the 4-chamber view. One thing is important, that if you look at the small tissue, this is the small eustachian valve, and it can be long as well. So one should not see this as inferior IVC margin of the ASD, because IVC is draining here. So this is the actual interatrial septum, and this is the ASD, not this one. Often it can cause mistake during the assessment, and one should be careful about it. In the post-procedure echocardiography, we look at the ASD device, whether it is in position, whether it is causing any obstruction to the SVC or IVC, and whether there is any residual leak or not. The apical 4-chamber view, this is commonly used by the adult cardiologist during the assessment, because subxiphoid views are not very easy to get in the adult population, but one should keep in mind false dropout is quite common. So one should be careful before diagnosis than the ASD, and one should demonstrate that there is left to right flow or right to left flow, whatever is present across the 2D dropout. In the apical 4-chamber view, during the post-procedure assessment, we look at the ASD device position and whether it is causing any problem with the AV valves. This is the parasternal short axis view, where we measure the aortic rim and the posterior rim, and we can measure the ASD diameter here as well. And this is how it looks in the color flow mapping. In the post-procedure echo, again, I'm looking at short axis parasternal. This is not a true parasternal short axis view. I have kept this view purposefully in the presentation, because while in the cath lab, the patient is in supine position, especially older child or an adult, it is difficult to get a parasternal short axis view. So one can get a view which is in between the parasternal short axis and the apical 4-chamber like this one, and assess the necessary things like the device position. There is a small residual through the device leak, but otherwise the pulmonary veins are unobstructed and there is no indentation or the aortic rim as well. Another question which often keeps in the mind of the interventional cardiologist, whether the ASD is too big for ASD device closure. Now, in case of adults, it is not difficult, because the largest Amplatzer device available is 40 millimeters. So if an ASD is 36 millimeter or more, then it is not possible to close it with an amplatzer septal occluder. But there are some Chinese devices which can be used for larger devices also, but those should be done with experienced hand. Now, in case of children, if you look at this echocardiography, so this ASD looks quite big. In the fourth chamber view, it is quite big, and in the subcostal view is measure about 18 to 19 millimeter, whereas the body weight of the child is 12 kg. Whether we should close this ASD with a device or not, that is often haunts the interventional cardiologist. Some people use the atrial septal length, some people use device body weight ratio. But most of us now are quite happy to close these ASDs if the rims are adequate. If you look at the post-procedure echo, it definitely does not look very good. The whole of the atrial septum is occupied the device, and even it is impinging on the AV valves also, causing some very little mitral regurgitation and tricuspid regurgitation. But there is no residual leak, and you can see that the device is quite stable in position. As the child grows, the device becomes relatively smaller compared to the patient heart. And most of us are quite happy to release these devices, although it is causing, if you look at the long axis view also, the left atrial disc is touching the anterior mitral limb, and there is a little bit of MR, but usually most of these are harmless. Now, it is more important to know when not to close ASD and how much to compromise with the standard recommendations. So if you are not happy with the 2D transthoracic echocardiography, then one should definitely look for transesophageal echocardiography, either 2D or if possible 3D. It is almost always necessary in case of adult patients because transthoracic echo windows are often compromised, and it gives better procedural guidance because you cannot turn the patient to the left side on the cath lab. These are the different TE views which already know. In addition to these views, some people use the transgastric view to look at the IVC rim, which is not very well visualized sometimes in these standard views. Just to give a few examples of the transesophageal, this echocardiography is a very suitable centrally located ASD as we go through the different views. And if you look at the sector one on the lower left corner, this is the large sinus venosus ASD, and this ASD cannot be closed with a device. If you look at this transesophageal echocardiography, you can appreciate that there is a significant atrial septal aneurysm. And when we put color flow, we will see that there are multiple ASDs in this picture. So there are multiple ASDs. Often when we are looking at the 2D echocardiography, it is not possible to exactly tell how many ASDs are there. But if you go through the different views, you will appreciate that this is an ASD which definitely will not take up for a device closer. So in the ASVC, IVC view, all the different views, I'm just keeping the whole loop. During the procedural guidance also at the cath lab, transesophageal echocardiography is very helpful.
Please try to wind up in 2 minutes if possible.
Yeah, I'll do that. So this is an adult patient where you can see that there is a fenestrated ASD. The ASD is not very big, but if we look at the IVC rib, I have not shown the pre-procedure. In the post-procedure, you will appreciate that the IVC rib, which I am marking with my arrow, is very thin and floppy. But you have to ensure that IVC rib is captured by the 2 discs of the ASD device. And one thing is important, all the operators, we know that the orientation of the ASD device, especially if the IVC rib is floppy, is quite horizontal. And because there is a traction of the cable, as soon as the cable is released, the device takes the proper position, and you can appreciate that this is nicely positioned and there is no residual leak. 3D echocardiography, it is mostly used in the transesophageal echo. The main advantage that we get a 3D reconstructed image, what we normally reconstruct mentally in case of 2D echocardiography. You can assess the rims and you can appreciate the different sizes of the ASD as it changes with different cardiac cycles. Another place where the 3D echo is very important, where there are multiple ASDs, you can appreciate that there are 4 ASDs actually. As I was mentioning in the 2D echo, you will see that it appears that there are 2 defects, but actually there are 4 defects, and such an ASD, no one will dare to close with a device, and there is a surgical closure. This is how it looks like during the procedure. You can see the LA disc and the RA disc. Intracardiac echo, I have very limited experience. In only one case I have used, but it is at par with TE. So there is no need to jump for intracardiac echocardiography. The only advantage is that we don't need a general anesthesia, and we don't need an extra operator as, for the echocardiography. But the cost is again prohibitive. These are the some of the intracardiac echo pictures. Complications, most of them are early. That is good that most of them are detected either at the cath lab table or before the patient is discharged. You can see that there is some indentation on the aortic root, which is thought of that cause aortic root erosion. And this is a multifenestrated ASD where the device has been placed in through a smaller ASD. That's the reason it is not properly placed. So this is something which happens in spite of all kind of assessment. This is a large ASD device which is embolized into the left atrium. It is just sitting in the mitral inflow. To summarize, echocardiography plays the main role in all stages of ASD device closure, pre and post procedure, and proper assessment prevents complications. Thank you very much for patient hearing, and I would like to respond to any questions from the audience. And
thank you very much for briefly presenting the echocardiography overview. Actually, you cannot discuss all the nuances of ASD closure here. And yes, please keep on waiting. And do we have Dr. Hemant Naik here?
Yes, sir.
Okay. Thank you. So we have Dr. Hemant Naik, Senior Consultant Cardiologist from Mission Hospital, Durgapur. He will moderate the next session. Do we have Dr. Saurabhi Das? Who is the speaker? Dr.
Yes, sir. Good evening.
Is Saurabhi there? Amitabh, can you confirm whether Saurabhi is there or not?
Yes, sir. I'll definitely see. I thought she was here.
Yes, Dr. Saurabhi will be there.
So can you?
Yeah, yes, she is there. She is there.
Please introduce her, and Saurabhi, please start sharing your screen.
Hello.
Yes.
Hello.
Please,
Yeah, Dr. Saurabhi. I'll just introduce Dr. Saurabhi. She is the consultant pediatric cardiologist at Mission Hospital, Durgapur. She received the pediatric cardiology training at R.N. Tagore Hospital and was one of the brilliant students. She is presently as a consultant at Mission Hospital, Durgapur. She is working with Dr. Hemant Naik, and they are doing a wonderful work there. So, Saurabhi, can you just start the talk, please?
Yes, sir. Thank you so much, sir, for your kind words. I'll be talking on the management issues in adult with congenital heart disease. And I'm sure we all know that this is just like a Mahabharata, and nobody has heard about a concise Mahabharata. So in order to make the journey a little more...
But you have to finish in 12 minutes,
Yes,
like Gita. Okay.
Yes, sir. Yes, sir. So in order to make the journey more pleasurable, I'll be discussing the lives of some of the adults who had presented with congenital heart disease to our OPD and how we managed them and what were the problems that we faced. In the beginning, I have some disclosures to make that I'm very grateful to all my teachers, seniors, and colleagues for sharing their work with me. And most of the experiences are in accordance with the European Society of Cardiology 2020 guidelines regarding adults with congenital heart disease. Now, to begin the story, these are certain landmark people who are in the glamour world. There is Arnold Schwarzenegger, the Terminator, and other one is Brian Larry. Now, he is the vocalist behind the Backstreet Boys. We all know glamorous life, but do we know that these were the patients of adult congenital heart disease? And Arnold Schwarzenegger had a bicuspid aortic valve and had undergone 3 consecutive surgeries for the repair of same. While Brian had a large ventricular septal defect, he had been hospitalized as an adult for infective endocarditis and had undergone surgery at the age of 24 years. So their remarkable lifestyle says that all is not gloom for adults with congenital heart disease. However, in the beginning, there are many challenges which the adults have to face, and it is at 3 levels, like the patients, the cardiologist, the cardiac surgeon. Cardiac surgeon has to deal with repeated sternotomy wounds, difficult vascular access, comorbidities, and ventricular dysfunction. Cardiologist, he has very little knowledge. He doesn't know what he is going to treat and what is going to be the future of a patient who is already 50 or 60-year-old, and he's deciding to treat him. While the patient, he has a lot of doubts. He knows nothing about his anomaly. He finds it very difficult to accept that he had led 50 years of his life with a defect which was present at the time of birth. How could I live so much, madam? I don't have any problems. These are the things which they say. Together with that, they have the burden of society, where they have certain social taboos. They have to deal with financial aspects. They have mental problems. So all these are some of the backdrops which we have to deal. But we have to remember that once a congenital heart disease, it goes on for long. And patients with congenital heart disease, when present as adult, may be patients who will have emergency admissions, exercise intolerance, sudden cardiac death, endocarditis, lifelong medical therapy, as well as early coronary complications with arrhythmias and hypertension. Pregnancy can be very much complicated. They may also lose their child. So firstly, let me begin with the shunts, the usual left to right shunts which we come across, like the ostium secundum ASD. Now, this is something which is very rosy to us. And also the guideline says that in case of OS-ASD, we should always try for a transcatheter closure. Here I am discussing the life of a 23-year-old female who had come to us saying that I have a hole in heart, but I do not want to start. So her ASD measured something around 26 millimeters with some floppy IVC and posterior superior rim. We went on to close her defect with a 32 mm device, and then we sent her to the nearby ICU for observation. The entire procedure was hemodynamically stable. But after 2 hours, she suddenly started complaining that I have some pain in my chest, I'm feeling palpitation. We knew that these complaints were something which was the blue. Everything was not rosy, and it was confirmed on doing an echocardiography, and fluoroscopically, we can see that the device is dangling into the RA. Now, what at this point of time? Should we panic? Actually, we should not. We actually discussed the case with the patient party, and since she was hemodynamically stable, we took her to the cath lab. Now, we also informed our surgical counterpart that in case of need, they have to be by our side. Now, what are the things that need to be done? First, stabilize the patient, arrange for a higher sheath, go for heparinization, if required, resynchronization. Now, here we are trying to take on the device, and the procedure that needs to be done is find an idle view where the device is, the screw of the device is perpendicular to our sheath and the snare. We are latching onto it and then slenderizing it in the IVC. If required, in daredevil cases in the aorta also, we can slenderize it. And here we are trying to find out the device, retrieve the device from the PA, which is the most safest site for retrieval. Now, nextly, I'm discussing the case of Uma, who is a 42-year-old female whom we closed ASD, we closed off with a 32 mm device. It was stable all throughout the procedure, but at 2 to 3 hours after shifting to the ICU, dyspneic, became hypoxic, and when we saw her echo, she had developed gross biventricular dysfunction, especially the LV looked very bad. X-ray showed immense pulmonary edema, so she needed to be immediately intubated, started diuretics. We also gave her NORAD as well as dobutamine, and then she stayed ventilated for the next 36 hours, after which we could actually extubate her, kept her with us for the next 5 days, and then she was sent on decongestive medications and also ionodilators. Now, this is another condition which we usually face in our clinical practice. Now, this is another patient who's 52-year-old female, and she sweet ASD, which we couldn't resist for closing. But the thing was, she had biventricular dysfunction. So this time we had planned a fenestrated device, and if required, we were ready to leave her. Now here we can see that we are taking a LV EDP along with pulmonary capillary wedge pressures, which actually have a very steep rise once we put in the device. So what we decided was to leave her alone and let her go. So these are certain critical decisions which needs to be taken when we are seeing an adult. Now, some people have actually recommended LV reconditioning by giving vasodilators as well as ionodilators and decongestant before doing the procedure so that a success is ensured. Now, next is ostium primal defect with a cleft in the mitral valve. This is the most commonest defect which presents to us apart from that of ostium secundum ASD. There is a severe left AV valve regurgitation. We have to send this patient for OT, but a right heart catheterization is a must because there is associated pulmonary arterial hypertension. Now, one thing which is recommended in the latest guidelines is that in spite of surgery, these patients may actually have remaining left heart regurgitation, left-sided AV valve regurgitation, and they need to be actually managed by medical therapy and not go for repeated surgery. Now, here we are in case of sinus venosus ASD, where a sinus venosus ASD, there is a paradigm shift where we see that the ASDs are now closed up in the cath lab rather than basically in the surgical ward. So here we are, I'd like to show you an interesting case here of a sinus stenosis ASD which is being closed off using a covered stent, that is a covered CP stent. This ASD measured 10 millimeters, and we had used a 13 millimeter covered CP stent, and we had also used a max LED balloon to inflate it. Now coming to a unique case of a VSD device closure. Now we whose name was Rehmat Ali. He was 20 years old when he was diagnosed with Epstein's anomaly of the tricuspid valve, along with the VSD. Now, the Epstein's anomaly was treated accordingly, but the VSD remained a very small VSD, 1.5 millimeter. He was on checkup with us, but after 5 years, at 25 years of age, now he was ready to remarry. He was ready to marry, I'm sorry. And then he was complaining that he has developed palpitation and chest pain. Now, we were not sure whether the marriage was causing all this or whether it was the underlying defect. When we saw, we actually found that his VSD had increased up to 6 millimeters. I'm sorry, this is the VSD. This is the Epstein's anomaly. And sorry, there's some glitch. This is actually the VSD, which had increased in size. So we again took him to the cath lab, saying him that he will not get any more new scars. And we actually put in a device which measured around 14 by 12, ADO1. Now, what was post device, the patient was shifted to the ward, but he started developing gross hematuria. Now he was very scared. He said that he had to cancel his marriage because he was having hematuria. He would not get married. He was always crying, and a sword was hanging on our heads. Now this is a very well-known fact in case of adults, where we put in devices across two chambers of very different pressure, one in the LV and the other is the RA. So there is a little bit of intra-device residual shunt going on. Along with that, this patient had also developed grade 2 TR post the device closure of the Gerbert defect. So this was causing the hematuria. So we kept him under observation. We actually went for alkalization of his urine. We stopped his antiplatelets, anticoagulants. He needed to be given 1 unit of blood transfusion because there was a drop in his hemoglobin from 13 to 10 grams. His LDH also went on. And then after 2 weeks, his gross hematuria settled down, but there was microscopic hematuria. And he kept on coming to us for the next 1 month with routine RE urine showing microscopic hematuria. And we had actually kept him on a regular interval observation. So after 1 month of the entire thing, the complaints settled, and now this month he's going to marry. So the thing is, this is a well-known fact. And what are the recommendations that some studies have been made, that we can give IV haptoglobulin or IV thrombin in such patients who have residual shunts. And there are also cases where they have actually introduced coils to close the further intra-device residual shunt. And a new trick which has come into the circuit is that some patients actually keep the device in the patient's blood for a period of 15 to 20 minutes soaked outside the body, and then implant this device into the body. Now coming to a third story of a pregnant female with PDA who was referred by the gynecologist because she was too scared to deliver a person with a heart hole. So in our institute, we actually practice the art of doing PDA closures using only echocardiography. So here we could see that we closed off her PDA measuring 5 millimeters using only echocardiography, and thereby she did not have any exposure to radiation. She delivered a 3 kg child after 9 months. Now here, coming to the obstructive lesions, the only guideline that I want to stress is left-sided, right-sided, both-sided obstructive, purely valvular lesions need to be closed off or treated by valvuloplasty in the cath lab. Coarctation of aorta as well as peripheral branch pulmonary artery stenosis can be stented, while the rest, like supravalvular aortic stenosis or subaortic membrane, where we have some kind of muscle bundle, supravalvular TS, they all need to be referred to the adult surgical team. Now, basically in these patients, we need to remember that we might require double balloon technique for treating them. Now, here is a case of coarctation of aorta. This was an adult who was 30-year-old. He had found a new job in the army, and there he was diagnosed with hypertension and some sort of murmur. So he was pleading us, he did not want to lose his job and to do something and fix him. So here we are again, we actually stented the coarctation, since it was a very discrete coarctation, using a Andra XL stent. It was a non-covered stent, but the dictum is you should always use a covered stent or else keep a covered stent in the shelf because coarctation is an aortopathy coagulopathy, and we may face with the problem of aortic dissection and catastrophe. Now, another is a bicuspid aortic valve patient who was operated at 8 years of age with Ross, and then has come as an adult presenting with symptoms of dyspnea, and also he had chest pains. We found that he had severe pulmonary conduit stenosis and he was very symptomatic. So in the next slide, I'll be showing that we had done conduit stenting. Here, severe obstruction can be seen. I'm so sorry. Some of my slides are actually not working. Okay, so conduit stenting was done, and the most important point is these conduits can be actually valved later on. So that is the important thing. Now coming to the cyanotic group. Now cyanotic group, we all know that we come across TOF.
You have 2 minutes left.
Yes, yes, I'll be doing it very fast. I'll just show the case scenario. Adults with biventricular TOF with biventricular failure, where we can actually go for balloon valvotomy. But diuretics are the mainstay in case of treatment when the RV is actually the failing ventricle. Now, next is regarding the group. In case of univentricular shunts like the Glenn shunt, we can actually go for branch PA stenting if the patient presents like that. TOF with MAPCA dependent for stenting of the MAPCA. In case of adult patients like 30 years off with all the criteria fulfilling pulmonary valve replacement, actually transcatheter pulmonary valves can be replaced. Congenital AV fistula device closure can be done if the patient presents with cyanosis of and then we diagnose fistulas. Here we can see that we are actually closing it off with coils and different type of vascular plugs. MAPCA device closure can be done in case of major hemoptysis. Nextly, this is the branch PA stenting. Heart failure arrhythmia subset, we have to keep a very low threshold. We need to take them to the cath lab. It may be because for catheter ablation, or maybe for PPI, CRT, implantation, or ICD. This is a case of Fontan fenestration closure done for cyanosis, and Fontan fenestration creation, which was done for Fontan failure, where the patient had developed a PLE. This is a 35-year-old man. And the last group is the Eisenmenger's group, where we all know that patients present very late. The first and foremost thing to remember is if it is a female, please counsel against pregnancy. And for Eisenmenger's, we need to do cardiopulmonary exercise testing before recommending the drugs. And the first line therapy should be an endothelin receptor antagonist, that is bosentan, which has been clearly said has got mortality benefits in case of adults with Eisenmenger. Now, what is new? There are a lot of gaps of knowledge regarding general measures, arrhythmia, heart failure. Can we imply all the drugs, all the management we do for an adult with no heart disease, for an adult with heart disease, whether they are compatible? The renewed recommendation, the second part, which I want to classify or stress upon, is that disease complexity classification has been done in the latest guidelines, and use of biomarkers, cardiopulmonary exercise testing, be it the simple 6-minute walk test, has to be used to follow up these adults, and emerging role of catheter techniques to treat these adults. I would leave you to ponder on that. Rapidly increasing cohort with multimodality approach to therapy is coming up, and we need to be prepared. Comorbidities and lacunae in experience on long-term outcome is a major limiting factor, and emerging role of objective quantification of the symptoms, biomarker use, and advanced imaging and catheter techniques is there to stay. Thank you and a very good night.
Thank you, Saurabhi. For lack of time, she could not cover on the medical aspects, only she could cover up the interventional aspects. Now, Amitabh, can you call in the other moderator and speaker?
Yes, sir. Dr. Devashri, are you here?
Yes, sir. I'm here.
Yeah, Dr. Devashri is one of our colleagues. He is a consultant pediatric cardiologist at R.N. Tagore Hospital. And the speaker is Dr. Mohu, our colleague. Both are from R.N. Tagore. They are pediatric cardiologists from RNT. They are doing a nice job there as a team.
Mohu is
see Dr. Hemant.
Yeah.
I just had
So,
one
Mohu,
question for
it is
Saurabh.
nice to see you here, but only time constraint is there, but you have got a very important topic to cover, CT and MRI. Please go ahead.
Yes, sir. Good evening, everyone. I would like to cover my topic by giving some case example only. There is nothing, no theory, nothing. My topic of discussion is role of CT and MRI in diagnosis of congenital heart disease. My first case scenario is sometimes CT and MRI is extremely helpful for the diagnosis of some rare planning of intervention. My first case, cyanosis with structure. A 7-year-old boy came to us with central cyanosis. His saturation was at around about 65%, and he had clouding. His X-ray and ECG was otherwise normal except some volume overload, left-sided volume overload. His screening echocardiography also shows structurally normal heart. However, there was dilated LA and LV. We suspected it might be a case of AV malformation. We did contrast echocardiography, and contrast echocardiography turned out to be positive. Then after meticulous echocardiography, we were suspecting that it might be a fistula's connection between LA. For that matter, we did CT angiogram, and CT angiogram confirmed our suspicion. It was a rare form of AV malformation, and there was direct communication between RPA and LA. We decided to take care of that fistula in our cath lab, and we put one big device that was 20 by 18 PDA device. Just immediately after putting the device, that patient's saturation went up to 98%. After putting this device, we realized that it is very difficult to understand the position of the device because some part of the device is actually outside the heart. So we decided to do CT angiogram, repeat CT angiogram. And CT angiogram shown that device is perfectly on place and there was complete occlusion of the fistula strap. In this case, CT angiogram was extremely helpful, not only for the diagnosis, but the execution and planning of these type of rare intervention is mostly depend upon the CT pictures, as well as is also helpful for the confirmation of the device position. My next case where CT was extremely helpful, that was the case of limb length discrepancy with early vascular compromise. We had a patient, 3 months old infant, came to us with incidental detection of murmur. However, she also had limb length discrepancies with early features of vascular compromise characterized by temperature discrepancy between two upper limb. Then we did echocardiography and we came to know it is a case of a right aortic arch with aberrant left subclavian artery. And there was flow acceleration at the origin of the left subclavian artery. We suspected that it might be a case of severe LSA origin stenosis, but it was impossible to understand or diagnose it completely by only echocardiography. So we had to do CT angiogram. And CT angiogram given us a beautiful picture. It confirmed our diagnosis of aortic arch with aberrant left subclavian artery and severe left subclavian artery origin stenosis. In view of impending vascular compromise as a limb salvage strategy, we took up that case in cath lab and we put one coronary stent to salvage that left subclavian artery. And immediately after putting that stent, we can understand there is significant improvement of the peripheral arterial flow. And we can also appreciate almost normalization of the limb length after about 6 months. In this case also, CT was extremely helpful for the diagnosis as well as planning of this difficult or rare intervention. This kid is the youngest one from India, where we have put one stent to salvage the left subclavian artery and the limb. My next case, an hypertensive girl came to us with features of Turner syndrome. That adolescent girl with Turner syndrome phenotype came to us for evaluation of her hypertension. We did echocardiography, but the echocardiography view was not very good. And we came to know there was a bicuspid aortic valve, but we wanted to see the arch properly, but it was not possible. We suspected there may be a coarctation of aorta, but we could not confirm the coarctation of aorta by only echocardiogram. So we did CT angiogram. CT angiogram shows it was not only a simple coarctation of aorta, it is almost interrupted aortic arch. There was luminal obliteration. And CT angiogram not only given us the diagnosis, it's also given us each and every segmental analysis, measurement of each and every segment. Then also we decided to take care of that lesion in catheterization laboratory. Our plan was to perforate the interrupted aortic arch and put some cover stent. Anyway, after repetitive attempt, we were able to cross that lesion and dilated by serial dilatation done by different balloon. And ultimately, we put one andro covered stent. Here also, we can appreciate the ultimate result and can compare the pre-stentic CT angiogram. In this type of difficult intervention, CT has got tremendous role for the diagnosis as well as planning of this type of intervention is somehow dependent upon the CT angio picture. My next case, adolescent boy diagnosed as idiopathic dilated cardiomyopathy. We all know this type of idiopathic dilated cardiomyopathy is a frustrating disease. Most of the time, these kind of patients are destined to death or become a transplantation candidate. So our aim as a pediatric cardiologist is always to identify any treatable cause is there or not. And after evaluation, we normally try to exclude any tight aortic obstruction or coarctation of aorta or alcapa. In this specific case, after a thorough evaluation, we understand there is a possibility of abdominal coarctation because there was flow turbulence in the abdominal aorta as well as there was diastolic trailing in the Doppler spacing. So we did CT angiogram and CT angiogram confirmed our diagnosis. It was a long segment coarctation, abdominal coarctation of aorta. That case ultimately turned out to be a case of Takayasu arteritis. And we treated that case with a large stent. In such kind of cases, like that of idiopathic dilated cardiomyopathy, CT angiogram or sometimes MRI is extremely helpful, not only diagnosis for intervention or operative purpose. My next group of scenario is pre-operative assessment. Sometimes CT or cardiac MRI it can guide surgeon what to do and when to do. My first case, shunt calculation. One 17-year-old male came to us with his T report in his hand. It was written in that T report that suspected PAPVC, right-sided pulmonary vein may be connected to the RA, and there was a small PFO. There was a suggestion written at the end of that T report that we should subject it to that patient in CT angio for confirmation of anatomical diagnosis as well as cath for QPQS assessment, so that we can send that patient for surgery. Instead of doing two investigation, we did cardiac MRI. Cardiac MRI beautifully detected that upper pulmonary vein and right middle pulmonary vein is draining to the RA. So there was complete anatomical diagnosis we achieved. Along with that, we requested to calculate QPQS. So the MRI guy, our colleague, calculated QPQS. It turned out to be 3:1. So we are comfortably sending this patient to our surgeon. Now surgeon is having anatomical diagnosis as well as hemodynamic data with him. My next case, that is pulmonary valve replacement. We are having a 25-year-old male patient, symptomatic patient with history of status post ICR. We all know before pulmonary decision-making of pulmonary valve replacement, cardiac MRI has got tremendous load. It can calculate the RV volume, ejection fraction. There are so many things. We all know about Jeeves criteria. So Jeeves criteria is mostly dependent upon the MRI criteria. So after assessing, we found out that patient needs pulmonary valve replacement. So we send the patient for pulmonary valve replacement. Now my next case to guide surgeon before complex intracardiac repair. We had a patient, 4-year-old girl, presented to us with diagnosis of VSD, but surprisingly that kid also having unexplained desaturation. After doing echocardiography, we understand that it is not a simple case of VSD. It is a large inlet type of VSD with significant overriding and straddling of tricuspid valve. And then we did agitated saline contrast study and understand that it is a different type of case. It is a rare case, that is, it was a case of double outlet right atrium. So right atrial desaturated blood is not draining only into the RV, it is also draining to the LV. That was the reason for heart desaturation. Then we did, that was sufficient. The diagnosis was completely done by echocardiography, but we wanted to guide surgeon. So we did cardiac MRI. Cardiac MRI showed each and everything, how everything like that of caudal attachment of tricuspid valve. So it was very much helpful for the surgeon to decide how to approach. Nowadays, 3D printing is the tool of choice for this type of difficult intracardiac repair. Although cardiac MRI has got a good role to guide the surgeon. My last case scenario, that is post-intervention. Sometimes what happened, there is no point of return. We have already done something. As an intervention cardiologist, we are sometimes somehow worried about our intervention, maybe stenting or maybe device. In that case, I think a CT angiogram has got tremendous role. My first case, that is status post PDA device closure. Nowadays, for the last 2 years, in our RN Tagore hospital, we are doing PDA device closure even less than 5 kg babies. So far we have done 24 cases and we encountered 2 complications. I would like to show those 2 complications. An implication of CT angiograms. A CT angiogram, how help us? My first case, 4-month-old 2.5 kg kid who was stuck on ventilation for congestive cardiac failure and sepsis. And after giving IV antibiotic for a couple of days, we took up that case in our cath lab and we put 6x4 PDA device. The procedure was uneventful and dramatically that patient extubated on next day. We are very happy and we discharged that patient after about 72 hours. But unfortunately, that same kid admitted in our unit with frank features of sepsis within 2 weeks of discharge. Then while doing echocardiography, we were surprised to see there was one big cystic mass in the mediastinum. So we did CT angiogram. CT angiogram shows there was a huge aneurysm at the vicinity of the device, as well as there was another 2 aneurysm in the different part of the aorta. Unfortunately, we couldn't salvage that kid. My next patient, it was also status post PDA device closure. That patient was 4.5.
The time is over, you have to wind up.
Okay, sir, this is my last case. And after doing that device, next day we are a little bit skeptical about our device. We again shift that patient in the CT room and we found out the device is somehow shifted to the aorta. So we shifted that patient to the OR. My last case, we haven't encountered this kind of case, that is OAS ASD, where rims are borderline while we have already done device closure and patient developed chest pain and echocardiography may show pericardial effusion or mild aortic new onset aortic regurgitation. In those cases, CT angiogram is extremely helpful. It can detect aortic erosion or LA roof rupture, and it may be life-saving. Thank you everyone for your patient hearing.
Thank you all the speakers and moderators. Amitabh, you have now the difficult duty to go for the discussion in a short time and just discuss with Jayanto how much time you can be allotted. There have been very important topics that have been discussed, but unfortunately time is very limited.
Yes, Jayanta, we have 5 minutes time.
Yeah, I think Jayanta,
hello,
can you allow Amitabh 5 minutes time for the...
I think within 5 minutes.
Yeah, please, Amitabh, quickly.
Yeah, sir, all the talks are very nice and to the point. All the speakers were extremely, dedicated. Hello, I think there are 2 sources from one person. Hello,
Amitabh sir. Yeah. Amitabh sir. Actually, it was very nice presentation by Dr. Mohua. I have a small question regarding that small boy which has been stented in the subclavian artery. The coronary stent has been put. May I know which size? Maybe a smaller 4 millimeter stent.
Yes, as far as I remember, there was a 4 millimeter stent because we couldn't put any larger size because of the arterial access way, and we had to, as far as I remember, because I was there in this case, and we decided to put in a stent because the reports say wherever balloon dilatation has been done, it had come back within a short time. So we had a very short, in the sense that the child's limb was already shortened, so hence we didn't want to take any chances and we stented. That was the reason.
Yeah, that was an excellent case. But how the limb will be salvaged? after the child grows to a certain age. So the 4 millimeter.
Yes, that is a very good question. Now, what happens is, even in case you do a classical VT shunt where you sacrifice the left subclavian artery totally, thereafter, even though in those cases, the child, the hand did not show much of a growth length discrepancy. But in our case, since the growth length discrepancy was already seen, hence we had to re-establish the source of blood. And at I have now a 5-year follow-up of that patient. Both the limbs are of the same length, have the same mid-arm circumference, and they have they are equally grown. So I think all the collaterals and other things are taking care.
Yes, Dr.
Nurul's case presentation was very nice.
Basically, at the time of publishing our case in IAP, in Annals, we had to discuss, or we had to give those answers. First one, why we didn't do the balloon. Because the balloon in subclavian artery is not very effective. We wanted to do something because there was impending vascular compromise. Next question was that why didn't we biodegradable stent? Because it is not available. Third question was there, if anything happened in adult and adolescent life, so what we can do. There are some kind of surgeries we can offer at that point of time, some kind of shunt surgery to increase the LSA blood flow. But in that case, it will be done in less emergency purpose, like that of one non-emergency kind of situation. At that point of time, when we put that stent, it was an emergency limb salvage strategies, because there was impending vascular compromise. There was pulse volume was discrepancy was there, blood pressure discrepancies was there, as well as there was temperature discrepancies. So by this way, we justified our procedure. I know it is a quite controversial thing.
Yeah, it's excellent case. Then one more case I used to comment. I like to comment. That was Dr. Sorovi's first case, that ASD device closure was done on a 23-year-old girl. That case was done by our institute. That case, all the reams were very juicy, so it was very tempting to close that ASD. And even the patient relatives, they didn't want a scar. So we went ahead and did that ASD. But unfortunately, after 2 hours, the ASD dislodged, the device dislodged. Then we re-evaluated the ASD after retrieving, and finally we found that IVC ream is totally deficient. So one thing I would like to stress upon, if the IVC ream is completely deficient, so should be very careful and should not attempt that ASD at all for ASD device closure. For all my pediatric and adult colleagues, so maybe we may burn our fingers in those cases. We have done what we say IVC ream deficient. Probably that IVC ream is not completely deficient in all those cases. But if we do a 3D reconstruction and see that there is no IVC ream at all, then those cases we should not attempt. So like the case, we send that case for surgery. Thank you.
Is Dr. Dipingina there for the final comments?
It was an excellent session. In fact, many of the things that I learned today are to stand by in making clinical decisions. That's it. An excellent program.
Now we are moving to our next session, which is arrhythmia.
One moment, Adhunika, let me conclude.
Okay, sir.
I think I missed Dr. Alok Majumdar and Dr. Bishwajit Bandyopadhyay. Are they are here? Okay, in that case,
sir,
it was
no,
a
sir,
nice
Alok Majumdar sir is, sir, he is not well, sir.
Okay, so it was a nice session, but only the problem was time constraint, and initially the fellows participation was less, but we would likely to improve further on. So Dr. Saha, can you go ahead for the next session? It is over now. To conclude, I should thank everybody, all the faculty and the audience, and it is members present is more than 330 now. That is a commendable thing. Okay, over.
Now we are moving to our next session, which is arrhythmia, what we need to know. And may I request the chairpersons and the moderator to proceed the sessions. The chairpersons are Dr. C. Narsimhan, Dr. Rabindranath Chakraborty, Dr. Monoranjan Mondol, and the moderators are Dr. Dipankar Mukherjee and Dr. Muhammad Azizul Haq.
Good evening. Am I audible?
Yes.
Jayanto? Yeah. Good evening. Jayanto, I must thank you for giving me this opportunity. And we have with us the speaker, Dr. Bera. I think he has joined. He is the first speaker on this in this session. He will be Dr. Reboboto Bera, electrophysiologist from R.N. Tagore Hospital. And he will be talking on the arrhythmia class. You may say that he will take a class on arrhythmia, how to evaluate arrhythmia ECG. So that's the most important aspect of anybody in the cardiology field, to learn how to do the arrhythmia ECG, and particularly in the ED emergency room, emergency department. So he will be talking, and we have with us the chairperson, no less than Dr. Narsimhan, and our two stalwart from Kolkata, Dr. Ravin Chakraborty and Dr. Monoranjan Mondol. Are they here, or I don't know, I don't find their face here. So I will request Dr. Bera to start with his deliberation on arrhythmia ECG.
Thank you so much, sir, and thank you, Jayanto, for the opportunity. I'll be just immediately sharing my screen, and it is a pre-recorded talk. Hope it runs well. I'm here also. If there is any issue, I can actually start the thing. Sir, can you see my screen, sir?
Yeah, screen is well seen.
Okay, sir.
We have got 20 minutes time and 5 minutes for discussion. Okay.
Yes.
Okay.
It will be done in his recorded talk, so it will be done in 20 minutes.
20 minutes, we'll be focusing only on tachycardia ECGs and the sinus rhythm ECG in patients who are having a tachycardia. We'll not discuss about tachycardia so that we can focus only on the specific topic. So whenever we are analyzing a patient with a tachycardia ECG, what we need to see? First of all, we need to carefully look whether it is regular or there is a slight irregularity. Very important. Sometimes the P wave is not very discernible, so you need to look for it to find out the P wave, whether it is present and what is the P wave morphology. We'll be also looking into few of the subtle clues of diagnosing what exactly the tachycardia mechanism is. We'll directly go into the case-based discussion. So this is one of a patient with 65-year-old lady who was having episodic palpitation and was treated as atrial fibrillation because she had multiple recorded ECGs showing clear atrial fibrillation, and she was on amiodarone and warfarin. And despite the medications, she was having continuous recurrences. In one of the recurrence of tachycardia, we could record this ECG, which otherwise looked like very regular. And if you look carefully, there is a R prime, what you can see here at the end of the V1. But sometimes, means if you have a R prime at the end of V1 or pseudo S, you always think about a AV nodal reentrant tachycardia. But sometimes many of the normal patients also can have such notch. So in this patient, keeping a diagnosis of AVNRT in mind, we tried adenosine, and it was successful in terminating the tachycardia. And this is what we see after the termination. So there is no notch at the end of the QRS complex in V1, which was present in the tachycardia. So now we are pretty sure that it was actually the P wave which was evident as R prime, and the patient was having indeed AV nodal reentrant tachycardia. So the learning from this case was, this is also described in literature, that many patients with SVT can degenerate into atrial fibrillation. This is more so common in little older age group. And if you actually treat the root cause of the SVT, we can get rid of the atrial fibrillation in many of those patients. This patient underwent a slow pathway modification for AV nodal reentrant tachycardia, and she's doing well over the last 4 years of follow-up. Coming to our next patient, who was a 28-year-old gentleman with a normal echocardiography and episodic palpitation. So this patient also has a narrow QRS regular tachycardia. What is distinctly different from the previous patient is a significant STT changes in, especially in the inferior leads. So, are you thinking of a coronary artery disease in a 28-year-old gentleman who didn't have any risk factor for CAD? So, just to mention that these kind of STT changes can be very well seen in patients having AVRT, atrioventricular reentrant tachycardia. This happens because of either of the two reasons. One is sometimes the P wave is hidden in this T wave, and that becomes a negative or inverted P, creates this ST depression in inferior leads. The other reason is called memory T wave sign, which I'll be discussing in subsequent slides. So in this patient, again, adenosine was attempted, and he was cardioverted to sinus rhythm after adenosine. But distinctly, again, from the previous patient, we can see a delta wave, a very short PR interval suggestive of pre-excitation. In fact, the patient had accessory pathway, which was updated successfully. Now, when you have such STT changes in patients with SVT, as I just described, that you should always think or keep in back of the mind that the patient might have a manifest pre-excitation, or they can also have a concealed accessory pathway. So you don't know, before you terminate the tachycardia, you don't know whether the patient has a manifest pre-excitation like this patient had. So most of the time we are successful and we are fortunate enough so that the adenosine is uneventful. But very, very rarely what happens is that adenosine is actually can induce atrial fibrillation. And in patients who have pre-excitation or gross WPW syndrome, if they develop atrial fibrillation in patients who have a very short accessory pathway effective refractory period or APERP, they can in fact develop a atrial fibrillation with rapid conductive rates, and on a given day they can even develop ventricular fibrillation. Rarely, if in presence of a rapidly conducting accessory pathway, the patient develops atrial fibrillation. So the learning point from this case is any patient with SVT, if you are thinking of accessory pathway mediated tachycardia, always keep your defibrillator ready when you are giving adenosine. Although majority of the times we are fortunate to terminate the tachycardia without any incidents. So coming back to our own patients, once we ablated the accessory pathway, we can see the delta wave has disappeared and there is normal PR interval. But what is noted here is significant T wave inversion in lead 2, 3, and AVF. Why this happens? Have we done any damage to coronary artery of this patient? Actually, no. So what happens? This is called memory T wave sign. This patient was, before ablation, this was his ECG. And before ablation, the QRS complex in lead inferior lead 2, 3, and AVF was clearly negative. And this abnormal depolarization was present since birth, almost since birth. So once you normalize his depolarization, the 2, 3 AVF become positive. But then the repolarization abnormality keeps a memory for a few days to weeks, which can persist. So always keep in mind that patients with WPW syndrome or patients with VT, when it is sustained for some long time, they can have memory T wave signs even after resolution of the tachycardia or resolution of the pre-excitation. Coming to our next case. So this patient was a 40-year-old lady with recurrent long episodes of tachycardia, rates going up to 150 to 160 beats per minute. And she was actually multiple times diagnosed as panic attack, anxiety disorder, sometimes labeled as inappropriate sinus tachycardia, and was given ivabradine without any effect. So when you look at this ECG, in fact, if you look at the limb electrode, it looks like it's a sinus tachycardia. The PR interval appears normal, and it is just a sinus tachycardia. But when you call a ECG as a sinus tachycardia, you should look for P waves in all 12 lead. If you look here in the inferior leads, the P waves are completely negative in all 2, 3 AVF. And this tells you whatever may be the cause, it is not a sinus tachycardia. So this has to be an abnormal rhythm. Generally, we call it a long RP tachycardia. That is, the R to P interval is longer than the PR interval. Even sinus tachycardia is a long RP tachycardia, but with abnormal P wave, especially lead 2, 3 AVF negative, it cannot be a sinus tachycardia. Then what are the differential diagnosis? It can be atrial tachycardia from the lower right atrium or coronary sinus os. It can be AV reentrant tachycardia, but as I said, the RP interval is long. So if it happens along RP tachycardia, it happens with a slowly conducting accessory pathway or PJRT. It can also happen in AV nodal reentrant tachycardia in the atypical variety. Coming to our next case is a 43-year-old gentleman with a mild palpitation, dyspnea and exertion. He had a prior history of closed mitral valvotomy, and there is recent decline in the ejection fraction to 45%, which was earlier 55 to 60%. And first look on the ECG looks like a sinus rhythm with a little long PR interval. Should you stop here, especially with this background in mind? So if you look on the ECG minutely, actually this is called Bick's rule, that whenever you find a P wave exactly between 2 RR interval, you should always think whether we are missing any alternate P wave which is hidden in the QRS complex. Sometimes the QRS complex is not well seen. Occasionally, the P waves are seen in some of the leads. Like this case, the P waves are well seen in V1, V2, although not well visible on the other limb electrodes, other 10 electrodes. So this patient indeed had an atrial flutter. And what is the clinical implication? There's tremendous clinical implication. This patient, if we misdiagnose it as sinus tachycardia, we will be missing the opportunity to give him a more needed or must needed anticoagulation which he needed. In fact, this patient required anti-arrhythmic drugs as well, and after giving amiodarone, we were fortunate enough to record one of his ECG which showed atrial flutter with 1:1 conduction, and after anti-arrhythmic drug, his atrial flutter got controlled and his ejection fraction also normalized. This is one of the relatively easier ECGs where you can see clear flutter waves, but this is clear when you have a 4:1 block here, as you can see. Sometimes with 2:1 block or 1:1 conduction, it is very difficult to discern the P waves. So this is called typical atrial flutter with P waves positive in V1 and sawtooth predominantly negative in the inferior leads. The beauty of this tachycardia is this is very, very well amenable to ablation therapy, and the results, long-term results, are pretty good in contrast to atrial fibrillation. Coming to one of our case, this patient was a 25-year-old young gentleman with a ASD surgical closure 20 years back. Of late, he has presented with episodes of palpitation, but moreover, he has a significant dyspnea and exertion, almost class 3 to ambulatory class 4 dyspnea, and the ejection fraction is just 30%. So when you looked at the ECG, in fact, this patient was treated as sinus tachycardia again with evaporatin, etc. But when you look at the ECG, if you blind yourself, just blind yourself with the QRS complex. If you blind them, you can see there is a sawtooth pattern very well seen in the lead, inferior lead, especially lead 2, 3 IVF. And this patient was again treated with ablation, radiofrequency ablation. After that, the patient is in sinus rhythm for last 2 years, and dramatically his clinical profile changed within 2 to 3 months. His ejection fraction normalized, and he is in class 1 to 2 now. Switching gears to some of the wide QRS tachycardia. So this 35-year-old gentleman who is diagnosed of hypertrophic obstructive cardiomyopathy and was referred for evaluation of occasional vertigo. Now, the physician who was treating him has picked up that there is a run of wide QRS tachycardia intermittently, and has been referred for evaluation and implantation of ICT. Now, with the given picture of diagnosed hypertrophic cardiomyopathy and family history, but no other risk factor otherwise, but with this possible VT, whether he should undergo ICD implantation. Now, this is the rule number 1. For a white QRS tachycardia, if you compare with the sinus rhythm, here you can see the sinus rhythm ECG, and the tachycardia ECG is exactly same morphology as well as axis. Although we have only 2 channels available, but whatever those 2 channels we have, the QRS morphology remains exactly same during tachycardia as well as sinus rhythm. This essentially rules out ventricular tachycardia except some rarer variety. And actually this patient had paroxysmal atrial fibrillation, intermittent atrial flutter. So he needed more of an oral anticoagulation and not an ICD. He's not a candidate of ICD. He's doing well for more than 5 years now. Now this gentleman, coming to our next case, this 50-year-old gentleman with episodic palpitation and normal echo. So we can see that there is a white QRS tachycardia. Whenever there is a clear white QRS tachycardia, first job for us is to classify is a RBBB morphology tachycardia or LBBB morphology tachycardia. So for that, we need to look at V1. If you look at V1, this looks like a RBBB morphology tachycardia. And that immediately tells you that the origin of the VT is most likely left ventricle. So any of RBBB morphology tachycardia, the origin is left ventricle and the vice versa. So obviously this one differential diagnosis is VT. Is there any other differential diagnosis? Obviously, yes. The second differential diagnosis is antidromic tachycardia or pathway mediated tachycardia. The third one is SVT with aberrancy. We need to differentiate between them because the management often differs. So SVT with aberrancy can be essentially ruled out if you look at the QRS morphology is not a typical RBBB, and moreover there is a positive concordance in V1 to V6. So this patient had annular VT which is ablated. But how you can change the diagnosis? This is VT and not antidromic tachycardia. Often they are very difficult to differentiate from the tachy ECG. Now, after cardioversion, when you look at his ECG, 12-lead ECG, there is no gross pre-excitation of the ECG. That tells you that the patient doesn't have any WQW syndrome. So obviously diagnosis of exclusion, he has a ventricular tachycardia and not a pathway-mediated tachycardia, except a rarer variety like mine. Coming to our next case is a 42-year-old female with recurrent palpitations and normal echo. And this is the ECG morphology. As you see here, the white QRS tachycardia, the V1 is negative. That means it's an LBBB morphology tachycardia. That localizes your VT. If it is VT, that localizes your VT from the right ventricle. Now, if you look at inferior leads 2, 3 AVF, they are strongly positive QRS complex. That means the vector is from above downwards. So this tells you the localization of the tachycardia is right ventricular outflow tract. So from the morphology itself, if we can localize to right ventricular outflow tract, we are pretty sure that this patient is having an idiopathic VT, which is supported by a normal echo. RVOT is one of the area where the triggered VT are very, very commonly noted. And if you have such kind of morphology, generally they are idiopathic VT unless the echo is up. And these patients are amenable to drugs as well as radiofrequency ablation if beta blocker or calcium channel blocker fails.
Dr. Bera, you have got 1 more minute time, okay?
35-year-old gentleman, episodic palpitation. He had a pre-symptom in addition to palpitation and a normal echo. So the ECG showed the LBBB morphology tachycardia, and if it is a VT, then it is coming from the right ventricle. It could be a pathway-mediated tachycardia. In that case, the pathway is on the right side. In contrast to the RVOT VT, if you see the inferior leads, there is negative QRS complex. That tells you this is not in the RV outflow tract, rather it is the RV inferior wall, which is not a common site for idiopathic VT. So despite this patient having a monomorphic VT, we did a cardiac MRI, which actually picked up a ARVC. So this patient, although the echo was normal, when cardiac MRI was done, it picked up a structurally abnormal heart, and he was a candidate for ICD implantation, not for ablation. Obviously, he needs antiarrhythmic drug to prevent the onset of ventricular tachycardia.
Dr. Bera, sorry, your time is over, huh?
Is it over, sir?
Yeah.
Okay. I thought it is a 20-minute presentation. It's 17 minutes now. I'll stop here.
Okay. You continue with 3 minutes more.
Yeah.
You continue with 3 minutes more.
Okay. Thank you, sir.
It's very nice presentation. You continue.
We'll finish in another film.
Another question, almost similar ECG. RBBB morphology, northwest axis. So there's no doubt about VT. Obviously, the AVR is also positive and P6 is also completely negative. This also again points towards VT rather than SVT with aberrancy. But what is noticeable here, there is a Q wave in V1 to V3. And in fact, if I give you the history, the patient has a 58-year-old gentleman, history of AMI 5 years back. He has an EF of 45% with a regional one motion abnormality. So this patient, although it appeared like a fascicular VT, the history in background and also the key waves present in the tachy ECG tells you this is a scar VT near the fascicle, near the septum. So this is a structurally abnormal heart with VT. So we shall advise him ICD rather than ablation. Drugs can be given after ICD implantation. This is a story of an 8-year-old boy with recurrent loss of consciousness while playing in school, and he was extensively investigated, and ECG, EEG, echo, everything was normal. So what do you suggest for him? And if we study Fleckner challenge to look for any aggravation of Brugada or a cardiac MRI. In fact, all three was done, which was negative. So the only thing we actually probed into the history, which told that the patient has lost his elder sister who was playing in school, and that gave us the clue that this patient might have some exertional arrhythmia. We advised for a TMT, which revealed the diagnosis of CPVT, capillary polymorphic ventricular tachycardia, which is again a treatable entity, very well treatable entity. Coming to a last case, so this patient is a young lady of around 45-year-old lady with recurrent episodes of palpitation and dyspnea and exertion. There is a clear ventricular tachycardia, white QRS tachycardia, there is VA dissociation. So there is no doubt about VT, but what is unique about the VT, you can see there is significant RR variability in this rhythm strip, and also there is subtle variation in the QRS morphology. So all these things suggest that the patient might be having an automatic VT or inflammatory VT. So when the patient came back to sinus rhythm, you can notice that there is a fractionation in some of the leads. Lead 2 and AVF shows a fractionation. And this tells you that the patient, although the echo may be normal, the myocardium is not normal. So this is one of our papers showing that in patients, they can even present with mimicking outflow tract ventricular tachycardia. And when you revert them to sinus rhythm, there are subtle clues which can tell you that the patient is not having an idiopathic outflow tract VT. And few of them are fascicular block or bundle branch block, fragmented QRS complex, and no low QRS amplitude on the SURF12. We still think about ventricular tachycardia. It could be a septal VT rather than a SVT. So the company it keeps is very, very important. White QRS tachycardia, compare a tachy ECG versus baseline. If the baseline doesn't have any pre-excitation, you are quite sure that the patient is having a ventricular tachycardia. And although VT doesn't always mean ICD, many of the structurally normal heart VT can be treated with medication and ablation. Thank you so much. I'll be indebted to both my mentors forever. Thank you so much for your kind attention.
Thank you, Dr. Bera. Very lucid and very nice presentation. Actually, you have covered all the practically faced situation and to one or two special example. So we can have some talk with this and some discussion. I think Dr. Narasimhan's face was seen and Dr. Yash Lakhondwala's face was also seen. If they are there, Anjanlal Dotto is there, Dr. Anjanlal Dotto is there on the screen. Anjanda, do you have anything to put to before us regarding the ECG session? Anjanda, am I audible?
You are audible, sir.
Can we discuss
There is
before the
unmuting.
at the end of the session?
Okay, discussion better at the end. So,
I
Devabhrata,
have only 2 points to make.
Yes, sir.
One, I saw an ECG with a right bundle branch block pattern, white QRS, but the axis was right axis. Now, for all practical purpose, when you have a right bundle branch block with right axis, before you jump to the diagnosis of VT, you must look into the other factors of VT, because it may be LV outflow tachycardia VT, or it may be true aberration of RBB with a right bundle branch block. What is your comment on that? And second, in a case of sinus tachycardia, or for that matter, narrow QRS tachycardia, ventricular rate of 150 is a dicey figure. That should be kept in mind, because that is commonly represents an atrial flutter of 300 per rate, 2:1 heart block. So whenever we get in atrial tachycardia, the patient is not very bad hemodynamically or clinically, but the rate is 150, and that is a dicey figure. We must keep in mind the possibility of atrial flutter with 2:1 heart block. A very practical approach of diagnosing.
Thank you so much, sir. Thank you for your comments, sir. Both the comments are very, very valid and well taken. Coming to your second point first, that any as you said, with the ECG looking like a sinus tachycardia at a rate of 150, always keep in mind that it might be a atrial flutter or atrial tachycardia of rate of 300 and 2:1 AV block. In fact, not only 150, any heart rate, something between 100 to 150, you should keep in mind, especially if the patient is on some antiarrhythmic drugs or beta blocker or amiodarone. Coming to your first point, obviously, yes, sir. If any patient has a RBB morphology tachycardia, your job is to differentiate between all three, either a VT or a SVT aberrancy or accessory pathway mediated tachycardia. So I have shown a couple of examples that if you have your, let's say you told about RBB morphology tachycardia, if the 12 lead ECG shows that the RBB morphology is like a typical right bundle of any patient, then most likely it is of a SVT with aberrancy. If it is not matching with the garden variety RBBB, what we see every day, it is most likely not a SVT with aberrancy. Thank you for your
small R followed by long R.
Yes, sir.
Hello. Suchit joined?
Yes, I think he was there.
Hello.
Oh. No, I cannot see him in the list.
Dr. Suchit Majumdar or Dr. Shomik Basu?
Ajijul is sitting idle.
Yes.
Silent.
Ajijul sir, any comment from your side, sir? You have to unmute, sir, yourself. You have to unmute yourself, sir. Hawk, sir.
Yeah.
Yes, sir.
Very good presentation. Very good points to learn. Actually, it's very good.
Thank you, sir. Thank you, sir.
Why everybody is silent?
What about Dr. Deepak, please continue the program.
What about chairperson?
Dr. Deepak Mukherjee, please continue the program.
It has not joined actually.
None of them have joined.
Dr. Deepankar Mukherjee, you unmute yourself first.
And you continue.
Okay, so Anjanda, you are here, so you can place your
I'm not conversant with the program very much. Minal is there. Minal can continue. You can continue.
No, we have got our program, subsequent program, but on this ECG, we have now plenty of discussion. We can continue the discussion on the ECG. I think Jayanto is, Dr. Jayanto.
I have the other speakers, Shomik Basu and Dr. Suchit Majumdar, to speak. Have they come? Have they joined?
Yes.
Yes, Suchit has joined.
Suchit has come. Suchit, please continue. Please start.
Okay. I will share my screen. Yeah. Share content. Screen. Start broadcast.
No.
Okay. So is it visible on the screen?
Yes.
Okay. So thank you, organizing committee of the CSI West Bengal 2020 conference, and especially thank you, Dr. Jayanta Saha, for giving me this opportunity for speaking in this conference. So my topic today is basics of EP study. I will be considering, because it's a vast topic, because EP study comprises the Brady as well as Tacky part. So I think because most of the people are dealing with Brady initially and then they are going into Tacky, I think we will start with Brady and go with the easy things. And maybe if time permits, we can show 1 or 2 cases of Tacky and discuss along with the cases. So most important, we have to understand why do we need EP study. In bradyarrhythmia, the
Is it audible now?
Not audible.
It is not audible.
Technical assistants, please look into the matter that Suchit's voice is not audible. Please have a discussion him over phone and instruct him. Is there Mr. Raghu? I am Dr. Dasbiswa speaking. Or any of his technical assistant.
Yes, sir. Yes, sir. Please.
Just give some technical support to Dr. Suchit Majumdar.
He is not being audible.
No, sir. Actually, I am also trying. He's there. He's there in the meeting. But I think he's lost his connection.
So you may please call him and let us know what is the situation.
Yes, sir.
You can call him and advise him.
Sure, sir.
পরের টকটা আগে করুন।
স্পন্দন বাবু কি বলছেন?
Next টকটা তাহলে হোক, যদি ওনার মানে if he has lost his connection, then we can switch over to the next talk. Request him to ensure his connection.
ঠিক আছে তো? ছন্দপতনের সময় সব ঠিক আছে তো?
সব ঠিক আছে।
Soumik Basu is there? Soumik Basu? Dr. Soumik Basu is there? Soumik, are you ready?
Next to Basu led. Mr. James Sahab. James Sahab.
Yeah, can I have that number, doctor number?
হয়ে গেলে লগইন বলিস। Dr. Mukherjee.
Yeah.
The Shomik cannot log in. He's trying to do that, so we can go for the next another program that is a primary pulmonary hypertension. You can stay back.
Okay.
Okay.
So, okay, you just discard. You just
He's not
call them.
Can I have his? Yeah, you can take it.
Dr. Kuntal Bhattacharya will be talking about primary pulmonary hypertension.
Yeah, Jayanto, call the other chairpersons also of that session.
That must be called.
Dr. Achut,
But Somik has joined, I think.
Dr. Kanak Kumar Mitro and Dr. Raja Rai.
Shomik has joined. Shomik has joined.
3987. Okay.
You can try with Shomik also.
Okay.
Shomik looks like Shivananda.
Saumika, next speaker. Access Ichna.
What that tech is doing.
Somebody can start the program. Either Shomik or Dr. Kuntal Bhattacharya.
Shomik is unmuted. Why? Shomik, please. Shomik is muted.
Shomik?
I cannot see
I don't
Shomik.
see him.
I cannot see him.
So let us start with Dr. Kuntal
Kuntal.
Bhattacharya. We can
Yeah,
continue. We can bring in Shomik later on.
Sir, there is no answer from Dr. Suchit. I called him, doctor. There is no answer.
Can I start going?
Sir, should I start then?
Sir, are you facing any issue?
Sir, this is Dr. Kuntal Bhattacharya, faculty from Medical College. Sir, should I begin my talk?
Yes, yes. You, Kuntal, you start.
Okay, thank you.
Yeah.
Thank you.
Sir, I'm talking from the back end.
Sir, I'm audible, I hope.
You are audible but cannot see anything. I cannot see anything.
Sir, we can see your document folder. Kindly open your PPT.
I've already opened it, I think.
You go to the next slide.
Yes, there is a problem, I think.
Can we see the slides, sir? No?
So you first open up the slide, then you share the screen.
Okay, okay.
You first open up the slides.
Now, sir?
Yeah, it's visible.
It's visible, sir?
Yeah, you carry on now.
Okay, thank you, sir. Sir, topic of discussion is primary pulmonary hypertension current management. The definition of pulmonary arterial hypertension has been updated in the 6th World Symposium. Previously, the cutoff was a mean pulmonary artery pressure more than 25 at rest and more than 30 with exercise, now than 20 millimeter of mercury. Precapillary pulmonary hypertension is called pulmonary arterial hypertension, and here the pulmonary artery wedge pressure will be less than 15, but PVR will be more than 3 Woods unit. The updated clinical classification includes 5 major groups, of which the first group is our group of interest. It includes the idiopathic pulmonary arterial hypertension, heritable pulmonary arterial hypertension, which have an indistinguishable clinical presentation. And associated with these two entities, there are the drug and toxin-induced PH and PH associated with several entities like connective tissue disorders, HIV, portal hypertension, congenital heart disease, schistosomiasis, and also PVOD and PCH, which are pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis. So primary pulmonary hypertension is essentially idiopathic PH, but heritable PH also presents in a similar fashion, except that it has got a family history of autosomal dominant inheritance with 20% penetrance. It has got a distinct female preponderance, and a presence of BMPR2 gene mutation portends a bad prognosis. The pathogenesis will include vasoconstriction, endothelial dysfunction, smooth muscle proliferation, thrombosis, inflammation, everything. These are historical interest, Heath Edwards classification, but up to grade 3, there are reversible changes, and after grade 4 onwards, their changes become irreversible. So how to diagnose? The clinical presentation in the initial phases is only fatigue and dyspnea, but gradually edema or angina, and in the later stages, dizziness and syncope ensue. The signs include a prominent A-waving JVP, loud P2, which is often palpable, TR murmur, parasternal impulse, and RVS4. Later on, when the signs of RV failure are there, then the patient has a very poor outcome. And we have to exclude left heart disease, lung disease, thromboembolic pulmonary hypertension, congenital heart disease, and drug history, mostly the anorectic agents and dasatinib. So the diagnostic evaluation will revolve around establishing the diagnosis, exclude other conditions causing pulmonary hypertension, and determine the severity. To establish the diagnosis, ECG and chest X-ray are basic investigations, but echocardiography and right heart catheterization are the major investigating tools which are employed for diagnosis. The ECG is neither sensitive nor specific, but if changes are present, then P pulmonary, right atrial enlargement, RVH, RV strain, RVB, and occasional or prolonged QT, which indicates severe disease, these may be encountered. The chest X-ray, we all know there will be enlarged main and hilar pulmonary arteries with peripheral pooling, and RVH can also be appreciated. These are the classical ECG and X-ray images. Echocardiographic estimation of pulmonary artery systolic pressure is most frequently done from the TR velocity, but the right atrial pressure estimation from IVC diameter is often fallacious, and that is why the PASP by echocardiography may be different from the right heart catheterization derived pulmonary artery pressure. The assessment of RV enlargement and RV systolic function is also very important. The assessment of the septum when it flattens, that is also required. Other important things are the right atrial area more than 18, indicating enlargement, dilated pulmonary artery, acceleration time of RVOT, and missed systolic notch in the pulsed wave RVOT Doppler, as well as the pericardial pulmonary regurgitation. Pericardial effusion, if present, indicates a poor prognosis, and the upcoming modalities are RV free wall strain and RV ejection fraction determination by 3D echo. These echo images are showing a severe TR, dilated RA-RV, the pushing of the interventricular septum and interatrial septum towards the left side, and also presence of pericardial effusion. So it's a patient in a late stage. Echocardiographic probability score of pulmonary arterial hypertension has been developed. So if the TR velocity is more than 3.4, then the probability of PH is quite high. And if it's 2.9 to 3.4 without any other echocardiographic sign, or less than 2.8 with other echocardiographic signs of PH, then it's intermediate. So right heart catheterization is reserved for intermediate echo probability and high echo probability. And these patients are, and if they undergo right heart catheterization in an expert center, then the morbidity and mortality risk are not very high. Measurement facility is available, and multi-parametric risk stratification model is used based on all these findings. So this is the multi-parametric risk stratification. High risk indicates more than 10% 1 year mortality risk, and they will have a low 6-minute walk distance and a very low oxygen VO2, peak oxygen consumption VO2, and the NT-proBNP value will be very high. and it will be functional class 4. So the natural history, median survival is very low and late, and no definite cure is available. So the screening is done for gene carriers and family member of hereditary PH to treatment.
Sir Kishore again from backend. So Dr. Kuntal Bhattacharya also having a network issue. So we lost him again.
Sir, am I audible and slide is visible or not?
Yes, sir. Yes, sir. Please go ahead.
Okay, okay. I don't know up to how much people could be able to see my presentation, so I don't have the idea. I hope everybody has seen the diagnostic part.
Sir, because of your network issue, can I stop your video so that we can hear your audio perfectly?
Okay, no issue. Whatever is necessary, you do it.
He's both audible and visible now.
Yeah, yeah. Please go ahead now.
Okay. So the coming to the treatment, the pulmonary arterial hypertension patient is first subjected to the vasoreactivity test, and if found vasoreactive, then calcium channel blocker in high dose therapy is initiated, and if found not vasoreactive, then we have to stratify as a low or intermediate risk or high risk. For there are two options, either oral monotherapy or initial oral combination therapy. And in high risk, we have to start with combination therapy with IV prostacyclin analogs. And if the response is inadequate, then sequentially we have to add up one or more drugs. And even if after that we find an inadequate response, then we have to select the patient for a lung transplantation. The general measures which have to be taken are just like heart failure, sodium restriction, smoking cessation, avoidance of pregnancy, updation of the vaccination status, and graded moderate exercise, avoiding excess of fatigability. If the patient needs to fly and is in an advanced functional class or having a PaO2 less than 60, then in-flight oxygen therapy has to be arranged. And if surgery is contemplated for some reason, then epidural anesthesia is preferred to general anesthesia. The supportive measures which need to be included, which need to be undertaken, are long-term oxygen therapy if the PaO2 is low, diuretic treatment if there is systemic venous congestion, anticoagulation for primary PH, and correction of anemia and iron deficiency.
Okay.
The drug therapy, the timeline dates from 1995 and up to 2015 when Selexipag has been approved. So what is the vasoreactivity testing? It's done during right heart catheterization. Inhaled nitric oxide 10 to 20 parts per million is the most frequently used agent, and an acute response indicates a decrease in mean pulmonary artery pressure by more than 10 millimeter to achieve an absolute value of MPAP less than 40 with an unchanged or increased cardiac output. Now, if this acute response is present, then the patient is a candidate for calcium channel blocker therapy, which is done in high doses. Verapamil is not used. Other than that, nifedipine, diltiazem, and amlodipine are used. And there is another definition called long-term response, which is assessed after 1 year on calcium channel blockers if the patient remains or gets converted to a functional class 1 or 2 and there is sustained hemodynamic improvement. If there is no response in 3 to 4 months, then pH-specific therapy is planned. The pH-specific drugs target mainly 3 pathways. One is the endothelin pathway, which is targeted by the endothelin receptor antagonists. One is the nitric oxide pathway, which is targeted both by phosphodiesterase 5 inhibitors as well as soluble guanylate cyclase stimulators, and prostacyclin pathway targeted by prostacyclin analogs and IP2 agonist selexipag. These are the important clinical trials, and meta-analysis of all these RCTs have showed that in low to intermediate risk patients, pH-specific monotherapy improves mortality, exercise capacity, functional class, and hemodynamic status compared to placebo. But combination therapy does improve exercise capacity, functional class to some extent. However, it doesn't improve mortality and creates more adverse drug reactions. So combination therapy is used with caution. So how to assess these patients and how to follow up? Clinical examination, functional class assessment, ECG, 6-minute walk test, and basic lab parameters are assessed at every visit. ABG right heart catheterization, they are assessed every 6 to 12 months or earlier if there is any worsening or change in treatment regime, and cardiopulmonary exercise testing every 6 to 12 months or earlier in case of worsening if the facility is available. The goals of therapy are prevention of disease progression, improve survival and quality of life, improve the functional class to 1 or 2, and maintain good RV size and function, reduce the RA pressure, improve the cardiac output. The 6-minute walk distance should be more than 380 at least, and VO2 max should be more than 15. Sometimes there is a pH crisis. In that case, patient is an ICU management. We have to manage the potential triggers, optimize fluid balance, and reduce the RV afterload. We have to increase the cardiac output and perfusion pressure. If ventilation needed, then low tidal volume, low PEEP is required because it might also increase the PVR. Inhaled nitric oxide is a therapeutic option, mostly in ventilated patients, and in refractory cases, atrial septostomy and RV assist devices in the form of tandem heart or RV impeller or venoarterial ECMO. And in the very refractory cases, we have to go for lung or heart-lung transplantation. Many drugs are in the pipeline like tyrosine kinase inhibitors, bardoxolone, methyl, tocilizumab, rituximab. They are in phase 2 or phase 3 trials. So take-home message is primary pulmonary arterial hypertension is essentially a diagnosis of exclusion. Echo right heart catheterization are the mainstay of diagnosis. 6-minute walk distance and functional class assessment are mandatory at every visit. Early initiation of treatment offers a survival benefit, and pH-specific drugs have improved the prognosis and delayed the necessity of lung transplantation, which is reserved for only drug refractory patients. Thank you for a patient hearing.
Thank you, Kuntal.
Thank you, sir.
For covering a topic of more than 1 hour in a matter of 12 minutes. We have covered almost all aspects. Without going into the details, you have given a brief outline of the important facets of management of primary PAH, which is very essential.
Thank you, sir. You have guided
I
me
would
a
like
lot.
Since this is a cardiology update and many of our postgraduate students are listening to this program, I would like you to elaborate a little bit more about the right heart catheterization in these primary precautions that we need to take in these patients compared to other normal patients. Because you know these patients are much more sicker than the general usual patients that we take up for either angiography or catheterization.
cardiac catheterization should be done in very experienced hands and in centers who are very well conversed with this process, because these patients sometimes they have overt right ventricular failure, and they also have a very fibrotic RV wall, and sometimes the wall is also fragile. So there is also risk of perforation, and sometimes the patient might go into hemodynamic instability. Moreover, to exclude a left heart lesion, sometimes we include a 500 ml of bolus fluid administration within the procedure. But this has also needs to be done with caution, because if the RV pushes the septum much more towards the LV, then there can be a diastolic dysfunction of the left ventricle, which can precipitate a failure on table. So these things have to be kept in mind before proceeding for right heart catheterization.
Absolutely. And
there is one
difficult
just a minute comment. There is one issue in right heart catheter in pulmonary hypertension, is the likelihood of arrhythmia. It's a very common. It could be a serious arrhythmia of RV.
And these patients are very prone to develop these arrhythmias also.
Yes, yes, sir. Right.
And the most difficult part that we encounter in doing a right heart catheterization for this patient is that the availability of the vasodilators, to do vasoreactive testing.
Hello, Arnab. Dr. Arnab Datta? Somik Basu, please continue your program.
ফুল স্ক্রিন করবো না, হ্যাঁ এবার শেয়ার করবো, করে এইটা পাওয়ার পয়েন্ট এইটা করবো না Hello, am I audible?
Yes, sir. You are audible.
Hello, good evening.
You are both audible and visible. Please
Thank
start.
you, sir. Thank you, sir. So today I'll be talking on the topic of anti-arrhythmic drug and choices. But before we talk about this issue, I think we'll have to do a very brief recollection of our both the how action potential is generated in the different cells of tissues of the heart, as also how arrhythmias are basically generated. With the advent of this ICD therapies, of course, there has been a paradigmal shift in the management of ventricular arrhythmias particularly, but as we all know that it is not a very affordable solution for everybody, nor is it logistically feasible to do it at all places. So the need for anti-arrhythmic drugs is very much still there, and unfortunately anti-arrhythmic drugs have only an efficacy between 30 to 60%. So the need for newer drugs arises at all point of time. So what is important is that we all know how the normal impulse is generated, but conduction can also occur between myocardial cells when a cell is depolarized and adjacent cells get depolarized, and that is how arrhythmias can go on, the circuit can go on happening, and that is where we need to have our drugs to be able to block the action. So as we recollect that the action potential of the normal atria, Purkinje and ventricle consists of 5 phases, and that of the nodal tissue is basically the 3 phases. The way it is very important to visualize and remember this slide, because this is how the classification of arrhythmic drugs are made, and also how the mechanism of action so that we can understand at what places to intervene. So phase 1 is because of sodium influx. Hello. Phase 1 is because of your sodium influx. Phase 0 is because of your sodium influx happens to cause the fast upstroke in this diagram. And phase 1 is because of partial depolarization due to rapid efflux of potassium. The plateau phase is because of calcium influx in phase 2. Then phase 3 happens then due to depolarization and due to potassium efflux, and then you have your resting membrane potential. In comparison to that, in your nodal tissue, you have the 3 phases. The phase 0 because of calcium influx, the phase 3 potassium reflux, and phase 4 where there is both an influx of sodium and calcium and there is potassium outflux. And the pacemaker cells are unstable membrane potential. Another definition which we have to keep in mind is the effective refractory period, that is also called the absolute refractory period, in which the cell won't be excited, and it takes place between phase 0 and phase 3. The action potential, the cardiac action potential are modulated by both the sympathetic and the parasympathetic nervous system. Opposite in direction is the action on the cardiac action potential. If you look at the diagram, the broken dotted line is the one which is the normal action potential. Your blue is the vagal action and the red one is the sympathetic action. The sympathetic increases the cyclic AMP, increases the calcium and sodium influx and decreases your potassium outflux. On the non-nodal tissue, it causes all these actions causes a more rapid depolarization and more forceful contraction, and your pacemaker current is enhanced, and there is increased phase slope 4 in your pacemaker cells, which leads to a more increased rate. Opposite things happen when your parasympathetic system is predominantly activated, and then although the rapid depolarization and forceful contraction happens as in non-nodal tissue, by the sympathetic system, your pacemaker current is suppressed. Arrhythmias basically are generated by either disorder in impulse conduction and rate, or in the origin of it, from place where it's originated. Although now we classify arrhythmias mainly as narrow QRS and wide QRS, it is still important that we go back to the basic and classify arrhythmias still as when they arise from the atria, the SA node or AV node, when it's called supraventricular, or when it arises from the ventricle and it's called ventricular. This is important because it helps in using the terminology as to which drug to use. As supraventricular arrhythmia, we use this drug, or in ventricular arrhythmia, we use another drug. The mechanism of action of arrhythmogenosis can be either an abnormal impulse generation, which can be because of an automatic rhythm or triggered activity. Automatic rhythm can be because of enhanced normal atomicity or ectopic foci, and triggered rhythms can be because of delayed or early after depolarization. You can have your abnormal conduction and like conduction block, which results in various degrees of heart block that we know, or it can be a re-entry. Or it can also happen because of an abnormal anatomical conduction, where you have something like an accessory pathway that will be leading to a re-entry rhythm. Action of drugs, basically, in case of abnormal generation, the decrease of phase 4 in the pacemaker cells and raising of the threshold, whereas in abnormal conduction, the drugs can cause decrease of conduction velocity or increase of the effective refractory period, so the cell won't be re-excited again. The rationale and goals of any antiarrhythmic regime should be restoration of normal sinus rhythm and conduction, and prevent the most serious and possibly lethal arrhythmia from arising. And the antiarrhythmic drugs are used to basically decrease conduction velocity, change the duration of effective refractory period, and suppress abnormal atomicity. Antiarrhythmic drugs are still classified, the basis of classification is still the Vaughan-Williams classification, or the Singh-Vaughan-Williams classification as it's now in vogue. However, in 1991, the Sicilian Gambit classification has come, where apart from this 4 classifications, they have added a 5th group where you have drugs such as adenosine, and digoxin and magnesium sulfate drugs which have action by some other mechanism. Newer classifications have also been proposed where they, apart from the channel blockers, the receptor agonists and antagonists and ion transporters, it's becoming more and more complex with advent of arrival of much newer drugs. So if you look briefly at the drugs which are available, the class 1A drug, and they are classified into A, B, and C, all of them, they decrease the conduction velocity in non-nodal tissue, and they act on sodium, open sodium channels. So mainly they are used in patients, or they are mainly active in patients who have tachycardia, because that's a use dependent phenomenon, and in normal rhythm they are not that much effective. 1A drug basically have a moderate action on your sodium channel. They slow the phase 0 depolarization and prolong action potential and slow conduction. The classical examples are quinidine and propanamide. Natacardine is, however, not always readily available. They have good bioavailability, and quinidine is metabolized through the liver, whereas your propanamide has this active metabolite, NAPA, is metabolized mainly through the kidney, and it should be used very carefully and should be avoided in patients with renal dysfunction. The class A drugs are mainly used in actually, although they can be used in supraventricular arrhythmias, but they are rarely used for that purpose. Quinidine and propanamide are mainly used along with class 3 drugs in refractory ventricular tachycardia patients on an ICD therapy. IV propanamide can also be used for hemodynamically stable VTs and for acute conversion of AF even in presence of WPW. The toxicities can be both cardiac, whereas in cases of propanamide, it's mainly the extracardiac, like SAD symptoms, which are more important. Class B, 1B drugs are your classical lignocaine, mexiletine. They shorten the phase 3 repolarization and decrease the duration of your action potential. The class 1B drugs, basically, lignocaine has extensive first-pass metabolism, and it is the drug of choice for acute emergency ventricular arrhythmias. Mexiletine is basically an oral analog of lignocaine. Their main adverse effects are neurological, and they are used in treatment of ventricular arrhythmias, particularly during myocardial infarct, ischemia, or due to digoxin toxicity. Lignocaine is a class 1B drug which acts selectively on disease or ischemic tissue, where they are thought to promote the conduction block, thereby interrupting your entry circuit. Lignocaine acts preferentially on ischemic myocardium and is more effective in the presence of potassium, with high external potassium. So any hypokalemia that has occurred has to be corrected for this drug to have its optimal action, and it has basically no role in treatment of supraventricular arrhythmias or for recurrent chronic ventricular arrhythmias also. Class 1C drug like flecainamide, which is an oral preparation, it markedly slows the phase 0 depolarization, and it can be used for refractory ventricular arrhythmias. Flecainamide is a particularly potent suppression of premature ventricular beats, but it should be used, or rather it is contraindicated in post-MI patients because it has been shown to increase mortality. So if we sum up the class actions of 1A, B, and C, the sodium channel blockade is maximum with your class 1C drug, and the effective refractory period is basically maximum prolonged by class 1A drug. Next, we have beta blockers, which are used mainly for sympathetic activity-induced arrhythmias such as stress and exercise-induced arrhythmias, for rate control of atrial flutter fibrillation and AV nodal tachycardias, and to reduce mortality in patients after myocardial infarction. The drugs mainly used are propranolol, metoprolol, esmolol. Esmolol is a short-acting drug which is basically used in acute arrhythmia settings such as post-surgery or during emergencies. The class 3 drugs are basically, majority of them have multiple mode of action, but the potassium blockade action is most important. They prolong the phase 3 depolarization without altering the phase 0. Your classical drugs which are available are sotalol, amiodarone, and ibutylide. They are mainly used in ventricular arrhythmias, but also drugs such as ibutylide are particularly used in acute conversion of the supraventricular arrhythmia like atrial fibrillation. But they can lead to torsade, and ibutylide is the only drug in this class which has predominantly or only potassium blocking effect. Others have multiple mode of action. Electrophysiological heterogeneity it makes it more homogeneous, and so the breaking of the arrhythmia is more possible with this drug. Although it's a class 3 drug, the incidence of torsade is much lower than expected for its class 3 effect, and the AV nodal block and bradycardia is possibly because of the class 4 action. It is some which is action on class 1, 2, 3, and 4. All 4 classes of actions are seen with amiodarone. The indications are VT, VF, atrial fibrillation, where it is probably the most effective of the available drugs to prevent recurrence of paroxysmal AF or flutter, and it can also be used in patients with congestive heart failure or with structural heart disease. It can be also used in syndromes. In AF, it's possibly the benefit is because of prolongation of the refractory period of both the left and the right superior pulmonary vein and the inhibition of the AV node. Unfortunately, it has got a lot many drug interactions apart from its toxicity. Two most common being with warfarin and digoxin, both of whose levels have increased, and also it has additive pro-arrhythmic effects with other drugs which cause prolongation of the QT. So it should be used a little cautiously. Sotalol is another one of the class 3 drugs which is available in the oral preparation, but for its class 3 action, it has to be used at least in the dose of 160 mg to 640. Below 80 mg blocking action in patients with structural heart disease, but it is relatively contraindicated in patients with renal function. It is not that sotalol is contraindicated in patients with heart failure, but like all beta blockers, it should not be used if there is a decompensated heart failure. Dronedarone, a congener of amiodarone, is used and should be used only for maintenance of sinus rhythm in patients with paroxysmal persistent AF who have been successfully cardioverted. But these patients should have a good AV function. The class 4 drugs are your calcium channel blockers, where they block the L type of calcium channel and they slow the phase 4 spontaneous depolarization and slow conduction in tissue dependent on calcium currents, such as AV node. Their mechanism of action is they bind to open or depolarized channels, and they prevent repolarization. So they act only in case of arrhythmia. They prolong the effective refractory period of your AV node, and they are more used in atrial rather than ventricular arrhythmias and with control of atrial flutter and fibrillation. Regarding the adverse effects, they should not be used in patients with the existing depressed heart failure, depressed heart function, and they can cause bradycardia, particularly when they are used along with beta blockers. Lastly, the three drugs which are covered in class 5 in your classification. One of them is adenosine, which acts on the A1 adenosine receptor, opens the acetyl-sensitive potassium channel, inhibits the calcium inward current and suppresses the calcium-dependent action potential, and increases the potassium outward current. It inhibits the AV node more than your AC node by increasing the AV nodal refractory period. It can be used as for both as diagnosis and treatment of your aberrant and re-entry circuits, and also it's a drug of choice for nanocomplex PSVTs. It, however, is contraindicated in patients with ventricular tachycardia, where it can cause hypotension and deterioration, and a high-grade AV block, and in patients who we suspect to have arrhythmia because of poison or drug induced. It can cause bronchospasm, but then because it has a very short duration of action, that is not very much clinically significant. Lenoxin is the age-old drug which we use for mainly for rate control of your different supraventricular tachycardia that blocks the sodium potassium ATPase pump. The other antiarrhythmic drug which we often use in an acute setting is your magnesium sulfate. Magnesium as an ion is necessary for transport of all the three sodium, potassium and calcium across the cardiac cell membrane, and it is only the intravenous magnesium salt which can be used, and oral salt has not been found to be any effect in arrhythmia setting. The mechanism of action is by mainly decreasing the calcium flux and preventing the early repolarization. It's indicated in Torsades and in polymorphic VT and digoxin intoxication, and also it has other uses in other medical practices. The adverse effects are hypotension and asystole and respiratory depression. Also, it should not be used or used with a very great deal of caution in patients with renal failure. So if you look at all the classes of drug clinically, your ECG, the QT is prolonged with mainly class 1A and class 3 drug, and to some extent with class 1C. The rule of thumb is that if the QT is prolonged by more than 25% or more than 500 milliseconds, it is better always to stop the drug and think of other therapies. Treatment of atrial fibrillation and ventricular tachycardia are two very common entities which we face. In atrial fibrillation, the first goal is to reduce thrombus formation. The second is to prevent the arrhythmia from converting to something more lethal, like a ventricular arrhythmia, where your first choice is a class 2 or a beta blocker drug, particularly after an MI or a post-surgery setting. And of course, the second choice should be a calcium channel blocker. And in case that both are not effective, then only lanoxin can be used, and lanoxin should only be used if there is underlying pulmonary dysfunction. The third goal of therapy in atrial fibrillation is conversion of the arrhythmia into a normal sinus rhythm, where you have class 3 drugs. If they are not effective, then you can go to a class 1A or a class 3 drug. However, even in atrial fibrillation, it's better to do the cardioversion if the patient is unstable. The second choice could be amiodarone. Like I said before, class 1C drugs are very much effective, particularly flecainamide in suppression of your ventricular PVCs. I'll just finish it. So we have in pregnancy and lactation, the only drug which we can use is sotalol, which is a category B drug, and it is, although not teratogenic, it can cross the placenta. We have certain newer antiarrhythmic drugs such as varnaclorid and tedmisen, which are class 3 drugs. Lastly,
try to stop here.
I'll just finish. I'll just give me just 2 minutes. I'll just finish. So we have here initiation of therapy is it depends on the severity of the arrhythmia and the proarrhythmic risk. All class 1A drugs should be started in hospital because they have the risk of idiosyncratic and non-dependent torsade. Mexidine can be started as an outpatient basis, and class 1C drugs which have low proarrhythmic risk can be started outpatient. Lastly, your pill-in-pocket approach is what we are doing nowadays with particularly flecainamide and propafin. But the potential complication is that it may convert the arrhythmia to a flutter where you have your 1:1 conduction and a high ventricular rate. So your take-home message should be that they are all antiarrhythmic drugs are proarrhythmic. They can have dangerous side effects. If the patient is unstable, it's better to cardiovert. One should enlist the help of an expert if we are in doubt, and one should try to stick to drugs which we know. Thank you.
So much, Dr. Soumik Basu, so much elaborated, but concise in a very meaningful way. You just keep wait. We have question answer session at the end. Now I request our electrophysiologist, Dr. Suchit Majumdar, who could not complete his talk due to some technical problem. Is he there to present?
Yeah, I am here, but that I cannot share basically.
Dr. Bhavani Prasad Chatterjee will be talking now.
Okay.
Bhavani Prasad Chatterjee completes, then Suchit Majumdar will.
Yeah, no problem. It's fine.
Okay.
Sujit Majumdar has been unmuted. Why? Sujit, please unmute Sujit Majumdar.
Okay, yes. Yes, sir.
Yeah.
Dr. Sujit, can you present your slides?
Yeah, I think there was some, I can present, but sir was telling, okay.
If you join soon, just after Dr. Chatterjee has completed.
Okay.
Yes.
Anjanda, he will start later on.
Yeah,
Okay.
just after this, he will talk.
Okay. Who is the next speaker?
I think Dr. Bhavani Prasad Chatterjee.
Sir, he was there, but we lost just now. He logged out.
Sujit, are you ready?
Yeah, I am okay.
So you start the program.
Okay. Which was the slide I had last left with? I'm not sure. I could not find out. And so what up to what point did I do it?
Yeah, these are all EP slides.
These are all covered?
No, you start from the very beginning. You start from
Yeah.
Okay.
You just started and thereafter it got stuck. Yeah.
Okay. Sure. Okay. Thank you, sir. So basically, I'll just make it short this time. I will just focus mostly on Brady, I think. So basically, from bradyarrhythmia, we have to, why EP study is required? Because to localize the level of AV block, if it is a suprahisian versus an infrahisian block, whether it is above the His in the AV nodal level, or it is in the below the His in the His-Purkinje system. Because the prognostication depends on that. The infrahisian AV block has a more chance of going into the complete heart block. And also the escape rhythm in an infrahisian AV block is unstable. The other way, if it is a suprahisian AV block, it has a less chance of going into a complete heart block. And secondly, also you have a escape rhythm, which is from the junction, and it is often reliable. So these are the very important for prognostication of level of AV block. AV nodal function and sinus nodal function. Now these are actually detected better in the Holter and otherwise. But usually we don't require an EP study for a sinus nodal function, though there are ways to determine it. Thirdly, very important is ruling out mimickers of AV block, that I will come in the later slides. In case of tachyarrhythmia, it's a supraventricular tachycardia. After ECG suggesting a particular mechanism, we have to confirm the mechanism by doing maneuvers and other things. Whether it is an AV NRT or it is an AV node, AV reentrant tachycardia, or it is an atrial tachycardia. And after the mechanism, we have to find out where is the culprit tissue. Means if it is an accessory pathway, where is the accessory pathway? And then accordingly the location of the pathway, and then ablate it. So these are the two indications of EP study: finding out the mechanism and ablating it according to the site. And in case of ventricular tachycardia, there are different things. One is that we have to see for the inducibility of VT. Now that is very important if you have a structural heart disease and you have some symptoms where there is no definite correlation between symptoms and the arrhythmia. You may have a structural heart disease, for example, a post-myocardial infarction. You have 3-4 beats of NSVT and Holter, but you have a patient having a syncope. And the EF is not that low. It is maybe 45, 50, something like that. So you can do an EP study to see whether VT is inducible. And if VT is inducible, then it can indicate the need of ICD. Secondly, if it is no structural heart disease, means normal heart, and you have a VT, then this doesn't require any ICD. So this requires drug therapy. If not working, then go for ablation. Now, EP study, if we are going for ablation, is helpful in finding the mechanism and site of origin and circuit in case of reentrant VT. Now, ECG versus EP, if you find out, the PR interval is a very important site. The PR interval indicates the summation of actually atrial depolarization followed by AV node, followed by His, followed by bundle branches and Purkinje system. So in ECG, we can only say that PR interval is prolonged, but we cannot usually say at what level of this has prolongation occurred. There are some suggestive features, but these are not confirmatory. In EP, if we can put catheters in the atrium, in the His bundle area, in the ventricle, we can think that which part of the AV block is contributing to the prolonged PR interval. And ECG can't show any high frequency signal like a His bundle depolarization. So that is the most important disadvantage of ECG as far as Bradley study is concerned. You cannot see the His by any way, or you can in the ECG. And also the potentials for activation of different parts of the circuit cannot be seen. Now, basic setup of EP catheters, I am not going into detail. So basically, this is the catheter which is going into, it's a RAO view going into the right ventricle. This is the catheter which has been put in the coronary sinus. This is the catheter which has been put in the His bundle area. And this is the catheter which has been put in the right atrium. And this is the same in the LAO view. We have the CS, and then we have the His catheter, then we have the RV catheter, and finally the RA catheter. So indication of EP study, localize the level of AV block. In case of if you have a bifascicular or trifascicular block where the symptom correlation is not that clear, and if you have a Holter or prolonged recording which has not shown an advanced AV block, then you can do an EP study to see that what is the HV interval. If the HV interval is more than 70 milliseconds, it is an indication for pacing. Now, that is one of the indications. Secondly, if you have a 2:1 AV block, there are different ways to classify it into a suprahisian or infrahisian by non-invasive ways. But if they are not very much suggestive, then you can go for an invasive determination of by EP study, and also to rule out AV block mimickers. Now, remember, there is no indication of EP study with a normal ECG and suspected bradyarrhythmia. Usually, if you have a normal ECG, you are very unlikely to find anything in the EP study in a suspected bradyarrhythmia. Now, HV interval, how do you make? So I have already discussed that if you put the His bundle catheter, and you have to find out from which pole you have the largest A and the His. For example, this signal is distal most, and here the distance between the signal and the V is less than 30 milliseconds. So this cannot be His. This has to be a bundle branch. His is this one. Because why it is His? Because
again, sound is gone. No sound, no sound.
So please unmute yourself.
Why it is muting? In between, could you hear, or just now it muted?
Now it's audible. You can continue. You may
continue.
continue.
Okay. Restart with bundle of His.
Okay, I don't know why it is muting. Somebody is muting. Okay, so bundle of His, I think this one, HV?
Yeah.
Okay, so so here, when we place the catheter at the His bundle, preferably you should place a decapolar catheter where you can have area or rather than a point, because His can be recorded over an area. It is not a particular point. And then we have to find out that whether we can find a good A in the His potential. So His potential is seen here also with a small a, and here also His potential is seen with a larger A. So whenever calculating a HV, you have to have a good A and a V for calculating HV. So it is a proximal His. So that will give you an idea. Now how HV is calculated? From the
Dr. Sujit Majumdar, kindly unmute yourself.
I am not muting. How can it's muting? I don't know. Somebody is muting actually.
Okay, carry on.
Yeah. So I think now, okay. So I will come to next slide. I am going. So here we can see what is called as a split His. Now here in the His bundle electrogram, we can see two sharp signals. Now, whenever we measure the His, if we measure from this His, we will get a normal HV interval. But if we measure from this His, the HV interval will be prolonged. So that is the importance of having a proximal His. Secondly, if you have a two His interval, you have to find what is the distance between these two. These two distance is usually less than 30 millisecond. If it is more than 30 millisecond, it indicates a block in the His. That is called as an intra-Hisian block. Now, this is very important in nowadays for His bundle pacing, where you have to go distal to the intra-Hisian block, and pace, and can get a good His bundle pacing. So this is very important to locate a split His, and that is not very uncommon to find, but we have to find it. Now, this is an example of a EP study, just an example how to measure the AH interval from the A to the H and the H to the earliest surface V. Now, this AH interval is usually under autonomic influence, that is a vagal stimulation, vagal influence and the sympathetic influence. While HV interval is not under the autonomic influence and it is more constant. So, for all the studies, we usually take the AH interval. AH interval has not much meaning because it can vary based on your vagal. I'm coming to that. So, after AH and HV, we have to find an AV Wenke backing point. We have to pace the atrium and we have to find at what cycle length there is a Wenke back. And after the Wenke back is found, we have to find it is a suprahisian or infrahisian Wenke back. Now, for example, here you have a Wenke back at 845. That is quite high. You should not have a Wenke back at that high level. But if you have this patient given atropine and it comes down to 605, and then it maybe more comes down to less than 450, then it is indicated that it is this vagotonia is contributing to this prolonged AH interval, and it does not require any pacing. But even after giving an atropine, and if you have a very high AV interval, AH interval, and patient is symptomatic because of that, then that may be indicative of pacing. So this is a suprahisian Wenke back. Why so? Because the beat which is blocked is not. So for example here, this beat is blocked. This A is conducted to this His, this A is conducted to this His, but this A is blocked. So when it is blocked, it has no associated His bundle. So that is called as suprahisian Wenke back. So whenever we see a Wenke back, we have to find out it is an AV nodal, a His bundle, or a bundle branch or infrahisian Wenke back. And second degree AV block, a second degree type 2 AV block, we have to find whether it is at the level of AV node or at the His Purkinje system. Now coming to two examples. Here there is a 2:1 AV block. And you see after this A there is a His and there is no V. So whenever there is a block P, there is His but there is no V. That means the block has occurred after the His bundle. So it is an infrahisian AV block. And that is dangerous. So you need a pacemaker. Secondly, in this example, you see there are A, H, and then no V. So that is also infrahisian block. While here you can say A, but there is no H and also no V. So this block has occurred before His. So this is a suprahisian AV block. This ECG contains both infrahisian and suprahisian AV block in the same strip. Now coming to the other phenomena which you have to exclude. One is a blocked PAC. So whenever you see a 2:1 AV block, just see that the premature, that the P which is blocked is normal or abnormal. If it is abnormal, then it is a premature atrial complex, and also the AA interval is shorter than the sinus AA interval. So that can be blocked normally physiologically if you have a refractoriness of the AV node. So that will not prove anything. So very important, whenever you just see a 2:1 AV block type of thing, just see that whether there is a blocked APC, that is a deformed P, or it is coming earlier than expected. Another thing is what is called as a concealed junctional ectopy. I don't have a tracing here, where there is a firing from the His bundle which neither reaches the atrium nor reaches the ventricle. But what it causes a block in the AV node that is called as a concealment in the AV node. And that causes the sinus P to be blocked, resulting in a 2:1 AV block. So if you see a 2:1 AV block, and if you don't do an EP study in these sort of patients, then you will never find that the cause of 2:1 AV block is not a problem with the infrahisian or suprahisian system, but a His bundle ectopic which is causing this. And secondly, atrial echoics causing Wenckebach. So this I have already discussed, that EP indicators of infrahisian disease. One more thing I want to highlight, that infrahisian block at cycle length of more than 400 milliseconds. Now often we can have an atrial tachycardia with a variable AV block, or atrial flutter with a variable AV block. We never tell that that is a dysfunction of the AV node. Why? Because the rate is more. Whenever the AA interval is less than 400 milliseconds and you have that sort of AV block, a few is conducted, others are not, that is not abnormal, and that is an infrahisian block which is physiological. While if the cycle length is more than 400 milliseconds, you have an infrahisian block, that is pathological. Also, the indication of pacing, if you have to pace a patient, then HV interval of more than 100 milliseconds, even if the patient is asymptomatic, needs a pacemaker. If you have a HV interval of more than 70 milliseconds with symptoms, then also it requires a pacemaker. And this is the same thing. So coming to the VT induction, you just maybe end with this. So VT induction is usually done from two places, either in the RV apex or RV outflow. And it has to be done with two cycle lengths, maybe 400 millisecond and 600 millisecond. And we have to see whether we can induce a monomorphic sustained VT. That is very important. If you induce a polymorphic VT, it is non-specific and don't dictate management in any way. Extra beats what you give should be 2 or 3. Better you can give 2, because the more beats you give, the more likely that it can induce a polymorphic VT and jeopardize your study. Thirdly, whenever you do a VT induction, you have to remember two things has to be there. One is a DP patch and another is an arterial line. That is very important, because to see the hemodynamic instability and shocking. And lastly, you have to rule out intracardiac clot before VT induction, because if you have a clot and you do VT induction and shock, then there is a chance of embolism. So I think we'll stop here, or we should continue.
I think you better stop here and
I think so, because
let some discussion be going on.
Yeah. So I don't want to go into trachy, because trachy is actually a long thing. So I am unsharing my slide.
Sujit, do you think that below 70 millisecond HV interval, the patient is safely discharged with advice of no pacemaker?
No, that is not true. Because what I personally think that whenever you have, most important in evaluation of a syncope is the history. History, that is very important, because if you have to find out by the history whether it is looking like a cardiac syncope or not. If you have a strong suspicion that you have a cardiac syncope, you have a bifascicular block, and there are two options. Either you can go for an empirical pacing, but that is class 2B indication. According to recent guidelines of 2017 and 2018 by two different societies, you have to do a EP study. So EP study, if it shows a HV interval of more than 70 milliseconds, then you go for pacing. If it is not showing, the guidelines recommend you put an ILR and document the block, and then you go for pacing. But it is not possible here because people can't afford two devices. So you can go for a pacing straight on if you have a strong suspicion, even if the EP study is not showing a prolonged HV. Because two things, HV is a dynamic thing. We don't use procainamide here. We don't have procainamide. That's why we cannot stress the HV to find out whether it is diseased. Also, there is one thing we can use, that flecainide. Flecainide can prolong the HV and cause AV block, and that can be suggestive. But usually there is no standard guideline for that. So I will not also tell to use that. So which subset is important here? This is something called as a paroxysmal AV block or idiopathic AV block. In this paroxysmal AV block, you can have a normal HV, and HV when prolonged at particular time, especially after you have a PVC or PAC, it can prolong the HV and cause a AV block.
Okay.
What about what about a concomitant sinus node disease and AV node block? If a patient has a biventricular heart block.
Yeah. So that is actually, sinus node disease and AV block can occur in the same patient, because sinus node disease, sinus node dysfunction, percentage of patients, as more elderly patients go on to develop AV block, that is there. Even some people can have a pan conduction disease where sinus node, AV node, and bundle branches can be affected.
Basically, it is a degenerative disorder of the conducting system.
Yeah, that can happen. So the guidelines of pacing and all this thing will depend on which is the predominant thing. For example, if you have a sinus node disease, which if you have a significant sinus bradycardia, which can account for symptomatic sinus bradycardia, significant pauses, then also otherwise it can mandate pacing even if it has a bivascular block. So that is the important.
Debabrata Bera, Dr. Kaushik, Soumik Basu is there. Dr. Debabrata Bera and Dr. Soumik Basu. Can you take on in questions?
I can take a question.
Soumik, you are here. Soumik?
Yes, I'm here.
Yeah. So with pill in the pocket, is there any other drug that is being introduced in the pill in the pocket? That is, ranolazine has been introduced most likely. Do you have any idea?
Flecainamide is used.
Flecainamide and propafenone are the two standard drugs.
Ranolazine has been, after this trial, ranolazine has been found that there is about, it converted about 77% of patients with atrial fibrillation versus placebo. And also it was found that post NSTMI, it reduced the incidence of atrial fibrillation and non-sustained without causing any increase of QT. It's basically a sort of sodium channel blocking drug. So it is, ranolazine is coming up in arrhythmia as a novel anti-arrhythmic agent.
Debabrata is there? Dr. Debabrata Bera? Okay, Suchit, how much of a PR interval you will take that it is not required to have any suspicion of infraesian block if the PR interval is 30 or 28 or 20, 0.24, 0.28 or 0.30? How
no,
much
you are telling PR interval, interval, no? So regarding this...
Or in other words, what are the ECG indication of infraesial block?
Yeah, so one is if you have a concomitant bundle branch block. If you have a concomitant bundle branch block, you can suspect that the bundle is already diseased. So there is chance of infrahesian block, number one. Number two, if you have maybe a normal PR, the PR is not great, but you have a 2:1 AV block, then it is more likely to be infrahesian or intrahesian also. Now, how to differentiate in a 2:1 AV block by ECG, whether it is an intrahesian or infrahesian? In intrahesian AV block, usually the QRS may be normal. So if you have a 2:1 AV block with a normal PR and a normal looking QRS, then often it is an intrahesian AV block. While if you have a 2:1 AV block with a normal PR with a prolonged QRS, then it is more likely to be an infrahesian AV block. For cutoff, as asked, if a PR interval is more than 300 milliseconds, there has to be some component of suprahesian AV block. If the PR interval is less than 160 milliseconds, then it is unlikely to have associated suprahesian AV block. But it is difficult to tell exactly a value, but these two are given in the guidelines.
You mean suprahesial or infrahesial?
Suprahesian, I am telling. If the PR interval is very more than 300, it is more likely to be suprahesian, I am telling. But below that, it can be supra or infrahesian. So that we have to see in different ways, other ways to see.
Dr. Ajijul is there? Dr. Ajijul?
Yeah, I'm here.
Yeah, please conclude the session by your remark.
Okay, very good presentations there. Shomik and Dr. Suchit Majumdar and Devakarta Bera. We have learned many things from them. I think thanks to them. And,
Yes, sir. Thank you, sir.
Dr. Jayanto, can we go to the next program session? Dr. Jayanto Shah?
Yes, move on to the next session.
Okay, so please call the...
Dr. BP Chatterjee is here. Dr. Bhavani Prasad Chatterjee.
No, sir. No, sir.
If he is not there, then Dr. Gautam Datta can start.
What about the band of chairpersons? Are they there? Dr. Ashok Dhar, Dr. Devanu Ghosh Rai.
Dr. Kashinath Ghosh Hajra.
Kashinath Ghosh Hajra is here.
But I am on.
Good
evening, sir. আমি আপনার পেশেন্ট দীপক ব্যানার্জির ছেলে বলছিলাম। আমি আপনার বুক করার করছিলাম, তো ওখানে আপনার একটা ওপিডি অপশন দিচ্ছে, আমি ওটা জানতে ফোন করেছি, আপনি এখন মানে বসছেন হয়।
Jayanto, you should call the chairpersons as well.
Sir,
you call the names, whether they are present or not.
Dr. Ashok Dhar is there. Dr. Ashok Dhar.
Yes.
Dr. Kashinath Ghosh Hajra.
Yes. Yes, I am here.
Kashinath Ghosh Hajra sir is here.
Oh, sir is here.
He is there, yes.
Sir, please join the session. And Dr. Devanu Ghosh Rai.
Devanu Ghosh Rai not there, sir.
Dr. Shahidul Islam, he is absent. Dr. Misro, Dr. Chandan Misro. Dr. Madhumita Kuila.
Chandan Mishra also not there.
Dr. Madhumita Kuila. So Dr. Datta and Dr. Kashinath Ghosh Hajra is there as chairperson, and Dr. Gautam Datta is there. And
yes,
we
sir.
have all other senior teachers here. So let us start the program.
Yeah, let us start it. Gautam Datta will be dealing with lesions at the two kingdoms, which are very close to each other and which are very common situation as well. Dr. Gautam Datta, please.
Good evening, sir.
Dr. Gautam Datta, sorry, kindly change your PPT as a presentation mode.
Is it okay?
Yes, perfect. Please go ahead.
Good evening, sir. My patient is a patient of unstable angina with significant coronary disease, and he had got concomitant occlusion of the left carotid artery and with a history of ischemic stroke 1 year ago. Now, there are two studies which had dealt with this. This is the same study, and the same thing in this population.
Is Gautam audible?
Am I audible?
Yes, sir, audible. Yes, sir, audible.
Both acute ischemic heart disease and the chronic stable angina and post-AVG patients are there in this this population, and they have a patient with stroke, both TIA, stroke, and asymptomatic patient. Correlation is that around 18% of the patient with ischemic heart disease, they have concomitant cerebrovascular disease, and they have or mixed therapy, either surgical CABG and endarterectomy, or endovascular PCI plus carotid artery stenting, or a hybrid procedure like stenting plus CABG or PCI plus endarterectomy. Now, the take-home message from the study is that patient with acute coronary syndrome who has got symptomatic carotid artery disease, they have got high mortality. And second take-home message from the study is that if you treat carotid artery first, before receiving heart disease, they fare worse than their other parts. Now, this is my patient. He came to our OPD with chest pain for last 2-3 days, and he had a nocturnal chest pain. This is nearly occluding circ. So we fixed the circ, we wired it, and then we stented. And this is the picture after stenting PV3 flow. Patient became pain-free, and we kept him in the CCU. And after 48 hours, he had another 2 lesions, LED and right coronary artery. This is his LED lesion. We fixed it after 48 hours. And this is his LED. And this is his RCA. We fixed only the mid part. And this is his RCA. But we purposefully left out the proximal RCA and the proximal LED lesion because of this. This was a FFR guided strategy. Both the proximal LED and proximal RCA, FFR was more than 0.8, so we left it. We do not know whether we have done the right thing or the not. So this is the latest 2020 ESC guideline. If a patient comes to emergency, you go for 0-1 algorithm. So first you go for ECG and troponin. If it is elevated troponin, you directly admit the patient in the CCU and plan for invasive strategy. But if there is no ECG change, troponin is normal, you can rule out that this patient is having any ischemic heart disease, acute ischemic heart disease. You can discharge the patient. But if there is a strong suspicion of suggestive chest pain, you wait for 3 hours. Again, you repeat troponin and echocardiography. If there is a fresh wall motion abnormality or elevated troponin, again you admit the patient and go for invasive procedure. Now, this is the same, the acute coronary syndrome guideline. Who are the patients who should go immediate angiography? And these are the patients who are hemodynamically unstable, having cardiogenic shock, refractory chest pain, life-threatening arrhythmia, mechanical complication, acute heart failure, or if there is a ST depression in more than 6 leads, 1 millimeter, or ST elevation in AVR. And the high-risk patient, they should go for within 24 hours angiography. These are the patients. Stamped diagnostic of NSTEMI, if there is a dynamic or new STT changes, or patient out of hospital cardiac arrest, and if the Grace risk score is more than 140. Now, Grace risk score is the only score which is now accepted as a the guideline for managing the NSTEMI patients. Now, for coronary revascularization, radial access is now the class 1 indication. DACE is also the class 1 indication. Now, for patients with multivessel coronary artery disease presenting with unstable angina, without cardiogenic shock, one should go for complete revascularization in the same sitting, the class 2A indication. But if the patient, you can go for the ad hoc strategy, mainly culprit vessel revascularization followed by either multivessel PCI or a CABG based on syntax score. Now, regarding anticoagulation, unfractionated heparin is the class 1 guideline. Bivalidine is now class 2B after the Validate Sweetheart study and the Matrix study. And if the bleeding risk is low, then dual antiplatelet therapy for 12 months, and then the monotherapy. But if the bleeding risk is high, you can go for 3 months of dual antiplatelet therapy followed by monotherapy. And if the bleeding risk is very high, the first month of dual therapy follows by monotherapy. Now, this bleeding risk is calculated based on ARC criteria. Now, there are some major criteria and minor criteria. The age-old, the BRC criteria is now gone into back burner. Now, the ARC criteria is then a new recommendation. Now, this patient with high ischemic risk, they should go for more than 12 months of double antiplatelet therapy. These are based on either diabetic, history of recurrent AMI, multiple coronary disease, polyvascular disease, or a premature atherosclerosis. Or if there is use more than 3 stents, 3 lesions, total stent length more than 60 millimeter, or if you are dealing with left main bifurcation stenting with 2 stent strategy, or with CTO with multiple overlapping stent, and if there is history of stent thrombosis in spite of adequate antiplatelet treatment. Now, some of the patient may have associated atrial fibrillation, and for default strategy should be triple therapy for a week, followed by double therapy, NOAC plus single antiplatelet, and after 12 months, only the anticoagulation. If the bleeding risk is high, you can reduce the duration to 6 months, then continue only with anticoagulation. But if the ischemic risk is high, you can prolong the triple therapy from 1 week to 1 month, followed by standard dual therapy. Now, some of the patient may have with on oral anticoagulation. What should be the strategy of anticoagulation peri-procedure? If the patient is on vitamin K antagonist and INR is more than 2.5, no more heparin. If the patient is on NOACs, irrespective of the time, you just give 60 units per kg body weight of heparin, and GP2B3 should be used only in case of either any peri-procedure complications. Now, regarding the medical therapy, this unstable angina, statin is recommended, and target is LDL less than 50% from the baseline, or LDL of less than 55. If you can achieve with statin, is okay. Otherwise, you add ezetimibe. If not achieved within 4 to 6 weeks, you can add PCSK9 inhibitors. But if there is a patient who has got recurrent disease, meaning 2 episodes of acute coronary syndrome within 2 years, target LDL should be less than 40. Regarding ACE inhibitors, beta blockers, MRA, there's the same standard guideline like that of AMI. And regarding proton pump inhibitors, they should be used who has got high risk of GI bleeding, age more than 65, alcohol abuse, H. pylori infection, dyspepsia, GERD. Now, many patients with unstable angina may have less than 50% of the lesion. They should go for functional testing like FFR, CFR, and IMR. And based on FFR, CMR, IMR criteria, they can be diagnosed as having microvascular angina. If it is normal, go for historeactive challenge test to stamp as spastic angina. All these are clubbed as INOCA. And this is the INOCA guideline. CAD, many patients may have spontaneous coronary dissection, there are different types, different strategy of management. Now, some of the recent trial data regarding this acute coronary syndrome. This is a Twilight ACS trial published in October 2020. Just like Twilight trial in myocardial infarction, this trial also they have shown that if you just give 3 months of aspirin and ticagrelor followed by a monotherapy of ticagrelor, their mortality is same, but bleeding complication is less with 3 months of treatment. Now, how long to continue beta blockers? Again, this is published in European Heart Journal this last month, and they have shown that there is no advantage of beta blockers if you continue 3 years or more. For elderly patient, what should be the antiplatelet of choice? I think this is the elderly means more than 80 years. Clopidogrel is safer than ticagrelor. For this is an OCT-based study, and they have looked into the plaque morphology of acute coronary syndrome. They have shown that the layered plaque, which are mainly distributed in the proximal LAD and proximal L6, and for right coronary artery, this is more or less diffusely distributed. They are more prone to have plaque rupture and acute coronary syndrome. Now, which one is better, ticagrelor or the prasugrel? This is published in JACC Intervention just again this year, and they have shown that in diabetic patient, the bleeding complication is more with ticagrelor than prasugrel, non-diabetic population, though bleeding complication is more irregular, but they are more or less comparable, not statistically significant. Now, for the non-culprit lesion, what should be the strategy? This is a FFR guided trial. They have with a meta-analysis of 5 trials. They have looked into both stable angina pectoris patient and the ACS patient. Now, just the FAME trial, the kind of advantage what we have got in the FAME trial in case of a stable angina pectoris for ACS patient, before strategy do marginally better, but they are not statistically significant. The bottom line is FFR guided strategy is best for stable angina pectoris, not for acute coronary syndrome. And for the complete revascularization, it is beneficial across the board. Whatever the sex, age, different coronary anatomy, diabetes, renal disease, across the board, the complete revascularization is better than the incomplete revascularization in acute coronary syndrome. And this is the early trial which has shown that patient with high or intermediate risk ACS patient, if you revascularize them within 2 hours, their mortality benefit is much more than the delayed strategy. This is the left main stenting group in acute coronary syndrome. Again, early invasive strategy is better than the delayed strategy. And for this left main group with acute coronary syndrome, even if the syntax score or a syntax 2 score or euro score is high, if you go for immediate angioplasty, they fare better than the others. Now, this is our patient. He has got a concomitant lesion in the left internal carotid artery. I'm sorry, this is not movie. This is a fixed. This is a still picture. This is the internal carotid artery. After EPD deployment, we dilated the lesion. This is stented. This is epic stent 8/60, then post dilated, and this is the picture after stenting. Now, question is what we have done, whether it is worth or not. This is the last guideline, ESC guideline again for management of the carotid artery disease. Now, if the duration is less than 6 months, less than 6 months of history of stroke or TIA, you go for duplex ultrasound. And based on the duplex ultrasound, you plan for either CT angiography or MR angiography. If the stenosis is less than 50%, only medical therapy. Stenosis is 50 to 70%. 1A guideline, 2A guideline is carotid endarterectomy plus best medical therapy, and stenting is a class 2B. But if the degree of stenosis is 70 to 99%, then endarterectomy becomes the class 1A indication, and carotid stenting is only class 2A indication, provided patient has got high stroke risk or a high mortality for carotid endarterectomy, meaning the risk is more than 5%. But if the history of stroke or TI is more than 6 months, they are labeled as asymptomatic carotid artery disease, as in our case. So again, you can plan for carotid duplex ultrasound followed by CTA or MR angiography. If the patient is nearly occlusion or total occlusion carotid artery, only the medical therapy. If the stenosis is less than 60%, again only medical therapy. But the lesion is between 70 to 99%, as in your patient. If the life expectancy is more than 5 years, and there are some risk factors which suggest this patient may have a higher risk than the others, then only you can go for carotid endarterectomy, which is class 2 indication. Again, carotid artery stenting is a class 2B indication. But for our patient, he refuses to go for carotid endarterectomy, so we went ahead with carotid artery stenting. Now, what are the features which suggest this patient has got increased risk? These are the features. If you have a TIA or a stroke, contralateral, ipsilateral silent infarction, or in duplex ultrasound, if the stenosis progression is more than 20%, if there is spontaneous embolization on transcranial Doppler, impaired vascular reserve, large plaque, echolution plaque, or if there is a hypoechogenic area behind the lesion, and for MR angiography, if there is an intraplaque hemorrhage or a lipid rich necrotic core, these are the features which suggest this patient may have in future increased risk of stroke. So you can go ahead with either stenting or endarterectomy. Sorry, my slide is stuck.
Sir, kindly select your slide on move.
How can I go back?
Kindly click on your slide. Just move your cursor and click and yeah, it's moving. Please go ahead.
The EPD protection device is a class 2 indication. Now nowadays the proximal protection device like MoMA device, they are preferable than the distal protection device. And regarding anti-infectious regimen, in case of carotid stenting, last month double therapy followed by monotherapy, and for end atherectomy is only monotherapy. And for CVD patient, if patient has got a history of stroke or TIA within 6 months, they should go for a carotid artery evaluation. But if there is no history of TIA or stroke, the carotid evaluation is not required. But if the age is more than 70 years, multiple coronary disease, concomitant lower extremity atherosclerotic disease, or this carotid fluid, one should evaluate the carotid artery anatomy. Thank you. Thank you for your kind attention.
Yeah, thank you, Gautam Datta, for giving us some inputs into the problem, particularly in terms of antiplatelets. But so far as this particular problem is concerned, you are right that unless the patient is having a lesion more than 70%, symptomatic beyond 6 months, probably we should not interfere. And the assessment is very important by all the parameters to assess. And I think equally important is the clinical assessment, whether the patient has other atherosclerotic cardiovascular lesions anywhere others, but the likelihood of recurrent stroke is high. So the question of going for fixing the LAD, there cannot be a second opinion about it, but there may be some differences of opinion regarding fixing the carotid artery. You have cited some of the clinical guideline recommendations, but above all, individual assessment is equally important. Yes, Dr. Kashinath Hazra, if you have any comment to make, please.
What was your strategy regarding the statin, and what was the antiplatelet agent that you used in this particular patient?
The guidelines is for
what was your strategy?
My
Whatever.
strategy.
What did you use it in this particular patient?
I personally use atorvastatin, and I use 40 milligram. I don't use 80 milligram.
Mm-hmm.
Though there are no Indian data, but there are data from CMC Vellore. We have even used 20 milligram of statin after stenting. But for Indian patient, I believe, for my experience, 40 milligram is enough, and they can reduce your LV target less than 50. So
and what was the antiplatelet agents?
Huh?
What antiplatelet agents you used in this?
My preference is of course.
Now, in this particular patient, we are talking about the patient.
I have used aspirin and Prasugrel.
Okay, from the very beginning.
Dr. Gautam Datta, I have a question before other to ask you a question. That we have been talking about dual antiplatelet therapy durations, 6 months, 3 months, or 12 months, or even beyond 12 months, depending on the trade-off between ischemic events and hemorrhagic events. If ischemic events is more, probably you can go beyond 12 months in certain situations, or it may be the other way around. But one thing is surprising, that while few months back or years back, we changed from DAPT to single antiplatelet, the single antiplatelet agent was aspirin. The P2Y12 was taken off. But here, whether we go for 3 months, 6 months, or 12 months, from DAPT to single antiplatelet agents, that antiplatelet agent taken off is aspirin. And we are continuing with P2Y12 inhibitor. That is the second important change. One important change in terms of duration of DAPT. The second important change is in terms of selection of the single antiplatelet agents. Now, we have enough data of using aspirin for an indefinite period, but we don't have enough data for use of aspirin, clopidogrel or ticagrelor for using infinite period. So what would happen if the patient is continuing with single antiplatelet as per recommendations? Would you like to continue with ticagrelor for a long period, or for that matter for months together, or prasugrel, or you just want to come back to aspirin? Or what is your personal impression about it?
Actually, sir, if the estimate is high, then and then we should prolong the therapy. Now, data regarding ticagrelor is very limited. There are, of course, few trials, they have continued ticagrelor for beyond 1 year, but the most of the experts, I believe, they prefer clopidogrel rather than the ticagrelor. And with prasugrel, there is no data continuing beyond 1 year, but there are data with ticagrelor continuing more than 1 year, and there are enough data to continue clopidogrel more than 1 year. But what I think
on the guidelines, it has been mentioned that if you want to go beyond, like in previous MI, previous ischemic events, no risk of bleeding, if you want to go beyond 12 months, you reduce the dose of ticagrelor to 60 milligram BD rather than 90 BD. So we are still not very sure what should be the dose and how long we should continue with that single antiplatelet, either in the form of ticagrelor or prasugrel, particularly even after ISARAC trial. So any other question from any other experts, please?
But particularly in this particular patient with polyvascular disease, both the carotids as well as the multiple coronary arteries involvement with multiple stents ranging total length of probably more than 60 millimeter, I think it is rather would be too dangerous to stop it within 1 year. I think it is better to continue with the dual antiplatelet therapy more than 1 year. What is your opinion, Dr. Dotto? What is your strategy for this particular patient?
I am very much afraid of cerebral hemorrhage. Honestly speaking, an intracranial hemorrhage is far more dangerous to me than probably a stent thrombosis. So I would not probably like to continue with the newer antiplatelet agents for an indefinite period. I would like to from
I will rather
for a longer period, if not months or years together, because there are the trials of switch trial have then, particularly after the Pegasus trial, there are some objective evidence of changing justification.
Gautam, may I have a comment?
Yes.
What is in your assessment was the proximal LAD percentage lesion in your case?
My impression is it should be around 60%.
60. Oh, that's why you did FFR, no? So it appeared to 80, 85 to me anyway. Okay, if it is 60 to you, then you have justified to do an FFR. Okay, thank you.
Any comments? Dipankar?
I think, Anjana, we are 15 minutes late already. 15 or 25 minutes late.
Okay.
Yeah, Soumitra, can you, on behalf of me, conclude and take over the next session?
Yeah, fine.
No, it's with Anjanda's permission only.
Yes, yes, take the permission of the chair.
If Anjanda is satisfied.
No, I'm quite satisfied. I'm quite satisfied. It is very difficult situations. We are at the crossroad. Right now, antiplatelet agents, some guidelines are there, some objective evidence, twilight, global leaders, glossy, Pegasus, Tico, a lot of
it's a very changing it's a very changing field and very fluid state.
Very fluid state.
And you will learn a bit more about ticagrelor in the next session anyway.
Yeah.
So thank you very much, Dr. Hajra and Dr. Jayanta Saha, and all the seniors present over here, Anjanda, Dr. Dev, Dr. Minal Kanti Das. So what I want to start the next session, which is an industry session and innovation session. Here there are 3 subjects, there is a common string. The subjects are dapagliflozin in CKD, dapagliflozin in heart failure, and past and future of ticagrelor. So can you guess what is the common string? Only Dr. Hajra knows the common string is AstraZeneca. Otherwise, there is no connection between these different types of subjects. But without wasting time, but these are, of course, very interesting and very relevant subjects. So may I request Dr. PC or Dr. Roth is with us?
Yeah,
yes,
very much. Yes.
Is one of the most respected fraternity in our in our fraternity. Thank you for joining us from Hyderabad, Dr. Rath. And I think without wasting time, we will go on to your subject, dapagliflozin CKD. You are armed with newer data in the recently published ESC guideline. So you should give us a very good, clear view what we should do in CKD patient and dapagliflozin combination. There are 15 minutes time for each speaker, and the program is 45 minutes. So I suppose 12 plus 3 will be a good blend. If you can manage to finish in 12 minutes, then we can have 3 minutes of discussion, because there is no separate time left for discussion, and it's pretty late at night. So it's up to you, Dr. Rath, as you feel comfortable.
Good evening. Good evening. Thank you very much for introducing me, and thank you for inviting me to participate in the meeting. I think there is some post-disabled participant screen sharing. Can you just take your technical person to allow me to share my slides?
I have enabled, sir. Sorry, please go ahead.
Okay, the DAPA is being promoted as a wonder drug, magic drug, so to say. It was initially developed for as an anti-diabetic. Then it proves the efficacy for as an anti-failure drug. Now it is being promoted to prevent progression of the renal failure. So as you know, this is the global prevalence phenomena, very high incidence of CKD, 1 in 10 million people, and the number of people receiving renal replacement therapy is estimated to increase up to 5 million 2030. And all these causes, you know, majority are diabetic, others hypertension, glomerulonephritis, and others. If you see mortality in this, most of the disease has been limited, but in the CKD is less limited. The number of patients receiving renal replacement therapy all over the world is going up, and more patients are getting added. There are few drugs that has been tried as a therapeutic innovation to prevent the new onset or worsening of renal function. And number one is ACE inhibitor ramipril, that has proved can reduce the progression of the renal failure. ARB, yes, it can. But when you combine AC and ARB, it has been proved to be not so good. DRI, that is direct renin inhibitor drug, that is alisicate, that also has not proved to be efficacious. Glycosaminoglycan is like a it is also not very good. Anti-inflammatory drug, bardoxolone, that has proved to be not very good. As you know, the SGLT2 inhibitor operates in 3 levels. It blocks the proximal glucose and sodium reabsorption, increases sodium delivery to macula densa, and TGF leads to decrease in intraglomerular pressure and proteinuria. In these 3 mechanisms, it helps in preventing the renal dysfunction and helping the heart, reduce the heart failure and reduce the so this is the trial which I'm going to talk. Is called DAPA CKD trial. It's a landmark trial in assessing the dapagliflozin in over 4,000 patients with CKD with or without type 2 diabetes. This is a double-blind trial recently published in NEJM in October issue, and it has a one arm which is DAPA, where DAPA 10 mg was used with standard care, and the other arm where the placebo was used. Key inclusion criteria was patients more than 18 years. GFR is more than 25 and less than 75. VSCR is 200 to less than 5,000. And they are usually on the maximum dose of tolerated dose of ACE or ARB, with or without type 2 diabetes. And primary outcome was composite or sustained reduction in eGFR decline renal or cardiovascular death. Secondary outcome was composite or sustained reduction in eGFR, ESKD, or renal death. Composite of CV death or heart failure, all cause mortality. 2.5 duration was 2 hours, 2.4 years. Both groups were similar, almost, and diabetes, cardiovascular disease, heart failure, almost similar, both groups. But when compared, DAPA significantly slowed progression of kidney disease and reduced the risk of adverse outcome. And the RR was 39% and the NMT was 90. That means if you use this, 1 out of 19 patients, you can really protect the kidney. This benefit was consistent across all specified subgroups, patients with diabetes and patients with mild to moderate renal failure. The significant effect of this on this composite endpoint of cardiovascular death or hospitalization for heart failure was consistent with previous DAPA trial. And here the reduction in RR was around 29% and ERR was 1.8%. DAPA demonstrated significant marked reduction in death from any cause. Here again, the reduction was, relative risk reduction was around 31%. And almost 31% relative risk reduction. It was a well-tolerated drug and consistent with the established safety profile in all these groups, diabetes and without diabetes. And most important thing was when it was used in patients who didn't have diabetes, they didn't have any hypoglycemia episode. So when I summarizing this trial, it's called the first statement with this is we had 4,304 patients, 32%, 68% with diabetes, 32% didn't have diabetes, and almost half DAPA was given, a placebo was used. And if you look at relative risk reduction, it was reduced in 39% all total. In diabetic patient, it was reduced in 36% and without diabetic 50%. If we look at the patient's renal outcome, there is 44% risk reduction in the renal failure patients, 29% reduction in heart failure patients, and altogether 31% risk reduction. So this trial was stopped early due to overall efficacy, results consistent in patients with or without type 2 diabetes. First renal outcome study to show robust benefit in all cause mortality. Heart failure, cardiovascular benefit in CKD patients that is consistent like DAPA heart failure trial. And also its declared trial demonstrate that ability to prevent the cardiorenal complication across the spectrum of diabetic kidney disease patients was well documented in this trial. Safety, again, this was a very well tolerated drug, keeping with its established safety profile. Adverse events rarely led to discontinuation of the treatment. Very few events of major hypoglycemia in DK patients. So in August 2019, FDA granted first track designation for the SGLT inhibitor DAPA for use in patients with or without diabetes who have chronic kidney disease to delay progression of renal failure and to prevent cardiovascular and renal death. First, let's go back. First track again is not a FDA approved. First track is a designation of a drug for expedited review to facilitate the development of drug that treat a serious or life-threatening condition and file an unmet medical need according to them. So this is even if it is not FDA approved, but it is given the permission to be used. And you know, there's other trial that is I want to share with you is a DECLARE trial, where it was conducted for patients with diabetes with diabetes only to see its efficacy. Patients were taken for this trial were patients more than 55 years with more than 2 risk factors, or patients who are less than 40 years with ischemic heart disease, peripheral heart disease, or cerebrovascular disease. Here, again, DAPA reduced. The relative risk reduction was around 17%, and for death or hospitalization or heart failure. Again, in this trial, it was demonstrated that the significant 47% reduction in occurrence of renal specific composite outcome, 47% risk reduction in DECLARE trial, it was so. Next. So these two trials, DECLARE and DAPA-CKD, are two different. DECLARE shows that it prevents development of renal dysfunction, and DAPA-CKD shows that it prevents deterioration of the pre-existing renal failure. So if you look at renal progression, it's a 47% risk reduction in the DECLARE TB 58, 40%, 44% risk reduction in DAPA-CKD trial. Cardiovascular death and heart failure, again, 17% reduction in DECLARE trial and 29% risk reduction in DAPA-CKD trial. So DAPA also significantly reduced the risk of cardiovascular death or worsening heart failure in patients with heart failure where ejection fraction was less than 40% with or without type 2 diabetes, and risk reduction here was again 26%. So if you compare all these three trials, DECLARE, DAPA heart failure, DAPA-CKD, all primary endpoint, heart failure, cardiovascular death was significantly reduced in DECLARE trial. In DAPA heart failure, cardiovascular death or worsening heart failure was significantly reduced. And in DAPA-CKD, your renal deterioration and cardiovascular death again was significant. In summary, the global prevalence of burden of CKD is substantial, driven by diverse etiology including diabetes, hypertension, glomerulonephritis. I have shown this in first slide. DAPA-CKD is a landmark trial of more than 4,000 CKD patients with or without type 2 diabetes mellitus. It addresses the significant gap of therapeutic innovation, demonstrating a significant reduction in the risk of kidney disease progression, end-stage kidney disease, cardiovascular and renal death, with a 39% risk reduction used DAPA. Cardiovascular death and hospitalization for heart failure, that is 29% reduction, risk reduction. And all-cause mortality is almost 31% risk reduction. DAPA-CKD builds on the evidence from both DECLARE and DAPA heart failure to further expand the cardiorenal benefit of dapagliflozin to patients with CKD. So basically, this again, this expands the use of DAPA from diabetes to heart failure now for preventing progression of renal diseases. Thank you for your attention.
Thank you, Dr. Roth. Now we know that dapagliflozin is given in diabetes with or without heart failure, with or without kidney failure. Dapagliflozin is given in heart failure with or without diabetes, with or without kidney failure. And now also dapagliflozin is given in kidney failure with or without diabetes, with or without heart failure. So it's a fantastic expanse of indication, but there is a paradox. When you are including patients in DAPA-CKD or say to say EMPA-REG trials or the EMPA heart failure trials also, the cutoff limit for eGFR is either 30 or 25. and you are treating for kidney failure patients only. So why should there be a lower limit of eGFR while you are indicating it for renal failure itself?
So this is just to include the patient on the trial. Basically, they didn't want to put they had to make a cutoff for the trial only, but this is not, I do not think it is, it will be subsequently, this primarily for the trial's sake, that this was the cutoff limit. Maybe to exclude the extreme end-stage renal failure so that to avoid that, but that was the limit, that was the idea. So the patient is
another panel member, any question, Dr. Deb and Dr. Manoranjan? Are you there, Manoranjan? So I want to ask one question, Dr. P.C. Rao. Suppose somebody, as Samitra was asking, suppose somebody is hypertensive, non-diabetic, no heart failure, creatinine 1.3, GFR is around 30-40. Would you start dapagliflozin in these group of patients to prevent progression of CKDs?
Yeah, that is key. It is now it is patient doesn't have diabetes, hypertension, or kidney failure. That's what you are telling, whether you are going to start it or not. I do not think there is enough evidence to start it. I don't think.
Dr. Datta,
so Dr. Hajra, you will.
Yes, Smita, go ahead.
Dr. Roth, that was a very, very interesting talk. And will you be kind enough to stay for the another half an hour so that we can have some discussion? Thank you, sir. So, Dr. Hajra, would you mind to introduce Shubhro Banerjee?
Shubhro is a great friend of ours and very elegant speaker, erudite knowledge, and I think Shubhro is one of the best orator like Soumitra Rai, and he will be speaking on DAPA-HF. Dapagliflozin is a new standard of care, and we have 4 foundational therapy of heart failure. And Dr. Shubhro, over to you, sir.
Thank you, Prakash. I think that's for your very kind introduction. I hope I am audible. I'm using a new laptop.
Go ahead.
Okay, great. So can I be allowed to share my screen, please? The host says it's still disabled.
So please share. It's
okay. Good. Yeah. Right. So I'm going to talk today on dapagliflozin and heart failure with reduced ejection fraction. Great. Yeah. So I'm a little bit indisposed today and may sound a bit off stream. Sorry. Okay. So we know that the foundational therapy in heart failure with reduced ejection fraction is 4 drugs in 3 pills, and that is we have beta blocker, we have the MRA, and then a RAS inhibitor, and with that maybe a sacubitril as well, which makes it an ARNI. So there's actually 4 drugs we can have in 3 pills. And we also know that the ESC guideline, which has been which last came out in 2016, has advocated initially ACE and beta blockers and have adopted a hierarchical approach. If the patient remains symptomatic, then we add MRA, and then if still symptomatic, we change over to ARNI or consider ivabradine, or maybe consider him for device therapy like CRT, and if resistant symptoms, then there are other measures. Now then, at this point of time, we have the advent of the SGLT2 inhibitors. Now the question is, with this, and as the recent trials have shown, is there a need to change the guidelines? Now, the 2019 ESC guidelines have recommended use of SGLT2 inhibitors, empagliflozin, canagliflozin, and dapagliflozin, and recently the 2020 artegliflozin in patients with diabetes and either established cardiovascular disease or at high risk of cardiovascular disease to reduce the risk of heart failure hospitalization. Now, if And as the studies have shown, that SGLT, the cardiovascular outcome trials, have shown that that SGLT2 inhibitors prevent the development of heart failure in type 2 diabetes. Then, of course, the other questions that would arise in this case is, can they be used to treat patients with established heart failure? Or can they be used to treat patients with heart failure but without diabetes? Now, the first study to try to answer this question is DAPA heart failure study, which enrolled more than 4,700 patients across 20 countries, and those who are in NYHA class 2 to 4 symptomatic, ejection fraction 40% or less, and have elevated NT-proBNP, and they were randomized to either dapagliflozin 10 milligram once a day or placebo. India participated in that study and had a sizable number of patients. Now, if you look at the baseline characteristics, NYHA class 2 was most common with about 68% to 67% in both the groups, and the mean ejection fraction was about 31%, and the mean eGFR was 66, and about 40% were diabetic. And they were on optimal medical treatment and also on device treatment as evident from here. Now, the primary outcome was a composite of worsening heart failure or cardiovascular death. And worsening heart failure was defined as either hospitalization for heart failure or an urgent visit resulting in intravenous therapy for heart failure. Now, the primary composite outcome was significantly lowered with dapagliflozin compared to placebo. And if you look at the components of the primary outcome, that is worsening of heart failure and cardiovascular death, both were significantly reduced with dapagliflozin compared to placebo. And there was a host of secondary outcomes. And if you look at them, for example, cardiovascular death or heart failure hospitalization, total hospitalization and cardiovascular death, and all-cause death, all were significantly lowered with the dapagliflozin compared to placebo. And if you look at the quality of life index, where Kansas City Cardiomyopathy Questionnaire was used, you would see that there was a significant improvement in symptom score with dapagliflozin compared to placebo. And the renal safety has already been discussed by Dr. Roth. And I would like to say that the renal serious adverse effects and also any serious acute kidney injury were significantly less with dapagliflozin compared to placebo. And the same holds true for doubling of serum creatinine. Now, it has been seen that dapagliflozin, the way it reduces cardiovascular death is not only by reducing worsening heart failure, but also by reducing sudden cardiac arrest. And if you look at these patients, as per their hemoglobin A1C status and their diabetic status, then the primary endpoint was similar for those patients who are diabetic or non-diabetic. Also, it was irrespective of their hemoglobin A1C levels. Now, let's have a quick look at the subgroups, that is, two subgroups with and without diabetes. The primary composite endpoint was similar in both diabetics and non-diabetics. Similarly, the individual endpoints like cardiovascular death, worsening heart failure, all-cause death were similar, similar with dapagliflozin compared to placebo, and didn't really matter whether they were diabetics or non-diabetic. And the same holds true for the quality of life index and for worsening of renal function. Now, if you look at the pre-specified subgroups in with regard to the primary endpoint, then you find that in all the subgroups, dapagliflozin was shown to be superior to placebo. And even if you look at the background heart failure therapy, then you would see that in whatever the therapy was, dapagliflozin was better than placebo, and not only for the drug therapy, but it was also true for device therapy. And this is just to emphasize, because ARNI is something which has been recently comparatively recently in use. So also the effect of dapagliflozin was independent on whether the patient was on ARNI or not. And if you look at the baseline ejection fraction, then again, interestingly, dapagliflozin was better than placebo, irrespective of the ejection fraction, provided, of course, the ejection fraction was less than 40%. And the same holds true for age. It was better than placebo at all age groups. And if you look at the EGFR, then it also was effective in all EGFR, provided we had that's within the normal, but with the range that was allowed in the trial. Now coming to the safety, the ones that we usually associate with the SGLT2 inhibitors, such as volume depletion, renal adverse effects, fracture, amputation, major hypoglycemia, diabetic ketoacidosis, none were found to be significantly more with dapagliflozin compared to placebo. And similarly, the adverse effects leading to drug discontinuation was similar in both the groups. And the urinary tract infection was not much different between the two groups. And regarding the genital infection, although genital infection was actually a bit more with dapagliflozin, but serious genital infections or genital infections leading to drug discontinuation, serious genital infection was more with dapagliflozin compared to placebo. And but still, if you and of course, genital infection leading to discontinuation of the drug was numerically more with dapagliflozin. But again, it's very difficult to come to a statistical conclusion with regarding this, because the number in the trial was more than 2,000 and only 7 patients had to discontinue. Now coming to the others, apprehend that the side effects that we are apprehensive of, for example, major hypoglycemia, diabetic ketoacidosis, foreigner gangrene, none was actually significantly more with dapagliflozin, and although few cases were reported with this complications, but all of them actually happened in the diabetic subgroup and not in those without diabetes. Now, if you look at the recent trials with heart failure with the reduced ejection fraction, and especially by that I mean the Paradigm Heart Failure study, which have also shown a substantial benefit with ARNI in case of heart failure with a reduced ejection fraction, you would note that the results of DAPA heart failure study is quite comparable with the Paradigm heart failure study. As you see, the cardiovascular death of heart failure hospitalization, combined or individually, and all-cause death were more or less similar in the two studies, though we cannot actually compare them that way because they are all different populations and are different study protocol, but still the results looked similar. Now, the Canadian Cardiovascular Society in 2019 have given approval for use of dapagliflozin for patients with heart failure with reduced ejection fraction less than or equal to 40% with or without diabetes. And this year in May, FDA approved the use of dapagliflozin for patients with heart failure with the reduced ejection fraction to reduce the risk of cardiovascular death and heart failure hospitalization. And in July this year, DCGI has also given approval for use of dapagliflozin for patients with heart failure in our country. So to summarize, dapagliflozin reduced the risk of worsening heart failure, cardiovascular death, and improved symptoms in patients with heart failure with reduced ejection fraction when added to standard therapy. The relative and absolute risk reduction in death and hospitalization was substantial and consistent across important subgroups, and irrespective of whether the patient had diabetes or not. Dapagliflozin was also well tolerated, and the rate of this treatment discontinuation was low. So dapagliflozin offers a new approach to the treatment of heart failure with the reduced ejection fraction. Now, so as I've said before, we have now 4 pillars for management of heart failure with the reduced ejection fraction, which fits the guidelines. But now with the advent of and with the enormous data that we are having for SGLT2 inhibitors in management of patients with heart failure with reduced ejection fraction, we should be talking about 5 pillars instead of 4. Thank you very much.
Thank you, Subro. Very elegant, very precise. And may I invite a comment from my fellow chairpersons, Dr. Mondal, if you're not there. I want to start with one question to you. If you have DAPA in your prescription, when they have CKD with GFR of 20 ml, ejection fraction of 20%, hardly any glomerulus left. Forget about afferent efferent mechanism. Hardly tubulo-glomerular feedback is left. Hardly any macular densa left. Hardly any myocyte. So where from this benefit is coming? When you do not have, it's basically kidney drug, but hardly kidney left in 20 GFR.
Sorry, are you asking me about the benefit in heart failure or benefit in kidney? The mechanism of heart failure.
Heart failure in CKD patients with 25% ejection fractions or 20% ejection fraction with 20 GFR.
Yeah, well, I think the mechanism of its benefit in heart failure may not be the same as that in kidney. We really do not know. There may be considerable inhomogeneity in the target organ response of to this drug. So there are, to be honest, we do not think we know the answer yet, what is the mechanism of action, but there are several mechanisms which have been postulated. If you leave aside the metabolic effects, which may or may not help, for example, which are actually dependent on kidneys, but there are also other hemodynamic effects, for example, reduction in interstitial volume. Also, there are other mechanisms, for example, it inhibits the sodium hydrogen exchanger. So these things also may be effective. And we also know that there is a theory about the metabolic shift, where it promotes more of more of glucose oxidation than fatty acid oxidation. Or even we know there is a postulated mechanism which they can act by activation of sirtuin-1 receptors, which make the cells feel as if they are starving, and they actually promote the
autophagy.
Positive mechanisms, yes. They promote autophagy. They would reduce the pro-inflammatory effects, and that could also be beneficial. But I think the honest answer is we still do not know how they act, but the fact remains it still acts.
It acts. Dr. Roth wants to make a comment here. Dr. P.C. Roth, yeah.
Yeah. Can you hear me?
Yes.
Yes.
When the patient in stage renal failure, the question is how it will work in end-stage renal failure. That's the question.
Yes.
In fact, the trial is all those trials, eGFR when it's more than 25. That's the trial. It's a cutoff limit. So we really do not know. But if there is some glomerular function left, there is some elimination, so probably it can work. But we do not know. But the trial, that the DAPA-CKD trial, is for patients which is eGFR is more than 20.
Dr. Rai?
Yes, I think, as I always say, it's nice to know how the food is made, but it's not necessary. As long as it tastes nice and is healthy. So as long as it works, we are not much bothered as clinicians how it works. So that I always believe. It's nice to know if we know, but don't go deeper into that. I have got one objection into the whole, Subodh Varma's whole thing also, that there are 4 pillars, now there are 5 pillars. I think it should be, there are 3 pillars, now it is 4 pillars. I should not think ACE inhibitor, ARB and ARNI should be classed as different molecules. They are together because they are mutually exclusive. You cannot co-prescribe them. So they should be one pillar, MRA, beta blocker, and now it is SGLT2. So we should change, because we show this slide everywhere. So I think
No,
myself
the
this
fifth
slide
is
should,
ivabradine.
huh?
It is ivabradine. Fifth is ivabradine.
Maybe, but how this slide is so popular a slide, and I myself have shown it several times, but I have got objection about this slide.
Shobitra, one comment. Yes, I think you are well. You are going with McMurray, because what he says is what I said initially. It's the 4 drugs in 3 pills. So
yes.
So that's the way he puts it, which I think which is probably is more appropriate than the way putting it on the pillars.
Yeah.
And
Great
one
people
comment.
look alike.
Sorry, can I just?
All great people think alike.
Make a comment,
Yeah.
please.
Yes,
Yeah,
yes.
just
May I
I
make a
was-
comment, please?
Just let him finish. Yeah.
May I make a comment?
Yes, Dr. Always, you have got the privilege to comment.
Yeah, it is as Dr. Banerjee rightly pointed out, there are so many mechanisms, but one thing stands out, that it neither reduces infarction, nor reduces stroke, nor reduces any other ischemic events. The maximum benefit is because of its relief from the heart failure. So there is no denying the fact that it works like a diuretic. But unlike the normal diuretics, which increases the renal system, which stimulates the RAS system and causes further deterioration of the kidney function, it's by a mechanism what is known as unique tubuloglomerular feedback mechanism. It reduces the renal angiotensin system. At the same time, it is increasing the diuresis. This is a unique phenomenon. And second, it is a profound anti-inflammatory effect, which has not been mentioned, and we don't know to what extent it works. And this profound anti-inflammatory effect is something new which diuretics don't have. But there is no denying the fact the maximum benefit is all related to heart failure related reduction of hospitalizations and complications.
Right. Last word from Subro, then he introduce
No,
the next speaker.
I'll ask Dr. Dev. I'll ask Dr. Dev. Are you convinced to start dapagliflozin in non-diabetic heart failure patients? Dr. Dev, are you with us?
Dr. P.K. Dev is there.
Dr. P.K. Dev? Okay, perhaps he's offline. So, yes, I think we have got enough of SGLT2 inhibitor, and we are going into another very important discussing molecule, that is ticagrelor. And Dr. Anjan Dutt is particularly fascinated about this molecule, as we knew from the last session as well. And of course, Dr. Roth, being in one of the most prolific interventionists, deals mostly with ticagrelor. So let's see first from Dr. Aftab Khan. He is a very, very academic and prolific interventional cardiologist. What he is thinking about ticagrelor past, present, and future, and then we can discuss. Dr. Aftab Khan, please.
Yeah, thank you, sir, for this kind introduction. So I'll just share my screen. I think they've made me the host now. So it is definitely an honor that we have the august gathering here. And as you said, Dr. Rath, and of course, all of you in the panel are all both clinicians as well as interventional cardiologists. So my job is to just put forward the data that we have right now. And I think we can all have a discussion about how we look ahead in this field. So just a small look back in the past, and then I think we look at how the future looks at with monotherapy. And as Dr. Ray already said, we've already had the last session where we had some discussion on this. So I think this is something that we all know. The role of the platelets in acute coronary syndrome in myocardial infarction is all well known. And DAPT has been a standard of care universally since a long period of time. We have these guidelines which have talked about DAPT use, and these have also put us in a patient with a stable coronary artery disease. Usually a 6 months DAPT, especially after a drug-eluting stent, is something that is recommended. Whereas if you have an acute coronary syndrome or STMI or non-STEMI, then usually what we do is a prolonged or an extended DAPT. And we have these various trials, of course, that we know of. Of course, we also know that this 1 year is an arbitrary figure, and based on your risk-benefit ratio of bleed vis-a-vis an ischemic event, you could either reduce it to 6 months if you feel that there is an increased bleeding event, or you could prolong it more than 1 year. And this is what the guidelines have left it at. Aspirin, a short word about aspirin. Well, we all know from our data of aspirin right from the cure days, aspirin in all dosages is beneficial. But what we also need to understand is that the incidence of bleed is greater when you use the higher doses of aspirin. So a dose of less than 100 milligrams is something that is often recommended in all the guidelines. Though we don't have 81 milligrams, 75 milligrams is available, and 75 to 100 milligrams is something that is consistent with good efficacy with minimal bleeding risks. And of course, we have these P2Y12 inhibitors. This is an old slide. We all have been knowing about this. Clopidogrel, with its little, though it's a good drug, it's helped us for a long period of time. Certain drawbacks, it's a pro-drug, takes time to act. And of course, resistance is something that we often realize only after patient comes back with an event. We have these other two new molecules, new in the sense that, well, it's newer as compared to clopidogrel. Ticagrelor is something that's breaking the market now because of its data. And of course, the fact that it's easy to acts fast, it's reversible, and of course is effective. And of course, we had a little noise that was made by the prasugrel also. Again, it's a good drug. What it has shown us that we have another option available. So let's not talk about superiority and inferiority, but we now know that we have these three molecules that have that are with us right now. Ticagrelor, I already mentioned, it's not a prodrug, it's a direct acting drug, acts fast, and it is reversible. And the Plateau trial had shown us that as compared to clopidogrel, it had risk reduction. It is significantly better in terms of cumulative incidence. The guidelines, again, in terms of the non-STEMI guidelines of 2014 and the recent guidelines of non-STEMI in 2020 have all talked about the fact that we need to continue the antiplatelets, and especially the dual antiplatelet up to a period of 12 months in patients with ACS, especially whether you're doing an invasive or an ischemia-guided strategy. And it is reasonable to use ticagrelor or clopidogrel, but of course, prasugrel is also to be used. But again, prasugrel is only for patients who have had an intervention, and you don't use it for patients who have a high risk of stroke or bleed. Ticagrelor also has been preferred over clopidogrel. This is the duration that we all know about. In stable coronary artery disease, 6 months is the guideline. You could, with a DAS, with a BMS, you could stop it at 3 months and then move on to a single antiplatelets. But again, as I said, a class 2B indication is either reducing it when you have a risk of a bleed or prolonging it when you think that you have a thrombotic event that's going to be higher. Whereas in an ACS, the cutoff is usually a 1 year period of time, with the guidelines again classifying us to go down to 6 months or to go higher than 1 year based on the clinical assessment done by the cardiologist. The ESC guidelines again talked about the same thing. And as I said, high risk bleeding risk, stable heart disease 3 months or 6 months, complex PCI, you could go more than 6 months or more than 1 year in a patient with ACS. So again, it all comes back to finding that sweet spot where you balance out the risk of thrombosis with a risk of bleeding. And this is something sometimes very difficult because the bleeding risks and the thrombotic risks, the risk factors sometimes all overlap. So advanced stage could be there, a risk factor of both thrombosis as well as a risk factor of bleed, diabetes, CKD. So it's sometimes a difficult proposition to find out whether the patient is at risk of thrombosis or bleeding. And we had these various scores that were devised, but these were scores that were based more to find out the bleeding risk. So the DAPT score, for example, looked at a score when you had a patient who was elderly or a patient age that is there. So you had a negative point. So a DAPT which was lesser was a patient who had a high risk of bleeding. So if you had a DAPT score more than 2, you would prefer to continue dual antiplatelet for a long period of time. Whereas if you had a DAPT score which was low, patient was more at a risk of bleed, and you would probably want to come down on the dose of antiplatelet or a shorter period of time. The only problem with these scoring systems was that sometimes they did not look at the anatomy or the sort of the work that you're doing in the cath lab. So what we find is that if you have a complex PCI, probably a short DAPT would not be good. You would have more events. For a non-complex PCI, a short DAPT versus a long DAPT would probably not make so much of a difference. And again, there was this precise DAPT score, which again looked at 5 points to look at a scoring system. A score of more than 25 would mean that you probably would err on the side of a small or a shorter DAPT if you had a non-complex lesion. Whereas if you had a complex lesion, you probably would still go with a longer period of DAPT. Let's see, the problem about all these scorings, again, as I said, they looked at more at the bleeding points rather than looking at the thrombotic events. And again, the advantage of these scores are there are now apps which are available online. You could get them on your mobile and you could use them once you do a procedure to decide where exactly you proceed. So again, we are now back to a bleeding or balancing act between bleeding versus thrombosis. So we have these questions of how long do you give a long duration DAPT? What exactly classifies as a short duration? Is it 6 months? Is it 3 months? Is it 1 week? Is it just at the time of the procedure? And of course, as Dr. Anjan Lal was also saying earlier, should we sort of continue monotherapy? And this is a question that is still burning. 2019, we had these studies where we talked about short DAPT, where we give a DAPT for a short period of time, and we continue with aspirin monotherapy again, rather than stopping the P2Y12 inhibitor. So we had the evolved short DAPT study and the ONYX study, where we would give the combined or DAPT for 3 months, and then you would stop the P2Y12 and continue with aspirin. And again, the ONYX study again, where you stop the P2Y12 after a period of 1 month and continue the aspirin. But again, we also have new therapies where we realized with the other studies that probably it was not the P2Y12, but the aspirin that was the culprit in causing the bleeds. And now we had monotherapies with aspirin. And we had these other trials, the STOP DAPT trial, where you stop the aspirin after 1 month and continued either clopidogrel alone. And this showed that monotherapy was superior in terms of bleed, but of course, without compromising the ischemic endpoints. So by reducing the aspirin, we did not lose out in the benefits of aspirin in terms of thrombotic endpoints, but we had a benefit in terms of the bleeding endpoints. Similarly, the SMART choice again looked at
Hello.
Yeah, we looked at again clopidogrel and aspirin.
Right.
And again, here again, this was 77% were clopidogrel, but we also had ticagrelor in this group. Again, P2Y12 monotherapy was superior in terms of bleeding, again, without a non-inferiority in terms of death, myocardial infarction, and stroke. So this put us on a very sort of an encouraging pathway. And we had this large trial, the Globus Retail trial, and everyone thought that, well, this would be a trial that would break give us a good answer. And this was a large trial and a well-designed trial, though it was an open label trial, and it was a superiority trial. But what it showed is that when you compared aspirin monotherapy, that you gave aspirin for with ticagrelor for a period of 1 month, and then you continued only ticagrelor for a period of 2 years, or you continued as the standard therapy DAPT for a period of 1 year, and then aspirin alone in the long term. But this trial was a negative trial when you looked at with statistically significant. So death, myocardial infarction, bleeding risks, there were no major differences. So this was a trial which was touted to be a major landmark trial. But again, when you did a subgroup analysis was done or a post hoc analysis was done, what was a negative trial was we looked at, and this was by Patrick Serra, the lead investigator. And he says that when you looked at the trial again, the most complex patients, in fact, did much better with the clopidogrel alone arm rather than the DAPT with aspirin, and a significant lower risk of death and non-fatal MI was seen in the most complex group, whereas the non-complex group did not have this benefit. So the post hoc analysis tended to favor a complex PCI with ticagrelor monotherapy. Again, the trends were more that if you had stopped this the arm earlier, so if this was just a 1-year study, probably the monotherapy would have been better than the aspirin and DAPT, the DAPT arm, because the second arm in the second year of treatment, there was a dropout rate in terms of ticagrelor monotherapy. So there were 78% who continued the monotherapy, whereas 93% in the arm with aspirin continued aspirin alone. So there was a difference in terms in the second therapy, and therefore this lack of adherence to the experimental strategy may have compromised the superiority of the assessment of this superiority of ticagrelor. But again, we looked at the data, and it has to be said that it was not a favorable study. So we then had the landmark AHS trial, which looked at the Twilight study. And again, this was a trial which again was looked at a huge population of patients. They looked at more severe sick patients, a high-risk PCI group, where you randomize them to a 3-month trial of open label aspirin and ticagrelor. And then it was a blinded study where you randomize them to either ticagrelor with aspirin or with a placebo, and then you followed them for a period of a year. And for another 6 months, another 3 months, they were in an observational period. So again, this was a high-risk arm again. So you had to have a positive ACS, or you had to have diabetic on insulin, or patients who had compromised LV dysfunction, compromised renal function. But also you had to have critical sort of a complex coronary anatomy also. And this is a trial which looked at a primary endpoint was to find out the bleeding risks, and a secondary endpoint was to look at ischemic events. Well, the BRC score, the 2, 3, and 5 were what were looked at. So anything that was actionable, so where we needed to treat the patient, give blood transfusions, or in fact, the patient had a fatal bleeding, these were what we were looking at. So this trial, what it has shown is that when you continued placebo versus aspirin, there was, in terms of the primary endpoint of bleeding, the BRC 2, 3, and 5, there was a significant reduction in the bleeding with the arm with ticagrelor alone, ticagrelor with placebo as compared to that with aspirin, and without causing without causing or losing out in terms of the ischemic endpoint. So when the secondary endpoint of ischemia was not worse when the placebo arm with ticagrelor was given rather than aspirin. So this was again a conclusion of this trial, which showed that high-risk patients who underwent PCI, if you treated them with a dual antiplatelet for 3 months, and then if you stopped the aspirin and continued with the monotherapy of ticagrelor alone, and this was 90 milligrams twice a day, there was a substantial less risk of bleed without compromising the ischemic events. We also had the diabetic arm and the complex PCI arm, which were presented at the ACC 2020. And there was the other study, the TICO study, which was a Korean study, which again looked at a similar subset of patients. But here what they did is that they used a single stent, or the bioabsorbable sirolimus stent, the Orsiro stent. And they also looked at the same thing, almost similar to your the Twilight era, the Twilight trial. And here what was found is that the net adverse cardiac events with monotherapy was much lesser. But again, most of these benefits of net events were mostly related to a lower bleeding that was seen with the ticagrelor monotherapy arm. So in the TICO arm, also the TICO trial also concluded the same thing as the Twilight, that after you give a monotherapy or a dual antiplatelet for a period of 3 months, you then, if can switch on to a ticagrelor monotherapy, you probably have a benefit which is related to mostly a reduced bleeding risk. And this could be the reason for an increased or a benefit in terms of net adverse cardiac events. A meta-analysis was something that we also understand and look at when we have these dual antiplatelet therapies, which was a monotherapy after PCI. And this was one trial which is in the American Journal of Cardiology by Malik et al. And this has looked at 4 major trials. So the global leaders, Twilight, Smart Choice, and Stop DAPT. And again, it has this has all the trials, the open label versus the double-blinded Twilight versus the others. And this basically has shown that when you looked at the pooled ratio for all outcomes, probably the monotherapy arm in terms of bleeding is much better, and also in terms of thrombosis. So in terms of hard endpoints or all outcomes, monotherapy is still better than a DAPT. When you look at major bleeds, again, naturally monotherapy would be better as compared to a dual antiplatelet therapy. And when it comes to trial-defined MACE, again, you had a favor more in favor of a P2Y12 monotherapy. So again, this was another the Donohue circulation paper, which again looked at another meta-analysis. And in addition to the American Journal of Cardiology paper, this also included the TICOS trial as compared to the last meta-analysis. And again, there were no major differences in terms of the endpoints. And we found the same results as was in the last meta-analysis. We looked at a huge patient population, stable coronary artery disease, as well as patients with ACS. This had mostly looked at ticagrelor. And again, you found is that the bleeding benefits were much in favor of P2Y12 alone, without a compromise in the MACE rate. So you do not worsen the MACE by a monotherapy, which you stopped after a period of 1 month to 3 months. Future monotherapy trials are in progress. Just a brief word about the patients with atrial fibrillation. And this is something that we all are aware of. These are from a special group of patients when we get these patients. And what exactly do you do? Dual antiplatelet along with anticoagulants. And we have these 4 trials with the different NOACs that we have available, along with the warfarin. And the guidelines are now going towards using a NOAC with a P2Y12 inhibitor and getting aspirin off as early as possible. So you try and get aspirin off. So this is something that we are all trying to find out the sweet spot to balance between the thrombotic and ischemic events. And well, we don't know the duration as yet, but this is what the guidelines would not talk about. So in an elective PCI, you could probably continue with a dual antiplatelet or a triple sort of drug therapy for a period of 1 month. And then you get off the aspirin as early as possible and continue with the NOAC and the P2Y12 inhibitor for a period of 6 months. Well, one could increase it or reduce it based on the thrombotic complexity of the intervention. But the intention is usually that after a period of 6 months, you continue with NOAC monotherapy alone. And with a patient with an ACS, when you're doing a PCI, well, what you could do is that if a patient has a higher risk of bleed, what you do is that you stop the aspirin as early as possible. And it could be as early as 1 to 7 days or even at discharge. And you discharge a patient with just the NOAC and the P2Y12 inhibitor. If the patient has a lower risk of bleed and a high thrombotic risk, you probably could continue the same, the triple therapy for a period of 3 months and then move on to a dual therapy and then monotherapy. So the guidelines are changing. Many of the discussion that we've had now about the newer studies the Twilight and the other studies which talked about monotherapy have not found their way into the guidelines as yet. And therefore, what we need to realize is that, ticagrelor has a benefit now as compared to the other drugs that we are using. But again, as I said, this is a discussion that we could all have. And I think all of us are lucky to have many of these stalwarts in the panel. And it will be nice to hear from them also how they have changed their practice based on the current data that we have. And thank you for being here so late in the evening also. Yeah.
Thank you, Aftab. That was very elegant presentations. And now if I start the discussion, look, when you do angioplasty and use a drug like antiplatelet, it's a serious act. And we have two types of things in the trial. One is looking for safety like bleeding, and another is death due to disease and device like stents. Do you think all these trials, they're doing justice to the endpoints like bleeding? They're not considering deaths due to bleeding. They're just considering bleeding. So do you think the future trials should be like deaths due to bleeding and deaths due to disease and the device, rather than just looking at the bleeding points?
Yeah, so that's a good question. I mean, I think unfortunately the trials have all been mostly designed to look at the primary endpoints, and most of these recent trials were to look at the bleeding risks. And they have classified as BRC 2, 3, and 5. Now, BRC 5 basically looks at death where you have bleeding which is suspected, for example, a retroperitoneal bleed at autopsy or something. I do agree that, well, most of the bleedings that we are looking at is the major bleeds, which are probably could be procedural as well as the antiplatelet related bleeds. But yes, we don't have clear answers to whether we can have a trial where we look at only the, not looking at the procedure related events and only looking at the antiplatelet related bleeds. So I don't know whether we'll ever have a trial like that. So, but that's a concern that definitely remains.
Thank you.
Dr. Khan, I have got one comment and one question. The comment is that these trials are very elegant, very fantastic trials coming one after another. But when you are seeing one particular patient in cath lab or your clinic, do you honestly remember whether your patient fulfills the inclusion and exclusion criteria of any particular trial? This is very, I with my IQ and with my wisdom, I could not unfathom it. They are so confusing. All the trials are elegant trials, but very rigid inclusion exclusion criteria. So when you are using it randomly, whether you are really doing justice to your patient or extrapolating the data, I am not sure. That's why in this murky area, I will still go by the most recent guideline, because the guideline has really picked their brain and their hair splitting analysis, and they come up. It may be 6 months, 1 year old. It may not be up to date, but I think still I can wait for a year or so to come for a new guideline. Till in this particular area, I'll go by the guideline. That is my comment. And my question is that all these ticagrelor trials are with Brilinta, or whatever name it is available in the world, in different countries. Do you think you will do justice by giving ticagrelor with a generic or biosimilar ticagrelor and expect the same results and extrapolate the data?
Yeah, so that's two wonderful sort of comments. So I'll take the second one first. So I think all of us have gone through this through this procedure where we have the generic and we have the research molecules. I think I would still put my bet on the research molecule, because we are not, let me be truthful, I'm not a sort of a biogenetic person to look at the bioavailability. And I'm basically guided by the person who comes and shows me his chart and talks about these bioavailability curves and all. So which is really confusing. And I really would not put my money on something that I'm not very comfortable with, because the last thing I want to see my patient come back is with a stroke or with a when it comes to any other drug. You see, I think when we are just talking broadly about any generic, and we know that we've been flooded with generics. So this is my looking at it. I think that each one of us practices in different areas, and each of us could have a different look at it. So I'm not being judgmental, but I think I look at it differently, and I probably would go with the research molecule rather than, because the trials have been done with research. And if I have to, of course, I would have a discussion with the patient. If he really is someone who's willing to take a chance and sort of look at it differently, that's fine with us. I think discussion with the patient would be something that would be helpful.
Subro.
Coming back to the first question, if I could just put in a small word there.
Yeah, go ahead.
Yeah, so the thing is that as you said very truthfully, that how do you look at these trials and then how do you judge your patients? So my take wouldn't be is that at the time of the acute procedure, I think we go by whatever we've been doing all these years. So it's not something that we make a choice about single antiplatelet, dual antiplatelet, triple at that period of time, and we treat accordingly. And it's only after a period of say 1 week, 10 days, 1 month that we make a choice based on your bleeding risks and then take a further decision. A given choice, we'd always want to push, especially with a patient who has a young patient with a low bleeding risk and a non-complex PCI. I think the decision is easy. But with a patient with a high bleeding risk and a complex PCI, I think that's where we need to sort of reassess our targets, probably 1 month down the line, 3 months down the line, and 6 months down the line, and then decide how long we would continue the drugs.
Right.
I mean, that is how we would look at it.
Yeah, thanks, Doctor. I think it was a wonderful presentation. I have one question in 2 parts. The first part is there any data comparing aspirin to ticagrelor after 3 months of DAPT treatment? And the second part is, if there is no such data, then what is the reason? Is it because aspirin is orphan now?
Yeah, so I think this was one of the concerns that many of the people who looked at the Twilight had, that when we had 2 arms, so where you had the placebo with aspirin, we had a DAPT and you had the ticagrelor with a placebo. People also thought that if you had aspirin with a placebo with that would have also given us one more answer. So truthfully, yes, after 3 months, we don't have much to say whether you have aspirin directly over ticagrelor to say whether we have a benefit in terms of a bleed when it comes to a DAPT. But again, that's how the trials have been designed, and I'm not certain whether we'll have a trial which will.
Arupda?
Yeah, thank you. I'll just make a couple of comments. One is we have to be patient specific rather than a specific protocol. Patient specific means patient profile, comorbidity profile, his coronary profile, and also nowadays stent profile. So these things are important. Another thing, newer things are being discovered regarding ticagrelor. This month only there have been 2 papers published regarding. One is there is endothelial dysfunction improvement with ticagrelor, as well as LV functional improvement also to some extent. And there is always a fight between prasugrel and ticagrelor in different subsets. But I'm not going to comment on this thing. But it was wonderful and nice to hear from Akshay.
Dr. Rath, any comments?
Dr. Soumitra, small 2 comments.
No, Dr. Rath, please, first.
Yeah.
You have to unmute yourself.
Firstly, in our country, people would, if asked to continue with antiplatelet for a long period of time, I'm afraid how many of them would be able to continue with ticagrelor or prasugrel because of the cost or financial constraint. On the other hand, people we have seen are continuing for a long period of time with aspirin. Secondly, in India, we are using enteric-coated aspirin. So the complications of GI bleed that has been highlighted so much in the other trials is not probably present in Indian patients with enteric-coated aspirin. And third point is that ticagrelor is rightly, as Dharu pointed out, not only endothelial dysfunction, it has been found to prevent left ventricular remodeling as well. The additional pleiotropic effect of ticagrelor. And lastly, when we say bleeding is risk factor for all comorbidity and mortality, we should remember that apart from the bleeding, usual complications, bleeding triggers secondary reactivity of the platelets. Bleeding triggers secondary procoagulative activity. So bleeding is harmful not only in the form of bleeding, but also harmful in the form of excessive thrombotic events. So we should be very much careful about bleeding, whatever drugs we're using.
Right. So if I come to Dr. Roth.
Just
let me phrase the question first, sir. So what is your minimum comfortable duration of antiplatelet in the setting of ACS? And second is, the bleeding is so important, why the deaths due to bleeding is not considered as a primary endpoint other than just bleeding in the trials? Then your comment, any message, last message to the audience. Dr. Roth, please. Dr. Roth.
Hello. Yeah,
Yes.
yeah. Tell me. You want
What is the minimum comfortable duration of antiplatelet in your practice in 2020? And what do you think that just why, if the bleeding is so important as Dr. Anjanal Dutt was mentioning, why not deaths due to bleeding is considered as a primary endpoint in the trials rather than just bleeding? And any other comments here?
Two things.
Yeah.
Comfortable dual antiplatelet. I think that is what you mean.
Yes.
I think it's 3 months for me. Second thing is, why not? In all trials have two things: minor bleeding, major bleeding. So if you look at analyze the bleeding, just not the bleeding numbers, you have to analyze how many are serious bleeding, intracranial serious bleeding. So that is the truth. That is the proof of it.
Right.
These are questions on the way. I just wanted, because the discussion is going on, I just wanted to give example. In spite of all the trials, recommendation, you have to have a patient specific about this. I just had an angio today for a patient, 60-year-old man, whom I had 10 stents has been put. Out of that 6 I have put during last 10 years, 4 have been put in USA. Every time he comes with a unstable angina, we open, stent is okay, there is no lesion. But the beauty is, this all the, after 10 stents, after 10 years, all the epicardial vessels are fine. Small branch vessels have some narrowing. But the problem is, this fellow doesn't tolerate most of the antiplatelet. Aspirin, when you start it, you will start after 10 days, you will start bleeding from the skin. Clopidogrel, he was tolerant, but clopidogrel also we didn't, because we are using so many stents, I couldn't live with clopidogrel. Ticagrelor, again severe bleeding. He couldn't, after 15 days, he stopped it. So ultimately, only drug he tolerates is prasugrel. Now, for last 4 years, he's only on prasugrel, and he doesn't tolerate any statin drugs. With prasugrel, he's going on. His stents, he has 10 stents. His epicardial vessels are perfect. But you know, as I told you, that you have to be patient specific sometimes. And the question is, how long you will give this prasugrel? He doesn't tolerate any of the antiplatelet drugs. Probably we have to wait till another new drug comes in.
Is he a German patient?
He's a Hyderabadi patient.
Okay.
So 6 times I have put stent here. Every time he's come, 4 times he has been put in USA.
Dr. Hajra would put him on PCSK9 inhibitors.
Yeah, that's what we have decided to start it for this time. PCSK9, because his epicardial vessels are perfect. He has prolonged angina, but he has disease in the PLV and OM1. We're not going to do.
It's precision medicines. Like some people are responsive to prasugrel, and most of the data is from Germany, German Heart Center, this ICER group, and even ICER React is one country where prasugrel is used in almost 100% of PCS. Where ticagrelor is not there. Barring Germany,
prasugrel hardly we use nowadays, but this is one patient only tolerant to prasugrel, and this arteries are good.
Dr. Rai, the night is approaching. Please conclude and last word from your side, sir.
So I think all the 3 speakers will agree they have done fantastic justice to their subjects. And if you ask the 3 molecules to discuss in 2020 in cardiology, I think 2 are SGLT2 inhibitor and ticagrelor. So these are so important nowadays, and we discuss them extensively, and the spans and horizons are expanding anyway. I think we have got a very fruitful session with good interaction, and I profusely thank all of them, particularly our guest speaker, Dr. Roth, as well as our friends, Dr. Banerjee and Dr. Khan, with my co-chairman, Dr. Prakash Hajra, and the senior people presenting with us, like Dr. Datto, Dr. Dash Vishwas, Dr. P.K. Dev, all of you. Dr. Jayanta Sharma is still here. So I thank all of you today and conclude the session, and I think it also concludes the day 1 of Cardiology Update 2020 on Cardiological Society of India of West Bengal. Thank you and good night. See you tomorrow. See you tomorrow, all of you. Thank you.
Thank you very much. Thank you all.
Almost Andhra left.